César, ya tienes... Hola, hola, ya. La presentación de el doctor Jaime, ¿verdad?
El doctor Jaime ya.
Súper.
Sí.
Va.
Sí, perdón, sí la teníamos, ya estaba. Ajá.
Pero la cambió en la mañana.
¿La cambió esta mañana?
Sí.
Ya ahorita vino y ya la revisó, de hecho.
Ah, perfecto. Ah, mira, ya va llegando. Muy bien.
Hola, hola.
Hola, hola, hola. 1, 2, 1, 2, 3. Hola. Apagado. Hola, hola, hola. Hola, 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 hola. Hola. Ah, perfecto. Sí. Ah, sí. Sí. Sí, no está muy... tal? Muy buenos días.
Hi, good morning. On behalf of the President of the Conference for Social Security, Mr. Soerbredo Aburto, who is also the General Director of the IMSS, and Alvaro Verar Canandez, who is the General Director, Secretary General of this conference. And on behalf of myself and my colleagues, we welcome you to the second day of activities related to our second Congress on HIV, done along with the IMSS and the Inter-American Conference of Social Security. In order to start the activities, we are going to start now talking about a topic which is of the utmost importance and is becoming more relevant as we are making progress in the combat against the HIV and AIDS, such as the implementation of digital technology to improve the access to services for preventing the HIV. Favoring the self-detection to reach that first 95%, which is so hard to get and reach. So in order to do that, we are going to have the participation of a colleague who visits us from United Kingdom, who is Mr. Jaime Vera, who is a teacher from the HIV in the Faculty of Medicine in Brighton and Sussex. He got his degree in the Colombian School of Medicine. Then he studied internal medicine in London. In 2018, he got a scholarship from the National Investigation Center in HIV in the Hospital of St. Mary in the Imperial College in London as well, where afterwards he completed his formation in HIV and medicine of genitourinary. During his work, he investigated the pathogenic agents associated to neuroinflammation in HIV using different perspectives and scans. He is also part of the University of Sussex, clinical leader of combined clinics in neurology, memory, and he's also a researcher of the Royal Sussex and leader in the investigation of the Department in Health and Global Infections. We are very happy to have him here. So please give him a round of applause. Good morning, everybody. I'm very thankful for the organizers for having me here. Actually, sharing the experience of implementing the digital technologies to improve the access and tools to detect HIV. I want to start and try to remind you of all the advances for preventions and this kind of advances in the last 4 years. They are very important because all these tools are absolutely key for getting the elimination of the transmission of HIV, especially the treatment as prevention and the introduction of, as we all know, as PrEP. That's very important. As a result of it, at a global level, we are seeing the impact of these strategies for preventing and management of the HIV with a reduction of around 38% since 2010 in the rate of new infections. This is actually very positive and makes us think that it is possible to reach to this point of elimination of the transmission of HIV. When we see at a global level the different goals of the 95, 95, 95, we see that there is still a lot of work to do, especially the first 95, which is about being sure that all the people know their status of HIV. There's a lot of work to do in this regard. And there's a lot of variation in the whole world in terms of who gets this kind of goals. And when we see Latin America or South America in general, we notice that the situation sometimes is not that positive. There has been an increase of around 8% in terms of new infection since 2010. And when we see specifically Mexico, we see that the trend is to a greater number of infections. So now we need to be super careful with these numbers that we find in UniAIDS because it all depends on the kind of epidemiology that they have in order to do these calculations. But the suggestion here is that in a global way, there's a lot of variation and a lot of work to do yet. And it's important to know this because this means that we can do a lot of work yet. One of the real problems or the reason why the patients or the users or the people who are in risk don't access to preventing tools is because of the obstacles in the services. And you could define these obstacles as in different ways. They are usually structural obstacles because the health system won't allow the patients to access these kind of services easily. There are social obstacles and cultural obstacles as well, associated specifically to the stigma, is not only to the with regards not only to the sexual disease, but also to the access. There are individual factors and there are factors that have to do with the places where they can receive the attention, even the distance that patients have to undergo to access these kind of services. That's important. All these factors and all these obstacles allow that some or prevent the access of some patients to some services. It's important to understand these obstacles too. Even in the context of every country, there are different regions with different factors or different structural obstacles, and it's important to know them in order to apply the right interventions. Finally, we have the tools and we know what to do. We have to do many more HIV tests, identify those patients who don't know their HIV status, and place them in a treatment, because we know if they are in a treatment, we will be able to prevent the transmission. And this also includes providing the PrEP to those patients that are in risk of getting the AIDS. But all these obstacles need to be taught in a different way. We need to go out of the clinic because we cannot wait for the patients to come to us asking for the test. We need to go out and find some other options in order for these patients or these users can access these services. And there's a lot of information about the test of HIV. And it's very important with HIV test to understand that there are many advantages. This is just a couple of examples for a HIV test. We have the oral HIV test, and there are also tests that can be done with a pinch on the finger. You don't need to talk to anybody. The users can do it on their own, which it's necessary to consider that the type of test is second and third generation types. They are not fourth generation, and the specificity varies, but in general, it's around 95%. And obviously, it requires that the user takes the samples and contact the service of health in order to have confirming results and for further treatment. We are giving the power to the individuals for them to have the control of running the test and link to the services. So it is very important to provide the information that is necessary for this to happen. That is key. So if we see the evidence in terms of access compared to the standards and services in health, I would say that the evidence is quite clear. The HIV test compared to getting tests in the attention center are much better in terms of access. And one of the advantages of self-tests is that they are very flexible. This is a meta-analysis of 14 randomized studies where we use self-test compared to those that are gotten in the attention center. And by doing this self-test, there was an increase of twice the number of tests that were run. But as I said, the most important here is flexibility. For example, in some kind of intervention, women took the self-test and gave them to their husbands at home. So this is easier. It's a different way to do it. Sometimes the tests were acquired in places different to a clinical center, like a drugstore. That's why they are easy. When should we ask the individuals or the user what they think about this kind of intervention? They also say that that is acceptable. There are no concerns that people will run a test during Friday night and then they will feel very sad and commit suicide or something like that. This hasn't happened actually, considering that the information is given for giving the link and the help with a reactive test. But even more importantly, there's a difference in terms of the link to the services, because one of the main concerns is that we give the power to the person to self-test. They self-test, but they will never reach the hospital. So this meta-analysis says that there is no difference in the link with the to the hospital, and it doesn't matter if you do it at home or if you don't do it at home. So this is a very clear evidence that justify the use of self-test to increase the access to the services of HIV and the test of HIV. But there are some other ways to do it. There are some other interventions that are there to improve that access. One of those are self-tests at home, not only for HIV, but also for other kind of diseases sexually transmitted. What you see here is an example of one of the interventions that we have in United Kingdom, where people can get these packages. They have different instruments for them themselves to... This looks like a ghost, I'm sorry. And to run the test themselves at home. So they do the syphilis, gonorrhea, chlamydia, and HIV, and some others if they are available. It also requires that the user takes the samples, and this user should put the samples in a package, send them through the postal service to a lab, so that the lab can do the processing of the samples. And it also requires that the individual access to the services in case the result is positive. So as we see here, the way or the pathway that the patients need to follow is like this. They get to the lab where they run the necessary tests. The lab communicates to the health authority, and the health authority sexual clinic, or where they handle this kind of diseases, they contact the patients for the treatment or to give them the results. This process lasts around 1 week. Another and different way to break those obstacles, because people don't need to go to the hospital. They can acquire the test in different places. So there are also some obstacles. Even with these interventions, there are some obstacles yet, because we know that many people don't want to go to the conventional services because of the stigma, time, convenience, and all those reasons. We know that these kind of self-tests and home tests have the power to improve the access. However, it depends on how we are going to distribute these kind of packages and these tests, because the locations where they can be acquired in many different places is limited, and for some users it's hard to do it. They don't want the packages to get home because it's because you don't want your mom to see that this package is coming to you. Why are you running some tests on sexually transmitted disease? Some people don't want to use their credit cards because they think that they will somehow be spotted. So there are limitations for these kind of interventions or this kind of opportunities. So I'm going to show you an example of the flexibility that actually we should provide in order to allow people to have access to this kind of prevention services. We have different clinics. This one is in Brighton. This is the management standard. If you want to have a test for HIV or STDs or access PrEP, you need to go to the hospital, to the clinic. You can set an appointment, and then you will be held by health staff. But there might be other options, and we will try to talk about these other options, the options that you can see in the cities, and you don't even need to go out of your home with just a computer or your cell phone. You can request one of these packages. I already explained the process a little bit and how it works. You can also do it with your cell phone, with your smartphone, and do it like in an Amazon way. You are just going to order it, and I will pick it in a very nearby place in a drugstore that allows me to do it. Or if I am in the university, and if there's a vending machine or a dispensing machine, I can go there and get one of these packages and do what I need to do and connect with the health service, with a hospital, or I can go to one of the organizations of the community that work very close along with the hospitals, and that way the patients don't feel so stigmatized, and they can get this type of services. Now we see the options that the patients have. Let's talk about the access. These are different examples of some services provided in the United Kingdom. As you can see, it's a website, just as if you were requesting any other kind of thing. And there's this opportunity for the patients to get, depending on their level of risk and depending who they are, and the kind of package they need. So this is not quite clear, but if you notice, there are different 4 packages. So if there's an heterosexual person, if this is a woman or a man having sex with men, there's a different package that can run different tests with samples of different places. But check the potential to distribute other things. So you can distribute medication of other kind, and as I said, or anti-conception medicine. This kind of concept is working out. This service was assessed a little bit ago, and they assessed the use, the access, and the clinical results of having these kind of services. One important thing here is that not all of the people who have these packages return the samples, and that's one of the limitations of this kind of intervention. And we have seen that it's around 60 to 70% of the people who take away the package or don't return the samples, or it happens that the samples were not returned properly and they don't work out. So they are limitations. The information is very important. Having videos for explaining the people how it works, and the technology explaining how they can use these services. We know that women, for example, have more chances than men to request samples and return them. Women also always do the things much better than men do, which is better, which is nice. The demand to this kind of services has increased. People know that there are this kind of services, and if they have never thought about it, they start thinking, okay, now I should do this. And there are no difference in terms of access to the treatment, which is something that I discussed before. The linking to the health services, it's very acceptable, 70 to 90%, depending on the community as well. There is acceptability in terms of confidentiality, the discretion, and convenience. And as I said, we need to run studies in each setting in order to determine if the acceptability is okay, because there are communities that are different to other ones. And for some communities, this is quite acceptable, and for other communities, it's not that acceptable. And the costs have reduced in terms of the test and the diagnosis. They have been reduced. So this is an option. And now, thanks to all the digital systems in place, it is possible to implement this. And there's experience in the kind of way that we can run these interventions. Now let's talking about these machines, not only for HIV tests, but also home test for HIV or other kind of STDs. So these are the machines that we have developed, but they have a lot of potential to offer access to other things, like, for example, PrEP or PEP, DoxyPEP, and also as the potential to get other kind of products for sexual health. Let's talk about these machines and what are the advantages and disadvantages of having these kind of interventions or options. One of the advantages is that there's availability, potential availability 24/7. Imagine these machines that no, I don't know. Imagine the vending machines that distribute Coca-Cola or chips. They are very good if they are placed in a position where the access is available 24/7. There are no training costs or staff because it's just a machine. If the test, what you place in the test has very clear information on how to reach the health services, that's important for this kind of intervention. But in terms of self-test of HIV, the costs are way lower. It costs around £9, but when you go to the clinic to run the same kind of HIV test, it costs £53 because of the administrative cost and all these kinds of things. So you can start seeing the balance between the cost and the benefit. And there's also a possibility to increase the number of machines and place them in different places. In many sites, increasing the access to these kind of interventions or opportunities. They can be placed, for example, in places where men will have sex with men, if it is the kind of population that we want to reach. Or it can be placed somewhere else, as libraries, in the campus, or in malls. This was the first machine that we developed in the United Kingdom, and we placed it in public bathroom where men have sex with men and they know other men. And what we noticed is that it worked very well. Not only were there more self-tests, with respect to the ones that the users used to get from a community service. But the most importantly is that the people who had a high risk used this kind of test and hadn't done any tests on them for a long time. We could get 33% of them had a history of not getting any kind of HIV test. We identified 3 HIV tests during the study period, but there were limitations. One of the limitations was that it only gave HIV self-tests, but nothing else, and they wanted more. They wanted an intervention that was more complete, not only HIV tests, but also some other kinds of STDs. For that reason, we started to develop the second generation of machines. The second generation, not only does it offer self-testing, but it also offers the packages for other STDs and home tests. And now we have around 10 machines in the city, in many places. In the libraries, we have machines. In the university campus, we have them in the malls. And obviously, at the beginning, the question is, if we place this machine, will the people use it? Are they going to use them? Someone will say, okay, this is a machine to run an HIV test, and no one will use it. But it's amazing how the people start using it. At the beginning, there were not so many people using it, and little by little, they started to use it. And now it is part of the furniture, it's part of the library, and it's become something normal. And running a test on yourself is normal. Not only HIV, but other STDs. So we have reduced the social stigma with this kind of test, which is something very important. Now, the information inside the packages is also very important too. This is an example of information that you will find in each of these self-testing to reach the health service in case something turns out to be reactive. So there's a card, which is very simple, with a QR code. And if the result is positive, then you will know what to do and where you can get an appointment, who do you need to talk to if you have a psychological issue or feels very bad because of the result. But even more importantly is that you start making the connection not only between the test, the machines, and the system, online system to access the test. There's a digital communication. This is the assessment that we ran in the machines that we have in the United Kingdom, and what we found out. And as I said, in this case, we are not concentrating on a very specific population like men having sex with men, but general population. And this is for all the population. And what we notice is that most of the people who are using these machines are young people, but more importantly, if we see the last time when people run an STD test, around 28% never had a test like this before. So this machine allowed people, this group, to access this kind of test. But even more importantly is that if you can see, number 43% of people had never run an HIV test on themselves. So we're really concentrating on populations that don't go to the conventional centers to get this test, and this is what we needed. And when you ask the people what they think about this kind of interventions, we see that most of the people like this kind of opportunity because it's private, it's confidential, and because of these and other reasons. But there are situations in terms of visibility, the position of the machine, that's very important, depending where you place it. So we need to fight against the stigma and obviously the technical issues that always happen with any kind of machine. This is important. It's important to learn of this kind of opportunities or interventions to learn more. The flexibility of it. This means that this can be moved to different sites, and these are just a few examples where we have these kind of machines specifically concentrated in different populations. For example, in Zambia, this is focused specifically in young people around 18 to 25 years. The machine has this kind of HIV test, but also condoms, things like sanitary towels, because that's a problem, because the girls don't have access to them. In Japan, it's different, completely different. The population is different. In this case, we are focusing on men having sex with men, and this is self-testing for HIV and syphilis test, and there are some others in other cities in the United Kingdom, like in Bristol or in Australia, where the concentration is in the indigenous or rural populations where they don't have this kind of services. We saw these kind of machines, we have the access to them, the online access. Now we can talk about the health. We are talking about mobile health, basically cell phones, where they can use an app in order to manage a little bit your health. We know that there are more people, and there are many more cell phones than people in the world. These are examples of two apps that we have in our clinic in Brighton. One is CoreMatch and the other PrepperMatch. This is a project done around 6 to 7 years ago. So it was designed with the community. We designed a digital app for the management of stable patients with HIV. The main idea here is that these kind of apps will make it easier the management of in the clinic, reducing the number of visits that the patients have, and making it easier or giving them the power to have the results of the test, or to communicate with the clinics, and when to know when they can get appointments and communication directly with the clinic to let them know when they need to come back and get their ARVs.
That's what we have seen, that the access has been improved, has reduced the number of visits to clinic in 30%, because these patients do not need to come because they are stable, making this time easy for the HCPs doing something else. And there are many patients who are already with this intervention, then can use it through the mobile in order to manage their own condition by empowering them. We have tried to adapt this to make it easier, the management of PrEP. We have seen that when we introduced PrEP within the clinics, there were so many patients with PrEP at the clinic. They were moving away all the patients that need to come because they have all these symptoms and STDs. We try to modify, to adapt the original app, and we designed the PrEP manage the app. And what they do is that they have the standard of managing it. And so patients need to go to the clinic, they have an assessment, they have the PrEP, they have to go back 3-6 months to have another prescription. What this app has been doing is to improve this because they don't need to go to the clinic every 3 months. They can run the test, and if everything is all right, you can have a digital prescription through the app. Everything is being managed. As you see here, we have like 2,400 patients with PrEP, and we don't have a waiting list, which in the rest of the UK is like 3 months waiting list. And this has been improved because of the digital use. This app. It seems this is what the app is doing. Allows us to be able to integrate, put together the app with the clinical record and the file that we have within the hospital has reduced a lot the number of visits to the clinic, and this means a cost. Every time the patient goes to the clinic, there is an administrative and time cost. We can't reduce that time, and has an effect of benefit and cost. And it provides empower to the patient to have access to results and also to medications in an easier way, and to have a way of communication with the clinic, because it's very important to be able to reduce HIV, that they receive the PrEP, they have exams every 3 months, and this is very important. But provides an opportunity to promote health, to send messages, to provide communication, the right one, the information, which is the right one. And so patients do not need to go and find out, and, well, they have misinformation through Google. That's what happens most of the time. So they trust on our system, which is important. There was an assessment, pilot assessment, by using certain tools to assess digital technology. Basically, we found is that it's not only in terms of usability of technology. There was no problem at all. The score was too high, and they used these tools with a stability acceptability scale. And so people, they found it very easy to use, getting the results, appointments, and also to take responsibility of their own health and functionality, to be able to have all these things. And they want more communication, they want more things. Patients, they are asking for more. And if it's free, more, well, the better. But we cannot just forget that even there are digital technologies, we have the community. There are many NGOs that offer lots of help to patients. It's very important to work with these NGOs and communities to promote not only self-test, PrEP, and other things. This is just an example of another intervention, which is PrEP to You, where patients go to some organizations which are termed Civic Store, which is one of the largest in the UK. Some patients, they don't want the digital part. They don't want to go to a hospital, but they want to go to this organization to receive the test. Working together with the organization has been possible to offer these services. It's very important to have the tools available, but don't forget, there are some other choices as well. To give you an example how it works and how can be developed through a pathway, digital pathway, this is an example of a work we are doing in Zambia by developing a digital pathway for young people who are includes also vending machines, dispensing machines, but mobile health, and also the use of computers, PCs, and even the use of these cards that might provide some encouragement for young people to have a test. All this is digital. All this is electronic. It's interesting to see how young people, they like these things because, well, most of young people, they have all this idea of sexual health through the mobile, so they know how to use it. It's easy for them to use it. So if we think about the choices there are, it's very important to think that we have to be flexible in terms of options, choices, not only digital, but also for patients to go to the clinic, to have the appointments, to have access to these services. The digital part might reduce or improve capacity within the clinic. People who need to go there, they can get an appointment. And the result in the UK has been very important, very significant. As of 2015, there was an important reduction of the number of new HIV infections. There has been a reduction every year. There has been two reasons. The epidemic in the UK is especially with men having sex with men, and this has been the introduction of PrEP, and also it has been reduced because of that, the test and the HIV tests. That has been the most relevant part. When you see what has happened at Brighton, well, this is our 95, 95, 95. We are very close to achieve the objective of getting rid of HIV transmission, especially because of what I was showing, flexibility for a patient at the city to have access to PrEP or HIV self-test or the STDs everywhere. So there's no way out if they want to have it. So we have improved the access and the impact as well. So we know that it has an impact. Which are the takeaways in here? I think that digital technologies had a lot of potential to improve the access to HIV prevention and infections services. And they are easy to get, easy to implement, they are acceptable, they work for most patients and for most users as well that are at risk of having HIV. It's very important, and I want to make it clear. It's not just the fact to buying the app that we have on the UK and implement it in other places, as in Latin America, but we have to create a design of the technology with people in the community. Even the color of the app, language, the flow of the app needs to be done together with the final user. It's important to do this because it's not going to work for everyone. If you've seen the dispensing machine at Zambia, we did that work with the young people, and so it has a different way than what we had, differently, very different than the UK. It's important to make the community be involved. Digital technology might reduce the cost and the stigma related to this test, but what is relevant is that there is a real digital divide. People have no access to Wi-Fi. They cannot afford even an intelligent telephone to be able to have this technology. We need to consider them, and these are vulnerable population, and they live in rural areas. They cannot afford them. We need to consider them and to provide services for them. Might not be digital, it doesn't matter, but it's flexibility of the services, and that is what matters. When we see all these things, we can say it's complicated, but the final message is that don't be pessimist, that things are so hard, I can't do it, it won't work. Don't be optimistic. Don't be optimistic that many people say, "Oh, it will work. It doesn't matter." It's important, but try to be activist. That's part of the solution. Activist, part of the solution. We can be part of the solution, trying to change in our own health system, and by implementing the access to prevention. It's possible to do so and to get rid of transmission of HIV for 2030. But we need to improve the access to these services, which are there already. So thank you very much to certain people who had helped me out during this time to put together this presentation. And with this, thank you so much for your attention. Thank you so much, Dr. Vera. Undoubtedly, your presentation has opened the view for people who are working on public health, seeking to reach the first 95 by favoring self-testing and detections. We have a space for questions and answer Q&A. So please use the microphone. I will start with the people who are here. If there is a virtual question, please let me know. Introduce yourself and tell me the place where you come from. I am Diana Erika. I come from Baja California Sur, Mexican Institute of Social Security. Thank you for this presentation, very good presentation. I have some questions. Has to do with tests that you're sending through the postal service. Is that through a civil organization or this is part of the government program? How is it done? Because it seems to me that strategies that you talked about are good, including vending machines, but it's by the government or a social or a civil association. Well, both, because there are some companies which are doing this type of work. And these companies, there are 2 or 3 companies in the UK which are distributing these packages at certain cost, but the cost is paid by the health service, National Health Service. To do this type of sustainable intervention, it needs to be taken by the health service. Otherwise, the costs are going to be too high, and cost is a barrier. We did some work with the vending machine. We were asking potential clients, how much are you willing to pay for this? And most of them, they wanted for free, of course. But the tops, it was around $6 they were willing to pay for. But this is a barrier for access for vulnerable people. Yeah, essentially it's a National Health Service that is doing directly from the clinic, or to pay a company who can do it and distribute these things, because the health service, the per staff, they are so busy to do so in a very systematic way. I have another question. When you were talking about the vending machine, it provides you the kit. How you took the demographic information for this study or survey? Well, it's a good question. It's very interesting because in some places we have been taking this vending machine. Well, I put my hand and it's doing something. I get the test. It does not work that way. When you go to a vending machine, especially if you're going to get a test, you don't want to be there for more than 2 minutes. It's not half an hour asking questions, whatever. When we did the co-design with the community, they wanted just a few questions, 4 questions actually, very fast, 20 seconds. Your age, when was the last time that you have this test? An HIV test. Where do you live? It's important for us to know whether were coming from the city or outside. Just a few information. That's why it's very relevant to have a co-design with the community, to know which is the type of questions, or no questions at all, no barriers. Right. Thank you. Well, I come from the IMS for the holders. How much prejudice on these practices of men having sex with men might be a barrier to get access to this PrEP, especially in Latin America, where the stigma among the HCPs might be like a barrier to provide access to this test. And in those Latin American countries, and also in Mexico, I guess that we need to include the unions. And there's an example that happened 30 minutes ago. A person, he came to the clinic to ask for an HIV test, and they say no because they were just for pregnant women. And unfortunately, he was reactive and positive on the public sector, and they did not want to ask to provide the result. He has to write a letter to ask for that. These are barriers that are creating issues to endorse access to treatment, timely treatment, as well as people who would like to get a PrEP or who are seeking for PrEP because they have an accident within these 72 hours. Okay, thank you very much. I think that the stigma problem is large and requires education, which is relevant with HCPs. It's very important because traditionally, usually, human being has some assumptions and judgment. It's important to fight that. That's why I was telling you to be activist. Each one of us might become a tool to be able to educate other HCPs in that sort of topics. You are absolutely right. This is barrier for access to prevention services. There are two levels: education to HCPs to understand that they shouldn't do that, but also to be able to understand that it makes sense from cost-benefit viewpoint when you are talking with people from the secretary. What they want is how much I have to pay for that. It's important to know that if we can prevent an HIV infection, a lot of money might be saved that might be used otherwise. And so that's the way how we have tried the UK to switch this type of cultural view within the Department of Health and the HCPs. This is something that needs to be done day in, day out, because the change of HCP health is constantly turnover, new nurses, new doctors. They come from the college. They have to talk about, we need to talk about stigma and HIV, and it will take some time, but we need to do it. This is a huge barrier for access. I don't know if this is answering your question. Hi, good morning. Yvonne Romero from OAD Morelos. I'm a nurse. I have a question in regards to you. I think that we are putting aside a vulnerable group, which are teenagers. The starting of sexual life on teenagers is around 14, 15 years of age. In our country, for them to have access to an HIV, they need to have the written consent of parents. And that's what, in your country, what is it that you use? What type of strategies do you use for the teenagers to have access to the PrEP? Oh, this is a good question. It depends upon the legal context of the country. I'm going to give you an example of UK and Zambia, where we are focusing ourselves on young population. Research has shown that young people, they don't want to go to the clinics because it takes too much time. They feel judged all the time because if they are 15 years of age and they ask for an HIV, well, because they have are sexually active. But we have to offer special services to this population. In the UK, we have clinics just for young people within the sex clinic. One day when they come, we will serve young people. And we have specific HCPs for that type of population, specialists on pediatrician, young people that they manage this type of people or population, and it has worked well. And there is access to many things. You can provide a holistic treatment. It's not just for young people, but STDs and HIV, but contraceptives and also sexual abuse. We are talking about different type of programs. This has worked well in the UK. Specific services for this population. We need to go out from the clinic, go where they are to have access. But with the digital technology, it's very easy to do so because they can do it through the mobile. And in Zambia, this is a country poor, sub-Saharan, and most young people, they have the first mobile phone at 12 years of age, 12 or 13, and they share with parents. But usually they have the mobile. So there's a possibility with digital technology for young people to be empowered to manage sexual health. Yeah, but nonetheless, in the case of request online, we are talking about they have to have the affordability to do so. But they will have to have the access for public, well, for population in general. Otherwise, we are leaving behind people who cannot had not a specific income, unaffordable. I'm talking about the UK because in the UK, everything, all these services are free of charge. And at Zambia, services are free of charge because they are paid by the government. If this is not the case, this is a huge barrier. Young people cannot have access to it. People who cannot afford it cannot do it. Thank you. Yes, it's important to make it clear that there is a norm that is updated to work with teenagers in between 16 to 18 years of age. They can have this HIV without the consent of the parents. And also, people who cannot have Social Security, they can access PrEP and PEP without any problem. And there is a model where we link when you are getting or losing Social Security, the PrEP will follow you anytime. It's important how, as an HCP, people are trained, updated on those services to endorse that they can provide the services, especially young people. They can have access to the test without bringing parents. And this is for 16 and 18 years of age. Can I make a comment? Yeah, it's important for teenagers to know that because they don't know that. You have to do a lot of promotion. So we have another question on behalf of streaming, and they are asking about adopting these strategies with a cultural belonging view, especially people who are on a migration situation. Okay. Closer, yeah. That's a good question. We are doing now a work. We have uh, we have a problem of migration, which is complicated. At the UK, around 2,000, 3,000 people crossing through the channel, La Mancha channel to the UK every single day. And the access to sexual services is complicated. This kind of population is hard to work with. We are working with the NGOs that work with this population to understand which are the needs and try to offer the necessary services. Co-design is going to be important to think about language, because it's not just going to be English, there are other languages. And for these interventions, we need to work with these organizations that already work with this population, trying to identify which are the needs, understand the background, cultural background, and use the interventions that we know they work. But we need to understand how to do it, how to implement them in the right context. And within these policies of the National Council of HIV from CONACYDA, there is attention to migrants, people who had no Social Security. We endorse the attention for people who live and come crossing through the national territory. They are endorsed to have PrEP for ARBs, pregnant women, endorsed that even they might have childbirth and the child is not going to be contaminated. And so also the PrEP, which is available for people who are migrants and had no Social Security, is available right now. So we have moved forward to endorse that migrants can be provided an HIV attention in Mexico. Thank you, Luis Adrian. Thank you so much, Dr. Vega. On behalf of this conference and National Mexican Institute of Social Security, we provide you this acknowledgement. Thank you. Now we will continue with a presentation of Dr. Magis. everyone. Following this agenda, I just want to make a comment in regards to yesterday. We have 15,000 interactions on online streaming. This is an hybrid congress. We have lots of visits and attendees on streaming. I am Dr. Ivan Martinez. I'm coordinator of programs on excellence, clinic excellence of the IMSS, where we work the national program of HIV. And now we will start talking about this relevant topic, following up what Dr. Vera mentioned before. The efforts made in this institution to be able to reach these international goals towards which Mexico also is a part of, and the whole health system of the Social Security Mexican Institute. The effort of the IMSS to reach the first 95, where are we now? What do we need to reach the goal? So this chat is going to be given by Dr. Carlos Magis Rodriguez. He's a researcher of Inter-American Conference of Social Security. Dr. Magis is a doctor, and he started in 1988, General Directorate of Epidemiology. He was in charge of the HIV control, and he was also head of the National Registry of HIV cases. From 96 to 2010, he was the head of research of SIDA. As of September 2010 to 2013, he was coordinating research of HIV in Mexico. From 2013 to 2019, he was in charge of integral attention of SIDA, now professor of public health of the National University. So thank you so much, Doctor. Well, thank you very much for this invitation. And I am going to show you the results of a project that the CIS is doing together with IMSS that has to do with the cascades and how we use them. What do we need to do? Why it says 95? Where does it come from? I hope that I can be able to share with you what we have been doing so far in terms of research. I want to thank my peers from IMSS, coordination where these doctors are, coordination of epidemiological surveillance. And so I want to show you now the second slide. What about the cascada for attention of HIV? Well, around for 2014, I was in charge of organizing by SIDA a meeting, Latin American meeting, where we decided within the framework of the PAHO to use the La Cascada of attention, cascade of attention, to see where we are at 2014. A long time, countries were within the framework of agreements of 20,000 countries every time, 5 years, they signed this agreement with the UN. So what did we agree on 2020? We agreed in 1990. What did that mean? As you see, 90% of people who had HIV, they will know their serological status. That means everything that the previous speaker talked about to improve detection, the effort made to get that early detection. The second 90%, those people we know that they know about their status to receive treatment. There is no reason at all for a person with HIV not to have a treatment right away. There are just a few cases where that we can define for other reasons, but there's sometimes since these guidelines had been modified, so ARB guidelines allowed us to do so. And finally, people who are under treatment, we wish that for 1990 to have at least been suppressed, to have a viral load non-detected.
And these were the goals that everybody had. They were agreed and they need to be reached by 2020. We didn't actually reach them. Some countries did. Sometimes we are closer or farther. By now, there's an update by United Nations. That is not 90, but 95. The same goals, the same groups. They need to reach this 95. So the cascade of attention, as it says, it's a way to measure the programs for HIV people with HIV, and United AIDS UN updated 95, 95, 95 as well. Where do we get these numbers from? How can we understand these cascades? So, what is does a UN AIDS do? Every year there are estimates, and Mexico contributes with workshops and makes estimates on how many people there are, the number of new infections, and the experts, of course, need to inform their serological status. That means that they are a part of the national epidemiological record. These cases and this institution I was in charge of for 5 years. In here, we count with all the institutions giving numbers since 1987. So the first thing is the number of people with HIV, and the second number is the number of people with HIV that know their status, which has to do with the epidemiological process, the number of people receiving ARV treatment. So they are known with names, and these are the patients that are under control. They have a file, they receive attention, and in Mexico they have universal access to ARV since 2003. IMSS did it first before other health institutions since 1996. And this is a kind of access that is free in all the instances. And as we were told before, for a population that moves, which are not few in this country. There are people who come who pass by Mexico, but Mexico also receives around 1 million people from the United States living in Mexico. Just for you to have an idea, this is the country out of sight of United States where most Americans live. The number of people that get the viral suppression, the guide says that for the management of the patients, we should have viral loads for them, and that is also recorded, and we can get the information that we need as well. So, United Nations AIDS is a special agency of United Nations. It's an agency where all the agencies participate. It's a program. You have the WHO, UNICEF, and all of them. But United Nations AIDS, since the beginning, said we want to be an agency that handles numbers, and since the beginning, they are doing estimates. We can see those numbers every year. In the past, for the World Day, December 1st, which is close, and now it's done in July. There's a big conference, international conference. This year was in Australia, and in there we get to know the numbers of how we are doing per region, per country. That can be found in their websites. Mexico has shown these numbers for all the country for 2021. For 2021, the Censida space made a calculation of 360,000 people, but as you can see, the cascade is not close to 90 in none of them, or 95, 65%, that is the calculation by Censida. They are the people that know their status. 61% of them are in treatment, and 54% of the whole people in the country haven't reached the virus suppression. So given this data, we are very far from reaching the goals. But the point here is, and the main question is, so what about the IMSS in the country? Because these are the national data that you can see in the country, but we would like to know what's going on with the country. And then we start working with an epidemiological tool that is called transmission mode. It comes from the United Nations AIDS. I used it when I was working in Censida. Other countries have used it. It has advantages and disadvantages, and We decided to use one and use it for the IMSS and not to use a spectrum, which is the one used for the whole country, which is the one also used by Sensita. So let me show you what we got here. What do we need to do for this? Estimates are always done in populations from 15 to 49 years old. We know that there are infected people before 15 years old. However, we still have vertical transmission, and we also have sexual assault. That's something that we can also count. But the countries use 15 to 49 because that's the reproductive age. And we also know that there are sexual relations after 49 years old. And of course, we have an age population with AIDS. So but that's the way the United Nations does it. That's why we use it. So where did we get this population from IMSS? We pay attention to this kind of population, and we were told that for 22 and 2022, it's an important year because we haven't closed the years for 2023, that there are 54 million people, 26 million of them are in the group of 15 to 49 years, and 12.5 men, and after that we need to distribute the population in different populations, in low and high risk populations. Not all of the populations, not all of the populations. We talk about vulnerability, but also about key populations which have high prevalence. The teenagers don't have high prevalence. The ones who have prevalence are the groups of men that have sex with men and trans women or users of injected drugs. And that's what the model needs. And for each of these groups, we need to know the size of the population and the prevalence. Once this is done, we can move on. Let me show you now. This is quite small, but for each of these groups, we have sources, national sources that will allow us to estimate, and then we can apply them to the IMSS population. So, for example, in this moment, we don't have the information from the national survey on the use of drugs, tobacco, and alcohol. I think this will show the growth in the use of fentanyl. This survey is being done now. Once we have the information, we will be able to use it. And we need to calculate the users of drugs, their couples, women, prostitutes, customers of prostitutes, and each of them need to be assigned. And this can be done because Mexico has great richness when it comes to epidemiological information. And by 2021, there was a new survey done by INEGI, which is a survey about the sexual diversity and genre. So all this gives us enough information in order for us to jump to the model and its results. So the model gives us this information, it's simplified, and we are told that there are 112,000 people living with HIV in IMSS. And now that year we had 7,700 new infected patients. Now let's see how many we saw in the surveillance epidemiological survey. This red group shows men having sex with men. From these 7,700 people, we can get more information, a graphic to synthesize that analysis. And what we are told here, from the whole total of these 7,700 new infections, where do we find infections? And the key populations, men having sex with men, 70% of those new infections in the year 2022. This is reasonable, but for 2021, similar. The couples of men having sex with men is 20.6%. Around 20% of men having sex with men also have sex with women in the last 6 months. And that's the way we can see heterosexual sex of low risk gives a lot of information. It's a lot of people. In this case, no, the size of the population does matter. So we have a lot of people living like this. And I want to focus your attention to ODs, which is the first user of drugs. 1.4, it's necessary to assume that there is population in IMSS that uses injected drugs. And the trans population, which is a group with a very high prevalence, around 20% of that prevalence in trans women, we discover that very probably the population is quite small for a country and even smaller for the IMSS, and it produces a lower percentage of infections. They are important populations, however, this modifies the way in which we see prevention and detection. We need to have a special place to detect the most affected populations. So for the epidemiological cases, it's possible to see that we have a comparison of 2022 and 2023, the first semesters. And what is the estimate? For 2022, here in the yellow box to the right, you will find the division by SWATs. The IMSS reported 7,960 cases, and I told you there was 700 new cases. The thing is that there's around 25,000 people, I'll show you that in the cascade, that have been accumulated that haven't reached the detection. Good news is that unlike the previous year, 2021 and 2022, we have recovered the capacity. People are coming to detection and we are detecting more people. This is an advantage because, of course, the pandemic made the detections dropped with or without IMSS. That detection number capacity dropped. And the longer these populations take to reach to detection, the worse their destiny will be. And there will be more transmission, of course. So the main results we see here is that there are different ways of transmission. We can see how much we're missing. I will show you the cascade for 2022. But we need to assume that we have 128,000 users of in IMSS with HIV, not all of them in other status. We have improved. We have new infections per month, but the detection has raised, and men having sex with men and their female couples concentrate 80% of the new infections. Another group that needs to be seen is people using injected drugs. Now, thanks to this information, I will show you how we can build an attention cascade to HIV for 2022. Where do we get the information from? The first of the categories, 112,000 from this estimate. People with HIV, 93,284, 83% of 112,000. The people with a treatment, this is information given by the attention area from IMSS, so 88,218, and suppressed people with viral loads under 1,000 copies. Because why? Because countries use this as a way to compare. We know that the machines that we use in Mexico give less than 40 copies or something like that, but we use 1,000 copies because that's the way we can compare. We have 80,122, we have 91%, 95, and 83 in a graph. This would be seen like this. And in here we can review that for 2030, people with treatment that has been reached. We have 95%. 88, around 88,000, it's 95% of 93,284. but in this case we are around 83% of the 112,000 with a simple question. We can see that there are people who don't know their HIV status, and in this case we need to do to make the greatest effort, because we need to give the best attention to these people, and because we have also shown that it's possible to manage them in a right way. We need to detect them, and the undetectable viral load is at high level, 91%. We have the clinic part that needs to review the strategies that are being applied in order to improve and reach 95%. We need to reflect upon these numbers. If we have 93,284 people with name and last name, and they are users of the IMSS services, why do we only have 88,000 people? Even if we reach 95%, that 5% missing, there's no clear logic why we are missing these numbers. I think that we need to review why we don't have at least 92,000 people, 92,000 people in treatment. What's going on here? So in some presentation we saw that 95, 95, 95 is okay, but those 95 leaves 5 excluded of something that we could be reaching. So these are the conclusions. The IMSS, of course, has made an attention protocol. This is the way we address it for prevention and promotion. We have 96% of them with a treatment based on integrasa inhibitors in a single chart. This is the treatment discussed in this Congress. That's perfect. By 2022, there was 90% of a correct replenishment. There are documents or supply. There are documents describing this, and that's the highest number reached in the last years. So we have a resupply. This was something that it was hard for us, and the supply of around 1 month in advance. If the person is okay, they don't need to come to us very frequently, and besides that, there's a group of experts reviewing the progress of every patient. There are many. How is this reflected? This is the last of the indicator. Forget the cascade. I'm going to move to the mortality rate by HIV. In the numbers we have people dying by HIV. And in here we have at the center, that green one is a country. It lowers, and in the top in brown, it looks like a mini computer. This is how the people with no social security are doing. There's a lower number, but they are decreasing, but not so fast. The IMSS is also decreasing. It's not IMSS. We have the users of health services. IMSS is the one that has the greatest part, but also we are considering is the users. INEGI doesn't discriminate. They only say users. We have PEMEX, Army, the Navy, and the Army. And for 2019, there was some kind of raise and a decrease by 2020. This might have to do with the impact of the pandemic, people with HIV who died because of the COVID, and that wasn't recorded by HIV. We need to review that, what happened, because there's a strange movement in the curves, and there was a movement that explains some kind of a change that in 2019, before the pandemic, we need to still review, because the last thing that we reviewed with this treatment was not having, of course, deaths. And the PrEP, of course, gives us a tool, and PrEP as well, but PrEP is more important because of the impact in the population, as we were shown for London, or at least for London, the drop in the prevalence in groups using a lot of PrEP. In Mexico, I don't have I have the report from June 2022. on 125. If we updated this by 2023, it would be around 4,000 people. The Secretary of Health has a similar number, 4,000 people. Probably there are around 2,000 people. In 2019, we run a private study. There might be around 10,000 people in PrEP. These are key members of a key population. That number is small because in order to have an impact in the decrease in the incidence, we would need to have as a country not 1,000 people, but 100,000 people in PrEP. Our goal with PrEP is high, we should need a growth in order to have better results. So we're still missing a little bit for 95. We are still for 2030. We are 5 years away. And the challenge is the challenge of detection. The challenge of detection. We need to improve with the tools we have available. We also have the new norm that allows the companies to authorize people to get a self-test. We hope this will be quick to have another tool. It's necessary to remember that in our country, for example, there are self-testing for other things. Any teenager can go and get a pregnancy test. Why not an HIV test? A moment ago, when we were talking about that, the norm in 2023 was already published as a project in 2018. So we have been dealing with this topic for a long time. There's something weird for the context of. For this context, there are pharmacies with a doctor's office next to them. They are offering this kind of test too, so we should offer the whole package. We should offer a test for other STDs. So the challenge is about detection, but it's also about reflecting about our detection models in the institutions. And even though the norm says it, I don't know any exceptions. There's a family unit for health nearby. There is none of them saying we give away condoms or a test available. Sometimes I did a test in the family units on the use of availability of condoms with the strategy of mysterious clients, young people who wanted the service, and we always found there's a lot of institutional bureaucracy. At that point, they were in the need of condoms. So we need to improve our detection tools. We need to reflect upon the norms and what it demands. There's a guide of detection that we don't need Western blot to confirm anything. That's been in the norm for a long time ago. We can go to the treatment with an algorithm proposed, and we have all the tools, but we need to think in institution-wise, and what we need to do in order for them to be applied. So that's the end of my presentation. I think this was the last one. Thank you. Thank you so much, and I think that this is a very important topic that from which we need to start, and the work that has been done along with the Inter-American Conference for Social Security, Mr. Alvaro Velarque, and the authorities of IMSS that have allowed us to have this moment, this kind of results, being transparent, and to have these breaches or these gaps we deal with, and that we need to understand as an institution to get the goal. Now I will open the forum for some questions in case anyone wants to ask something to Dr. Magis. Go ahead, please. Hi, good morning. This was an excellent conference. The data was very interesting. I would like to ask you two questions. I think that the challenge of 90-90 and get 95-95-95, as a country, we are still missing a lot to do. But this is a very important difference when it comes to those with social security and those who don't. there's a very big gap, and in Mexico, there's around 40 or probably 50% of the population who don't have social security services. So that gap can be filled with the strategy that we have now. That's my question, because besides that, it has to do with resources. And the second question, and that's about the institution, it seems that the gap is in the process of detection. In detection, sorry, we have 82% and we should have 90. I think that the challenge here is to detect, because at the end, the viral load, detectable viral load is in 90. We are very close to 95, and that's thanks to the colleagues that we do every day. So there's a very important difference here. So the most important strategy would be detection. So that would be the real challenge. And I think that this was considered as a search of options and creativity to get the detection. Thank you. Thank you so much for your question. And yes, the country would go better if the national indicators were the IMSS indicators. The IMSS has had a very superior performance with the users, and this is a permanent right. This is a recent story. Now we have a popular insurance, and we have this new institution. Now we are betting the people who think that we should have a universal social security as a scenario to recover or to close the gap between those people who are users and excluded, because the users, that's nice, but some others are excluded. So I really hope this works. Unfortunately, making this change in the middle of the pandemic, that spoiled many programs for detection of TB, HIV, vaccination, all these things that the Mexican population decided not to use to the hospitals because of the pandemic during 2020 and 2021. After the pandemic, we needed to make a bigger effort. By 2018, we were able to detect 18,000 new people in the whole country and in all the institutions. We lowered to the half of that by 2020, and now by 2023, we are returning to at around 15,000, but we are not having the performance we used to have. So there's a gap, of course, in the rightful claimants or beneficiaries, or a gap before the pandemic, and what needs to happen after pandemic. So we need to make a bigger effort to that done in 2018. 2019, sorry. We have a question for one more. We have time for one more question, and at this moment we are going to start the transmission for the in the session room. So first of all, Mr. Magis, because this is the information that we have requested IMSS for a long time. Also, thanks you for to their efforts down here. Thanks to Alvaro before you leave. When you started to work in Social Security, we said that we should be held for the supply of medication. We knew that the commitment of a gay man helps to these processes. And when there's someone from the community in these decision-making places, can give something, because the perspective is different. And the last question, when are we going to get this piece of information? They are urgent. We need to start working with the SOAIDs to fight these numbers. And we think that not only with this model, we have been working for 20 years to improve the processes. And for us, this is a lot to do in order to generate and to perform actions and to start implementing them in the work that we do with the OATs. The OATs has a commitment, an agreement with the IMSS. We need to deliver the results of IMSS, and once they are delivered, we need to find a way to supply them. So they are open to a publication. We will see how this can be done. But in this moment, this is public information. Thank you so much. We're going to deliver the acknowledgement to Dr. Makis and a round of applause.
Bien, dando seguimiento a nuestro programa.
Following our program, our agenda, I am so pleased to introduce our next speaker. He's also a speaker who was so kind to help us 1 year ago with a presentation. And I'm talking about Dr. Roy Gulick. As you know, he is in charge of infectology, treating patients with HIV. Dr. Gulick needs no presentation, but he is a head of infection diseases at the Cornell University. He is a doctor at the Presbyterian Hospital, New York, and main researcher at Cornell, New Jersey, for the trials and group from this medical college, and also he's from the Presbyterian Hospital, and he has been in charge of doing a lot of research for human services of DHS. He's member of the board antiviral of the USA. He was the member of the board of research of HIV from the office of NIH, and member of the U.S. Clinical Research Association of Physicians in the USA, International Association of HIV, and Infection Disease Association. He has been a part of different fora, and he has been published in different journals. He will be talking about PrEP and the use of the real world. As we know, as of 2021, 2022, we have the prophylaxis pre-exposition or exposure oral in oral medication, but still we have now this deposit medication, and that's what he's going to talk about. So welcome, Dr. Roy Gulick. Well, from the Baylor Cornell Medical College.
Great. Gracias por la introducción.
Thank you for this invitation to talk with you today on this Congress. I like very much to visit Mexico. Now I will switch to English.
Para esta lectura. Disculpe. PrEP 2023. Where are we? I have no disclosures. So we have known for many years that antiretrovirals not only are treatments, but also are preventatives. They prevent HIV. And that goes all the way back to the experience with pregnant women living with HIV. We know if you give a pregnant woman antiretrovirals, you prevent transmission to her baby. And the latest data show that 3-drug ART for a pregnant woman reduces her risk of transmitting to her child to 0.5%. We also know that if we treat heterosexual men and women living with HIV and they are suppressed, that they reduce their risk of transmission to sexual partners by over 90%. Finally, we know that people who are exposed to HIV benefit from receiving post-exposure prophylaxis with antiretroviral drugs, and that has reduced the number of occupational and non-occupational transmissions. So antiretrovirals can prevent HIV. And that leads us to the strategy of pre-exposure prophylaxis that you know well. This is the idea that you give HIV medications, antiretrovirals, to uninfected, at-risk individuals to try to prevent them from acquiring HIV. The optimal candidates would be potent, safe, tolerable, and convenient. And the first candidate drug that you know was co-formulated tenofovir and FTC or emtricitabine, one pill once a day. But there were concerns early on for this strategy. We use tenofovir FTC for treatment. Do we want to use the same drugs for prevention that we use for treatment? What about drug resistance? Will that become a problem if we use PrEP? What about toxicities? We know that tenofovir disoproxil fumarate, or TDF, causes both kidney and bone toxicity. And TAF, the newer formulation, tenofovir alafenamide, can cause weight gain. Will those be a problem with PrEP? And then finally, the cost of PrEP. Can we afford it? With all of those caveats, the very first study to formally test the concept of PrEP was called IPREX, now 13 years ago published in the New England Journal. They randomized almost 2,500 gay men who were all HIV negative to either receive PrEP with TDF, FTC, one pill once a day, or a matching placebo. And over the course of the study, PrEP reduced the risk of infection by 45%. This was the very first study to show that PrEP could work. Now you're thinking 45%, that's good, but not excellent. In fact, if you looked at the men on the study who had tenofovir detected in their blood, PrEP was associated with 92% decrease in the risk of acquiring HIV. So this reminds us just giving pills is not enough. People have to be able to take the pills for them to work. This led to two other large studies that were conducted in Africa, mostly in heterosexual men and women. The Partners PrEP study, which tested two different PrEP regimens, TDF by itself, TDF FTC versus placebo, and the CDC TDF2 study, which looked at heterosexual adults in Botswana and randomized them to TDF FTC or placebo. You can see that PrEP was associated with 63 to 75% reductions in the risk of acquiring HIV in heterosexual adults. And once again, if you selected the population that had detectable tenofovir levels, you can see nearly 90% efficacy. So these first three studies showed us that PrEP could work to prevent HIV in men who have sex with men and in heterosexual men and women. This led to two other studies exclusively done in women, one called FemPrep and one called Voice. And they enrolled thousands of women in Africa to test the concept of PrEP. In FemPrep, it was a similar design, TDF FTC versus placebo. And in the Voice study, there were additional arms looking at tenofovir gel preparations. The bad news is in the far right column. In these two studies, PrEP was not associated with a reduction in acquiring HIV. And this was puzzling when these results were first released. Why the difference between these two studies and the previous three studies? And it turns out it's all about adherence. So on the FemPrep study, less than 40% of women ever took PrEP at all on that study. And on the Voice study, less than 30% of women ever took any of the PrEP options on the study. So once again, this reminds us adherence is critical for people to take PrEP to avoid HIV. And so this led to one final study done in Thailand in injection drug users, a population who can acquire HIV either through needles or sexual exposure. You can see they enrolled 2,400 Thai injection drug users, all HIV negative, randomized them to TDF alone versus placebo, and TDF was associated with a 49% reduction in the risk of acquiring HIV. Once again, if you looked at people who took the drug, 70% protection in this group. Well, these studies established the fact that PrEP could work for many different populations to avoid HIV. And this launched 2 other studies that came out after the results of the previous studies were known. So this was now known in the community that PrEP works if you take it. 2 studies done in parallel. The IMSS study was done in men who have sex with men in France and Canada, and the PROUD study was done in men who have sex with men in the UK and England. And again, all of them were HIV negative when they came into this study. In the IMSS study, they randomized between TDF-FTC and placebo, but instead of giving it on a daily basis, they gave it on demand, meaning 2 pills prior to sex, 1 pill 24 hours later, and 1 pill 48 hours later. That's called on-demand PrEP. In the PROUD study, they gave it the typical way, 1 pill once a day. Half the group started PrEP right away, and half the group delayed starting PrEP for a year. So we're on no PrEP for the beginning of the study. The good news here, PrEP in both studies led to 86% reduction in the risk of HIV infections. And these are 2 of the best PrEP studies we have today. Why are these numbers better? Because the community realized that PrEP worked, and so people began to take it more regularly. So what we've learned early on from PrEP with TDF-FTC is that adherence is critical. And so across the x-axis here, you have what percent adherence on the different studies I just showed you. And on the y-axis, you have the effectiveness of PrEP. So in the upper right-hand corner are the highest adherence rates, nearly 100% on the PROUD study, with an efficacy of 86%. And then you go all the way down to the bottom left, the 2 studies done exclusively in women with very low adherence rates, and PrEP didn't work. So we can sum this up by saying PrEP works if you take it. Well, how safe is PrEP? This was a meta-analysis that was done early on, and it looked at 13 randomized trials, including the ones I just showed you, of TDF-FTC versus placebo, or no treatment at all. And you can see they included over 15,000 patients looking at safety. So TDF PrEP is in the dark blue bars and placebo in the light blue bars. But what you see for all the parameters they looked at here was no difference. So no difference between grade 3-4, that's moderate to severe adverse events. No difference in serious adverse events, things like hospitalizations. No difference in bone fractures. And on the far right, no difference in grade 3-4, that's moderate to severe elevations in creatinine, the renal toxicity that we're concerned about. So no difference in any of these. What they did see a difference in was lower grade increases in creatinine. So PrEP was statistically associated, PrEP with TDF-FTC, with more increases in creatinine over time than placebo. So we need to note that. Another concern about PrEP is that people will stop using condoms and may acquire other sexually transmitted infections. Early on, there was this systematic review that looked at 8 studies of PrEP with over 4,000 participants. And what they concluded was that although there was a slightly higher rate of STIs, sexually transmitted infections, in the PrEP group, it was not statistically different from the other groups. So their conclusion was that PrEP was not associated with an increased risk of STIs, at least in these early studies. The other concern is drug resistance. If you use TDF-FTC and it's widespread in the community, will you begin to see resistance? And so they looked on the PrEP studies. You can see them listed on the left, the ones I reviewed for you earlier. They looked for how many people who acquired HIV on those studies acquired drug resistance. And you can see that the second column were the number of drug-resistant HIV infections in the PrEP arms, and there were only 5. And then if you look 2 arms later, you can see the number of drug-resistant infections in the placebo arms on the PrEP studies, and you can see there was 1. Both these numbers are small, and they concluded that the overall risk of resistance on these PrEP studies was 0.05%. So very small risk of developing resistance. So the WHO looked at all of these data back in 2015 and made some conclusions about PrEP. And at that time, PrEP was limited to TDF-FTC. They concluded it was highly effective across groups and in both men and women, that adherence was highly variable on the studies and critical for the success of PrEP. They did note that side effects were no more common with TDF-FTC than placebo, although they raised concern for subclinical or minor renal and bone issues. They've agreed that drug resistance risk was low, and that risk compensation, the concept that people would take more risks if they were on PrEP, didn't seem to be increasing. Finally, they concluded that cost of PrEP, if it truly avoided HIV infections, could be cost-effective or even cost-saving. And ultimately, although they note significant concerns about the logistics of administering PrEP, they recommended PrEP for the world. So where are we with PrEP based on those data? The US was the first country to approve PrEP now over 10 years ago. So TDF-FTC was approved in the United States in 2012. As mentioned, the WHO, after a thorough review, concluded that PrEP was beneficial and recommended PrEP with TDF-FTC for any person, quote, at substantial risk of HIV. The European Medical Association approved PrEP in 2016, and by 2021, 141 countries across the world had put HIV PrEP recommendations into their national guidelines, and that includes Mexico. And then another 14 countries added it to their guidelines in the last 2 years. So as of 2021, the latest statistics for PrEP worldwide is that 1.6 million people on the planet have taken PrEP at least 1 dose. 1 million of these were in sub-Saharan Africa. So PrEP is being rolled out in sub-Saharan Africa as a preventative measure. Here's a map of the world. Green means that PrEP is incorporated in the national guidelines. And you see the US and Mexico. Most of the Western Hemisphere is green. Much of Europe, Africa, Asia, Australia, green. The orange countries, it's under consideration. You can see a couple, including notably China. And then the purple countries have not approved PrEP. So most of the world agrees that PrEP should be included in national guidelines. Here's a figure from the Mexican National HIV Guidelines as of 2021. La PrEP es una estrategia más de prevención ante la transmisión del VIH. Okay, what have we learned since then? So renal toxicity is an issue that we need to keep our eye on. Here is an example of a longer clinical cohort study, not a clinical trial, but a cohort, a group of people. Over 170 PrEP users who were followed through over 600 visits and had their creatinine and their creatinine clearance or glomerular filtration rate, GFR, determined. And you can see in both the green and the blue lines that creatinine clearance does decrease over months of PrEP. However, the change is quite small. So it's about 6 millimeters per minute decrease by the end of 2 years on PrEP. There were no cases of elevated creatinine in those with creatinine clearance less than 60 when they started, and no one discontinued PrEP because of renal toxicity. So although it does exist and we need to monitor for it, it seems to be mild and not a big issue in most people. What happened with bone changes? We learned more from the IPREX study. They did DEXA scans, which are bone mineral density assessments. And they did them of the hip, which is the upper graph, and the spine, which is the lower graph. And this is over months of the PrEP study. You can see the black bar is placebo, and bone mineral density doesn't really change. That's what we would expect with the placebo arm. The red arm is the TDF-FTC PrEP arm in people with detectable levels. And you do see a reduction in bone mineral density, both of the hip and the spine. But it's important to look at the scale. It's only about 1 to 1.5% decrease. Is that clinically significant? We don't know, but doesn't seem to be. And the other thing to note is that it doesn't continue to decline. It actually plateaus, and then in people that go off PrEP, it actually recovers back to normal levels. So again, bone toxicity is real, it happens, but it seems to be mild, then stabilizes, and can be reversed if PrEP is stopped. We also learned that taking pills once a day does not work for everyone, and what level of protection do you get from PrEP if you don't take it every day? They used the IPREX study to model this with a PK study. If people took 7 doses a week, there was a 99% risk reduction. If they only took 4 doses of PrEP per week, you still got a 97% reduction. If you only took 2 doses a week, that began to fall off to 76% risk reduction. And I'll remind you, this is only in men who have sex with men. We do not have these data for heterosexual men or for women. So we don't know if less frequent dosing is protective in those groups. And then, of course, we have the whole concept of the on-demand or event-driven PrEP. And just to remind you again, it's taking 2 pills of TDF-FTC prior to sex, 1 pill within 24 hours after, and then 2 pills within 48 hours after that. That was what the strategy was for the IPERGAY study that showed an 86% reduction in HIV infection. So what's the status worldwide? Well, this has only ever been studied in men who have sex with men. We don't know if this strategy works in heterosexual men or in women, and it's not currently recommended in those groups. But for MSM, the 211 is recommended now by the European AIDS Clinical Society, the British HIV Society, the International AIDS Society USA, although as an alternative strategy, and then WHO incorporated it a few years ago, and my own city of New York City also includes it as an alternative. So many people around the world use this as an alternative strategy for PrEP in men who have sex with men. What else happened? Well, everything we've talked about so far has been TDF-FTC, but of course we have the newer form of tenofovir, TAF, tenofovir alafenamide, which, as you know, has less renal and bone toxicity. How did it do for PrEP? So there was a study called DISCOVER, which was double-blind, non-inferiority PrEP study. It enrolled men who have sex with men, MSM, and TGW is transgender women. You can see it's a large study. Over 5,300 people were enrolled. They either got daily TDF-FTC, the standard of PrEP, or TAF-FTC, one pill once a day. And the results were they saw 22 new infections. They were more common in the TDF group than the TAF group, but not statistically significantly different. And so they concluded overall that TAF-FTC was non-inferior to TDF-FTC. They also noted that there were improved bone and renal markers with TAF compared to TDF, as has been seen in treatment studies. They also took a look at weight gain on PrEP studies. And so if you look at the first graph, it's been widely known that TDF alone is associated with weight loss. And so you can see that in the first graph, that people who took PrEP actually lost weight over the first 48 weeks. And that's compared with a slight weight gain in the placebo group. This was seen previously on treatment studies, but had never been documented on a PrEP study. So TDF associated with weight loss. If you look at the DISCOVER study on the right that we just talked about, TDF is in black. You see the same results, a slight decrease in weight, and TAF associated with weight gain on this PrEP study, similar to what's been seen on treatment studies. So that may help us choose among the options for PrEP. We don't use TAF in women yet for PrEP. Why is that? Well, the main reason is that we don't have the studies to prove that it works in women. Those studies are currently enrolled and ongoing, so we probably will have results soon. But part of the concern is what levels of tenofovir do you get in the female genital tract with TDF as shown on this graph here in blue and TAF shown in red. So if you look at vaginal tissue, you can see they're similar, but if you look at cervical tissue, the second from the left, you can see the red bar is lower. So TAF leads to lower levels of tenofovir in cervical vaginal fluid. And some are concerned that that could lead to less PrEP efficacy of TAF in women. So currently we do not recommend using TAF-FTC for women for PrEP, but more data are expected. So where are we? The data I just showed you, the DISCOVER study led to the US FDA approval of TAF-FTC for PrEP in at-risk adults and adolescents to reduce HIV infection from sex. But then note the underlined portion, excluding those who have receptive vaginal sex. So essentially excluding women from TAF-FTC. Interestingly, in 2021, the drug manufacturer of TAF-FTC announced that it was withdrawing its application to the European Union for TAF-FTC as PrEP due to, quote, lack of demand. That's puzzling, but that will not be developed in Europe. And what about Mexico? There is a website that you can go to called PrEP Watch, and here's a screenshot from that website, and you can enter any country to find out the status of PrEP in the country. And I'll just point out that it says here that TAF-FTC is currently under consideration by Mexican government to approve for the use of PrEP, TAF-FTC. It also says on this slide that about 4,600 Mexicans have received PrEP, are currently taking PrEP, which was a little bit higher than what we heard in the last talk, which was through 2021. So this shows that 22 and this year, additional Mexicans have been put on PrEP. Here are PrEP initiations by country, looking at the whole world. The darker the color, the more, well, that's not true. The dark purple shows you the highest rate of PrEP use. And that turns out to be South Africa, has the highest PrEP use in the world. You can see the dark purple are countries with significant numbers of people on PrEP, including the US, Brazil, many sub-Saharan African countries, and Australia. And then you can see Mexico and other countries have people on PrEP as well. So much of the world now using PrEP. Here are the CDC guidelines for how you manage PrEP practically. The first question is, who is eligible for PrEP? And essentially, it's any person who has a partner who is living with HIV is a candidate for PrEP, and anyone who has had a bacterial sexually transmitted infection in the last year. So syphilis, gonorrhea, or chlamydia should be a candidate for PrEP as well. And then it tells you, importantly, that you need to rule out acute HIV infection before you start PrEP. So you need to, in the US, they recommend sending a viral load level to determine whether someone has an active acute HIV infection going on. Why is that so important? Well, obviously, if you treat HIV with only 2 drugs, you are going to select for resistant virus. So you do need to rule it out with signs and symptoms. So take a history and then doing a viral load test and obviously an antibody test as well. And then they recommend follow-up of people on PrEP every 3 months. So continue to do HIV testing, either antibody or in the US, we actually do viral load testing of people on PrEP. You want to test for sexually transmitted infections, syphilis, gonorrhea, and chlamydia, reinforce adherence and other risk reduction counseling, and then assess for adverse events, including renal and bone. And these are the current guidelines that we use in the US. Well, some of the bad news about PrEP, at least in the United States, is it's not being used in the populations that need it the most. So the biggest number of new HIV infections in the United States is among African Americans and Latinos. And this graph shows you who would benefit from PrEP. That's in the lighter colored tan bars. And you can see people out there, hundreds of thousands of Americans could benefit from PrEP. But the purple bars show you who's actually been prescribed PrEP. If you look at the white population, 78% of people at risk are actually prescribed PrEP, but much lower rates, less than 20% in either Africans or Latinos living in the United States. So we are not doing a particularly good job. Lots of effort to try to fix this disparity in who's receiving PrEP in the United States. All right, so we have TDF-FTC, we have TAF-FTC. What's next for PrEP? And there are 3 agents I'm going to end my talk with. One is cabotegravir, a drug you know well. It's the injectable integrase inhibitor and has completed phase 3 studies for use as PrEP, and I'll show you those results. A newer drug on the scene is lenacapavir. This is the first HIV capsid inhibitor. It can be given orally, but the excitement about this is that it can be given subcutaneously every 6 months. And so that's being explored as a PrEP agent. And then a new reverse transcriptase inhibitor, islatravir, is a nucleoside analog, has been developed as an oral agent, but the excitement for PrEP is that they are beginning to develop implants for PrEP. And I'll show you those data too. So cabotegravir, integrase inhibitor, similar to dolutegravir, it's potent, but the excitement about this is its nanotechnology formulation and the fact that it's an injectable agent. So the first injectable agent in our field. Phase 3 studies combining injectable cabotegravir, or CAB, with injectable rilpivirine, the non-nucleoside reverse transcriptase inhibitor, for people who were suppressed on therapy, showed that the injectable agents were non-inferior for treatment. And this 3 big studies showed that it was acceptable in people who were suppressed on their current antivirals for treatment. And that led to additional studies which showed that you could give it every other month and that the lead-in was optional. And that led to approval of the all-injectable regimen in both Europe and in the US from the FDA. And this is now being considered in places around the world. In 2022, FDA approved IM, intramuscular, cabotegravir rilpivirine for every other month dosing for treatment, and the lead-in dose is optional. So that's CAB for treatment, but a lot of excitement about CAB for PrEP, so using it as a single agent. These 2 large studies were done in parallel. The HPTN is the US National Institute of Health HIV Prevention Trials Network, and we're a part of that at Cornell. And this was the 083 study, which was done in men who have sex with men and transgender women. You can see over 4,500. And the 04 study is the bottom one, and this was done at-risk sub-Saharan African women aged 18 to 45. And again, 4,500 women were enrolled. These 2 studies were conducted in parallel and had the same design. So they tested standard TDF-FTC, 1 pill once daily for PrEP, versus injectable cabotegravir given injections in the buttocks every other month for PrEP. And what you see on the far right are the results. So few HIV infections in either group, but there were more in the TDF-FTC group than in the cabotegravir group. So 39 versus 13 in the men study, and 36 versus only 4 in the women's study. Both studies concluded that cabotegravir was not only effective for PrEP, but was superior to 1 pill once a day TDF-FTC. These 2 studies have led to approvals. So FDA approved cabotegravir for PrEP as of last year. The EMA approved it earlier this year. That's the European Medicines Association. And a number of other countries have now approved cabotegravir for PrEP, including Australia, Brazil, Botswana, Malawi, South Africa, and Zimbabwe. What are the problems with injectable antiretrovirals? We wrote a review last year to say there are a lot. So there are patient issues with injectable antiretrovirals. This is an injection in the buttocks, which can be painful and has to occur every other month, which is a lot to ask people to come back to the clinic. There are also issues with the drugs themselves. They require refrigeration. They've not been tested in pregnant women or children, so we don't know if it works there. And then probably the biggest barrier to widespread use of these are system-level barriers. How do you gear up in your clinics to be able to provide every other month injections in the buttocks, so it's a private injection that needs to be done by a healthcare worker. So this has posed significant barriers to the use of this in all regions of the world. Well, if that sounds depressing, the good news is they're working on ways to relieve these barriers. There are new formulations of cabotegravir coming. These could be given less frequently. So there's one that could be given every 3 months with an auto injector, so you don't need a healthcare provider, and could be given instead of intramuscularly, subcutaneously. And studies are starting on those. There's another ultra-long formulation which could be given as infrequently as every 4 to 6 months. And these are being, trials are being designed right now. And then there is an extended release nano formulation, which has been shown in animals to give extended levels. And what you see there are levels in green of what we use today with cabotegravir, compared with in red, the new ultra-long formulation. This would require an injection only once a year. So imagine that for PrEP, once a year injection. Could be popular with people. Also, they're working on patches that could give antiretrovirals. And you see the photo there, it's not painful. So when you put the patch on, it doesn't actually cause any pain. It doesn't reach the nerves. And in early studies in humans, cabotegravir has achieved target levels with these patches. So this is being worked on right now. All right, new class of drugs, HIV capsid inhibitors. So as you remember, when HIV enters the CD4 cell, it loses this inner coating, the green structure here called the capsid, which releases the RNA into the nucleus of the cell. Later on, new viral particles are made and the capsid, again shown in green, is reassembled. So the new class of drugs, the capsid inhibitors, hit the life cycle in 2 different ways. They prevent disassembly of the capsid, and they prevent reassembly of the capsid as well. So brand new mechanism of action. Lenacapavir is the first compound that is an HIV capsid inhibitor. It's potent in the test tube, but one of the features of this drug is that it has a very long half-life on the order of 30 to 43 days, and can be given either orally or SC is subcutaneous injection. Phase 1 studies showed that it was potent, but the excitement about this was the phase 2-3 treatment study in heavily treatment-experienced people who received lenacapavir with an optimized background, and the majority of patients were able to resuppress their viral load level. And importantly, lenacapavir was given as 1 injection every 6 months subcutaneously. So this was approved by the EMA and the FDA just last year for heavily treatment-experienced people who need options. But this began to be explored for other treatment regimens, including in treatment-naive patients, and began to be explored in prevention. So currently, lenacapavir has been tested in a macaque or monkey model and showed that it was highly effective against a rectal SHIV challenge, given subcutaneously every 6 months. And that has supported a current fleet of phase 3 studies of lenacapavir for prevention. So it's going to be lenacapavir subcutaneous once every 6 months versus daily oral tenofovir FTC, the standard of care for PrEP. These are called the PURPOSE studies, and you can see they are aiming at a variety of different groups all across the world. So we wait to hear the news about this. Lastly, islatravir is a new nucleoside reverse transcriptase inhibitor. Again, part of the excitement about this drug is its long half-life. And it's highly potent in the test tube, and there are both oral and parenteral injectable formulations of islatravir. It shows highly potent activity with 2 log drop after a single oral dose. There are phase 2 and 3 studies that have been completed, although additional studies are in progress. But the excitement is islatravir for prevention. And the new way of looking at this could be an islatravir implant. So what you're seeing there next to the US penny is the implant itself. And what you see are holes there, and then on the right, slits. So islatravir is inside this implant and is slowly released over time, much like a contraceptive implant. Does this work? Well, you can see that this shows release of the compound over hours and days. And then they took a look in monkeys at plasma levels, so you can see reaching target levels. And importantly, islatravir triphosphate, which is the active compound, including in peripheral blood mononuclear cells and rectal tissues, achieved target levels. So could this be another strategy for the future? They have studied these in monkeys, so vaginal biodegradable implants. So these would be implants that you don't have to take out. They just disintegrate over time, which would be more convenient, and showed protection in an early study. And then they're looking at ultra long-acting implants that could be put in place for 3 to 4 years. And in monkey studies showed promising results in early published studies. So this is an active area that's being explored. All right, what conclusions then, right on time, could be made about HIV PrEP in 2023? And the first is PrEP works. TDF-FTC works for men and women. TAF-FTC works only for men who have sex with men, but studies in women are in progress. And cabotegravir works for both men who have sex with men and women as well. And all of these are highly effective for HIV prevention. We need ongoing monitoring of side effects, particularly renal and bone. The incidence of sexually transmitted infections, because they do seem to be increasing as PrEP is being rolled out. Drug resistance, and importantly, weight changes over time. Big message for HIV prevention is people need choices. So some are going to like one pill once a day. Some would like an injection, maybe every other month. Some would like a subcutaneous injection every 6 months. Others would like implants once a year. If we have a whole menu of options, people can pick the one that works best for them and potentially switch back and forth between PrEP regimens as well. And then finally, I showed you some of the new drugs and formulations that are under investigation for PrEP. So there's plenty more to come for the future. And I will stop there, acknowledge our supporters and some friends who loaned me slides. And muchas gracias por su atención.
Muchas gracias al doctor Gull.
Thank you so much, Sir Mr. Gulick. It was a very clear presentation. It was a very thorough presentation of the PrEPs. If you have a question in this moment, please go to the microphone so that you can make it. Thank you so much for your presentation. It was quite clear. Thank you for your presentation. It was a very clear presentation. My questions are, first one, in Mexico, as you showed, we have few patients with PrEP. How many would be necessary in Mexico or in the world to have an impact in the decrease of new cases of HIV? And second question is, in United States, in New York, where where is it, where can you get the PrEP? The primary doctors or the doctors in the hospitals?
Thank you very much.
Primero, no sabemos exactamente qué
First, we don't know exactly the amount of
efecto de
and we don't know the effect of the infections. However, there are places in the world, specifically Sydney, Australia, where the infection with PrEP is like this, and the level of infection is very low. In London too, in San Francisco and New York too, same thing. But what's the number? I don't know exactly. And for the question number 2, there are many different people that can prescribe PrEP in the United States. So infectious, infection doctors, general doctors, and little by little, and thanks to the education of this, acknowledgement of this medicine, they can also prescribe, and also the nurses can prescribe it. With reading and education, the general doctors wouldn't have an issue to issue this PrEP, these PrEP options. Does anybody else have another question?
She is seeing a lot of an important number of failure cases of failure in the intermittent group. What is your experience in this group of patients?
we
Yeah.
Okay. The best experience is on la mejor experiencia on el estudio de
The best experience in the use of IPRA, it works very well. We in the United States, this is not very common because the FDA hasn't approved it. It's not highly recommended, but in some patients saying I can't take the pill every day, so we use other options. Or there's this patient that asks, can I take 1-to-1? So I personally haven't seen any failures with 2-1-1.
The principal barrier to expand the use of injectables for PrEP.
The biggest barrier is simply the logistics of this, because people have to come back every 2 months for injections. It's a big deal. Many people don't want to see us every 2 months. That's true for treatment, right? Because if you are stable on one pill once a day, you see us every 6 months, right? And people like that. With this, you have to come back every 2 months. So it's a big deal. Some of the newer drugs, if we had an injection every 6 months, that would be great, right? No problem. We don't have that yet.
¿Alguien más tiene una pregunta?
Does anybody else have a question? Perfect. So we are going to give Mr. Bullock an acknowledgement. Thanks for your participation. Thank you so much.
Bien, continuamos.
In this moment, we are going to continue with a break. Please be punctual to come back to this program for 12:10.
Entonces, ¿por qué no lo cambias cuando llegues a tu
De mujer. Aquí, a ver, aquí está centrado, yo creo. Es que como que le falta volumen a estos micrófonos, ¿no?
Literal, tienes que estar así.
Ah, sí, ya. Mm,
Hola, sí. Hola, ¿qué tal? Ay, no.
hola, sí, se tienen que pegar.
Sí, es
No hay de otra.
porque mira, con uno de estos.
Sí.
y con quién debe aliarse y con quién debe dialogar es muy complicado. Y es utópico pensar que todas las ONG se van a juntar un día y se van a unir para un propósito. Eso no ocurre. En ocasiones hay temas fundamentales que logran congregar la participación de muchas ONGs, pero una vez resuelto el tema, cada una de las ONGs toma su propio camino y esa es la dinámica. No creo que debamos pedirle otra cosa a las ONGs, porque esa es la dinámica en un país donde es tan diverso también. Las ONG son resultado de una necesidad específica y un sentido de urgencia, y esto es muy importante. Nadie que forma parte de una ONG, bueno, de las que se crearon en los 80s, 90s y al inicio de los 2000s, después ya con el dinero es otra cosa, pero al inicio nadie de los que formaban parte de una ONG tenían el propósito en su vida de ser activista de una ONG. Nadie quiso hacerlo. Todos los que nos sumamos a una ONG, a una organización de base comunitaria, un grupo de autoapoyo, lo hicimos por una necesidad específica y por un sentido de urgencia, ¿no? A todos nos tocó ver gente muy cercana a nosotros morir, gente muy cercana a nosotros que les negaran los servicios de salud, gente muy cercana a nosotros que nos corrieran del trabajo, o a nosotros mismos, ¿no? Que nos negaran el trabajo, que nos corrieran, que nos corrieran la familia, que en el hospital o en el centro de salud no nos quisieran dar atención médica. Entonces eso nos hizo movilizarnos. Las ONG se han transformado a sí mismas, lo que ha determinado su actuación también es otra cosa, no son estáticas, son dinámicas que han venido transformándose a lo largo de todos estos años. Y dependiendo del momento en el que estemos hablando, pues va a haber una característica específica de la organización y una forma específica de actuar. Y lo que sí es, ya lo anticipaba hace rato, han jugado un papel fundamental en la transformación de la noción del derecho a la salud. Y aquí viene una parte importante. ¿Cómo lo han hecho? Yo creo, y esta es la tesis que propongo, que lo han hecho a partir del saber. Y el saber, en este caso, entendido como conocimiento, es decir, una forma organizada de representar los datos de lo que asumimos como la realidad, con un sentido determinado y una lógica específica que permite a las personas interpretar sus interacciones con el mundo externo. Y he querido ilustrar este inicio de apartado con esta portada de una revista que se creó y circuló en Monterrey en 1993. La revista se llamaba Ser Positivos y SIDA, Ciencia y Cultura, y en la portada aparece una persona que dice: yo ya lo sé, vivo con el virus del SIDA. ¿Y tú? ¿Pero qué significaba saber que vives con el virus del SIDA? ¿No? ¿Qué significaba saber y además hacerlo de manera explícita?
I caught a little bit of him from the back.
Bueno, sí,
Then I didn't see
perdón.
him. I thought I would see him on the way out, but I missed him.
Sí, además es otra actitud, ¿no? Que tiene que ver, es una actitud positiva, que tiene que ver con el título de la revista, y que además, dicho sea de paso, se trata de una revista que ha sido fundamental, cuando menos en un sector en Nuevo León, en Monterrey, para la construcción de estas perspectivas sobre la salud y la enfermedad, desde la experiencia propia, desde un conocimiento especializado, y ojalá y pudieran echarle un vistazo. Creo que es difícil de conseguir, pero hay un artículo que está publicado y es de acceso libre sobre esta revista. Frente a la necesidad y el sentido de urgencia, creo que ocurrieron varias cosas. Se desató un interés y un consumo de la información especializada. Las organizaciones y las personas con VIH o en riesgo de actividad de VIH desarrollaron este interés por encontrar información especializada. ¿Qué nos decían? Y por consumirla, no solamente por obtenerla, sino para consumir.
No, azul. No, ese es el de mañana. Órale. Rivera.
Bueno, también se produjo.
Perdón, ¿eh? ¿Paso? No, vaya.
Bueno, pues seguimos. Además de este interés y este consumo, se produjo algo que podemos denominar traducción de los conocimientos, porque quienes leían los artículos, por ejemplo, en inglés o a veces especializados en español, pero muy especializados, luego a los padres iban y les platicaban, esto quiere decir esto, y eso considero que es una suerte de traducción del conocimiento que permitió también una redistribución de estos conocimientos, porque muchas veces la gente sacaba fotocopias, se las distribuía del material, o se creaban revistas, se crearon varias revistas, o en las revistas dedicadas a la población se incluían artículos sobre el VIH, sobre el SIDA, sobre tratamientos. Hubo alguna, incluso,
Ok,
absoluta.
sí va así. Entonces hay que cambiarle por...
Doctor Galán. De la doctora Rosana. Ese es de ella.
No tengo el de la doctora Augusto, la tengo yo. ¿Quiere que le ponga lo mismo que la doctora Augusto?
Sí, porque venía por parte de la industria.
Ok, entonces este se queda y este ya lo puedo quitar. Y ahorita le pongo aquí a la doctora Augusto.
Entonces, sería después los trabajos que podemos ver, de lo que ponen. Y luego a ver si...
Vamos a poner así. Este con este y este con este. Y se los dejo aquí abajo. Esos ya no. Tráeme el personificador de Goel. Goel Galán.
Galán.
Sí. Galán. Nada más. Estoy
Nada más que la
segurísima.
parte de abajo va a estar...
¿Pero es de la VH o de la jefatura de impacto?
Tengo tiempo para eso, para el de Javier Medina. Pero estos ya los tengo. Así siempre que mando los días. Ahorita solo voy a revisar con tantos que no me falta ninguna. ¿Qué son las que tiene aquí, cierto, doctor?
Sí, las de aquí de allá.
Las tengo ya.
Hay un...
Voy para allá.
Uno. Uno. 1. Para que lo tengan. No, ese nomás de guía.
Ah, es de guía. Ah, perfecto. Sí, yo creo que en un minuto. Sí, vamos a iniciar puntual.
En cuanto
Muy buenas tardes a todos ustedes. Vamos a dar inicio a las presentaciones del concurso.
Good afternoon, all of you. We will be starting the awarding of the contest that we have of 3 works. We will be trying to assess these 3 works. You will have 10 minutes for assessment of the 3 works. You will have later on 5 minutes for questions. Questions are going to be in charge of the people doing the assessment. And I'm going to introduce right now. We have infectologist Dr. Eric Ochoaji. He is infectologist. He works for Deputy Direction Epidemiology of the National Clinic Institute, Medical Science, Salvador Subirán. And also we have Dr. Alman Moises Santana Rodriguez. He's coordinator of medical programs from the first level attention coordination of the IMSS. And we have these 2 people who are in charge of assessment. We will have the participation, and I'm going to ask you, please, to come here, Dr. Ibrahim Klos Mahmoud. He's going to introduce the work Ecorcinos, preliminary analysis for all the people living with HIV. They live at Rio Grande, Brazil. And I want to tell you, doctor, this is the name of the program, Ecorcinos. This is a preliminary analysis of the geriatric syndromes of old age people, the elderly living with HIV at Rio Grande do Sul, Brazil.
A ver si los marca ahí. Sí, ya está. Bueno.
Buenas tardes.
Good afternoon, everyone. And I greet you from Brazil. I am Ibrahim. I am a family doctor. I'm not an infectologist. Brazil treatment of HIV is decentralized. Primary attention We keep the patients who have 4 ASIMA 350. Those patients who have under 350, they go to infectologists. To give you an idea of my work, I want to explain that at Rio Grande do Sul, and I'm going to show you, this is a state from Brazil where this is a pioneer in research with elderly people, both from Brazil and also research worldwide. So our research is with this target, this group. You have another names of the authors who are coordinators of this program. So we have a very wide team. We have involved some postgraduate students and medicine, nursing students, and we have Dr. Paulo and geriatric, Dr. Rodolfo, a biologist, Dr. Denise. So these are part of the team. To introduce my topic, I want to explain to you that at the present time, in the last 5 years, in the last census at Brazil, we have seen these demographic changes. We have a high number of elderly people living at all the states of Brazil and also in the south part of Brazil mainly. So we were thinking about the sexuality on the elderly and has not been talked a lot about on the works of guidelines, because when we do some research and we talk about behavior managing the HIV patient, well, usually we have this idea up to 55 years of age. And with that, well, we have seen an opportunity to work with this group. Epidemiology in Brazil, so you understand how is that. In the last 10 years, there's been an increase of detection of HIV with people from 60 years and more. In 2021, we have 1.2 men and 5.1 women, and the death rate has been reduced in the last years in all ages, but in between 55 and 59 years of age, and 60 or and over. And why? Why? This is the main idea of the research in the country. The objective of our work is to assess some syndromes, depressive syndromes that are important for clinical practice. What we have are depression, deterioration in cognition, multi-morbidity, and polymedication, and functional deterioration. Now, this survey is a cut longitudinal survey where we try to search for an estimate based on this group and based on the PIB group of England. And we have 110 participants on this study. Now, these data that we have here are preliminary information from the first collection of data that happened in November 2022 to February 2023. In this information that I'm going to show to you, we have some information that shows some variation in Mexico, the geriatric depression scale for showing depression on the patient. We have Almeida, which is a long-term type of scale, mini mental state examination, MMSE. We have the Bartle Index, which is an assessment of functional basic activities of the elderly, and Lawton and Brody, which are instrumental activities. One is more independence and autonomy of the patient. Now here, I would like to show you what is Brazil is a very large country, has a wide territory, and of course the states have different features. As I've said before, our study happened in the last stage on the south, together with Argentina, borderline with Argentina and Uruguay. And this study was taking place there because there was a large amount of elderly, and the research center was located there. And the region to carry on this study is the one that appears in red. This is called Vale dos Sinos. This is a metropolitan region where we have a coverage, wide coverage of first attention, primary attention. That's why we have very reliable information results. So we included people with 60 and over, 54 who live with HIV, 56 of the control group. And I want to explain to you this control group. These patients with HIV, we had a tracking to find out in which region of the cities that were picked, were they located. And so we went there to the health centers, and randomly we found some patients the same age, and we did the test, the PrEP test, that, that my nurse Pierre is going to explain further, which is part of it. And when the test had a negative result, we included these patients on our control group. So the ages of the first group is 60 to 82 years of age. And we have a patient of 65 years old, and she has HIV, and she has hepatitis C. And the patient abandoned treatment, and she was living for 5 years without the treatment for hepatitis C. And 58% of the sample were female and 42% male. Well, you see here the results, main results of this study. We have the poly medication was higher on these people with HIV, morbidity, comorbidity too. Remember that multi-treated patients, when they use 5 medication or more, and comorbidity, the ones that have 2 or more pathology. The cognitive deterioration was higher, and the depression also was higher in this group. So conclusions. Yeah, the GDS and MMSE had very high values on HIV people, and the poly medication and multi-morbidity as well. We imagine that we have this higher data because of the use of different medication. And I want to add that this information are from this transversal part, cross section of the study. We cannot just make a crossing in between, and the reliability or what we have been talking about. What we got by means of this sample are this information by means of a screening that we did before. And you see a photograph here of the team. This is a multidisciplinary team. We have online meetings and personal on this primary attention and specialized services. We have 15 participants under this survey, and peers and nurses, physicians, but also we have pharmaceuticals and gynecologists also in this study. And that will be all. Thank you so much for listening to me. Thank you, Doctor. So, we start with a round of questions. Dr. Eric, would you like to take the floor and pose a question? Yes. Thank you very much, Doctor. First of all, because you're perfect Spanish, I want to congratulate you. The question I have, do you have more detail in regards to this extra morbidity of patients who are living with HIV? You were talking about comorbidity, so I guess that maybe this is related to the type of drugs that they use or related to the poly medication, and on the long run, this might account for preliminary why these patients that live with HIV in this area, they have the worst outcome, or over 65 years of age, they have a high death rate. Do you have more information about this, what I ask you? Thank you. Thank you very much. Well, I'm going to talk about the profile of the sample on the comorbidities, what I can anticipate. of preliminary information is that the crossing that we did of the data, we were relating whether these depression symptoms, polymedication, with the results of cognitive deterioration. We already are certain to talk about that. Some previous pathology, maybe neurological, also were impacting on the data of depression and functional capacity. Dr. Allen. Hi, good afternoon. Well, it's not a question. I want to highlight two important points. Even though this is a cross-sectional type of study, we see the prevalence, the percentages. There is an important area of opportunity because you identified a control group. This allows us to find out if there was a difference in between the patients with HIV compared to those who don't. And we kept the percentage, and we figure out if there was a significant difference. And the other one that I see, and is another area of opportunity for other research, to identify whether these factors that had been described or identified might be factors for other outcome. I don't know, maybe overextension or life expectancy, or we need to see how we can use this information. Thank you for these considerations. Well, other than these results, we are calling the participants every 6 months by looking for those who go to the hospital and the main causes that had taken them to go to the hospital. The future answer is to assess this life expectancy of these patients. A round of applause for the doctor. Thank you. Thank you. Now we invite Dr. Eric da Rosa Lemer, and is the second part of this research, as we heard before, and it's a cutoff. The second work is Ecorcinos profiled with elderly living with HIV, Rio Grande del Sur, Brazil. Ecorcinos profiled of a cohort with elderly people living with HIV on Rio Grande do Sul, Brazil. He says, good afternoon. This part of the survey, this is the profile of the cohort. And I am Eric, I am a nurse. As my previous speaker mentioned, aging of population, especially the ones living with HIV, is a challenge for the Department of Health. In Brazil, we have the fast test that the nurse is applying when the elderly people will come there, and then we apply it. In 15 minutes, more or less, the patient will have the result of this test for HIV, hepatitis B and C, and syphilis. One case of a positive result for HIV. In case of that, we are doing another test from another lab to check that this is the right result. If it's positive on the second test, then it goes to the clinician, and as my peer just mentioned before, we do an assessment of the elderly people and relatives, the family. The main objective of this study was to describe the profile of the cohort of Ecorcinos, and I mentioned this before. This already has been shown, and so well from people who were under this research. Most of them, they are 60 years and over, 54 with HIV, From these with HIV, 83.3% received this diagnosis of HIV before they were 60 years of age. So it's some percentage received these when they were over 60 years of age. Only 19 where is with CD4 over 350 with a very developed in disease. 7.4% they live with HIV for more than 20 years, and 46.3% in between 11 and 20 years. In this population, well, the population is aging with HIV, as we can see, and in this sample of these people, 90.7% show some undetectable viral load and 94.4% CD4 over 350. So they required an ARV treatment. When we compare comorbidities, the group living with HIV shows more comorbidities compared to the control group, and those are the ones that have more disparity: neurology, kidney, psychiatry, and digestive. So sexual orientation of population, heterosexual. Religion is mostly Catholics. And when we see education, well, both control group and HIV, they have elementary school, but not being completed. Only for people, they had a complete elementary education. The civil status of these people with HIV, well, they were, some of them were, the first group was not married, and the second group, they were divorced. The use of tobacco. Half of the sample have never used tobacco, and 33.3% of the former smokers, they have HIV. On the HIV group, there were some people who were using, or they are not using drugs any longer, but they had one time. And the consumption of alcohol, people with HIV, they were having more alcohol compared to the low consumption compared to the control group. Now, the auto-perceived health, half of the group of the sample, they consider that they have a good health. Sexual relations in the last 12 months, half of the sample, they answer yes, and the ones that answer yes, the use of condom, 69%, 69.2%, and the HIV group, and a little bit less on the negative group. And in conclusion, people are aging with HIV, and most of them with a controlled pathology. Elderly with HIV presented a higher number of pathology added, and also it was shown that diagnosis on this elderly population is very late. And it's highlighted the need of new public policies and protocols that might allow to include this profile of age and actions for promotion of health and the multi-professional care for this cohort. Thank you. Doctor, would you like to come here, Alan, for questions?
Hola, buenos días. Otra vez, sabemos que este estudio...
Hi, good morning. We know that this study is very linked to the previous study. The system is the same, the methodology is the same, you're using the same kind of population. And my understanding is that we are assessing a profile of people living with HIV against with the control group. And the main question here is, this identification should help us to identify those factors and again relate them to another end such as an undetectable load. Now, the public policies for detection, now we are saying that we are talking about use of substances and some sexual practices. Is there anything regarding how to use this in the territorial, in the geographical areas? Thank you so much. For by November, we are going to start with the new, we will get new results, and by February 2024, we are going to finish with the new comparison of data to check the final results. In the field of public policies, we have the understanding of the people who have a risk to be contaminated with HIV in this region in Brazil. We have a very wide coverage on community agents, health community agents linked to the public service that know the community and who let us know about behaviors and people with higher risk. Likewise, my namesake, Eric, well, we are namesakes. That's the name you would use, or the term you would use for that in English. Thanks for your Spanish. I know that it is hard. I cannot speak Portuguese, so I'm going to make the question in Spanish or in English, and I can make the question in English, and then we translate it. In general, the people with HIV, since they have constant consultations, they usually have good health in other aspects of their lives. And I am interested in what was shown in the previous work, because it's been seen that there are greater number of diseases, multimorbidity. So my question is about is to know if you are trying to control these different extra diseases that are shown by the patients with HIV, and if probably those patients, compared with the controls, might have a better quality of life since they are being tracked, or they receive a follow-up, or there's a better detection in their diseases, or even a better control of those diseases additional to the ones that were originally detected. Was I myself clear? Thank you. The adherence to the consultation in health service institutions is being studied in other part of the study, where the participants with HIV had a wider coverage with respect to their vaccination, with their vaccines. And now we are assessing the medications in use. We generalize the list of medications in use, one-on-one, and also the interaction of them, and some things like bone densitometry and some lab results. We also assess that in the groups, and we try to have a control group. Thank you. Thank you for that. So now we are going to continue. We are welcoming Miss Ángeles Salgado Jiménez. She comes from the Regional Hospital of Acapulco in the state of Guerrero. It's a pleasure to have her here. She's going to now introduce her research work, analysis of using Euclidean distance in the behavior of lymphocyte CD4 in people living with HIV. Hi, good morning. My topic is analysis of conglomerates in R using the Euclidean distance in lymphocytes TCD4. I am a family doctor. I have a master in statistics and sciences. This is my team. We are national researchers and we live in Guerrero. As you all know, there are 39 people infected. We know that the population of TCD4 in them is very flowing. They are dynamic. We have a mobile populations to the Acapulco port. They constantly migrate, sorry. Why is it important to study them? First, because this is the first indicator of the immunological status of the patients. It predicts the population and the progression of the disease, and it is also used to stratify. And thanks to that, we can make decisions. He is Euclides. He's the father of geometry. All the mathematicians know him. He used to say that the natures of law were not but mathematical thoughts of God. I think that what he tried to say, or well, understanding this in our environment, is that everything can be quantified. From one point to the other, there's just the need of one straight line, and the internal angles of any triangle add up is 180 degrees. The people from that time could only read the Bible and their postulates. That's for the literate people at the time. And the main goal of this investigation is to research the behavior of the lymphocyte TCD4 through a non-supervised learning, and thanks to that, develop methods to economize the system of health in our country. We use a learning algorithm. In this case, it's the cluster analysis, which that is, I might not have previous information of my patient. My patient is in front of me, and I don't know how many TCD4 lymphocytes, because he might come from Cancun or Los Cabos, and in this moment, because of any reason, I don't have the counting of the TCD4 lymphocytes. In the analysis of cluster, what we are trying to achieve is to see the homogeneity in the groups. That is, these clusters, lymphocyte clusters, should look similar, and at the same time they should be different between the groups. Homogeneity and heterogeneity between and in the groups. The classification is like this. We're talking about non-hierarchical algorithm. The analysis of the behavior is a multivariate technique that will allow us to group cases and variables because of their similarity. And our measuring, we will use the Euclidean distance, which is the square root of the differences to the square. That is simple. Materials and methods. We're starting from a cohort of 2,000 patients. We took 142 observations in a lapse of time between 2018 and 2022, and we did that during the R studies. This is the first sample we can see. These are the first outcome of the results. We can see the progress of the TCD4 in time. This is a summary of the first observations. And this heat map can be translated as this. This is a standard of the matrix. The pink part, there's a cluster there. That means that the distance between one lymphocyte and the other one is very short. The goal of every algorithm is to find the better clusters, the best cluster for a smaller variance, and the initial choice of the centroids was done thanks to the people who know, who are experts. In this extract, we can see the grouping by the media case. We can see how the centroid moves through the times from 2018 to 2023. We can see the size, the addition of the squares, and the label for each cluster. This is our metrics for the grouping method, and we can see that what you can read 251, which is the addition of the squares in each cluster. If this is added up with the squares between the clusters, will give us the final addition, which is 564. This is the model I'm going to show you to each of your emails so that you can use it with your own data. And we got 3 different clusters. In this lapse of time, we can see the average of our lymphocytes and the cohort population from 2018 to 2023. As you can see, this looks like an elbow. This is the way it looks. From top down to down, we can to bottom, we can see 3 points where we can see the line. That means that these are the 3 best clusters in which we can group the population of lymphocytes CD4 during time. In this case, we can see this in this map, in this graphic, they organized by colors. And in here, we cannot see very clearly the years, but we can see an evolution. The cluster of points makes progress. And in here, we can see the dispersion and the Euclidean method. And the results. In the conglomerate number 1, there's a drop and raises in the counting of the TCD4 lymphocytes, and this is the cluster with higher levels. In the number 2, the media was 600 TCD4 lymphocytes, but this cluster is very stable, which is important for a study. It keeps a constant in time, and conglomerate or cluster number 3 shows the lowest values. However, we see that there are raises and drops that are very sudden. In conclusion, we can see 3 clusters in 3 years, in 4 years. The cluster number 1 and 2 have the best translation of the infection if we consider a TDC4, and number 3, for medical purposes, require more surveillance since they tend to drop and have better chances to acquire toxoplasmosis or TB. The analysis of the number values of the TCD4 lymphocytes through a series of time contributes to generate savings in the health system. Since the last year, we see a pattern. We have a memory through fractal calculations. And I want to show you a picture which was taken after the Otis hurricane. And how can I use my study if today I were told, you know what, you don't have 200 or 100 tests and you have 400 patients that want accounting of the TCD4 lymphocytes. I can use my data bank. I can use my clusters to get the conglomerate of the clusters and use the TCD4 at the moment based on the numbers and all the previous records. So this can be useful, this method can be useful for decision-making processes. Eric, Alan? Thank you so much. Congratulations for your work. You are the only Mexican woman here, Mexico against Brazil. I'm just kidding. My question is about understanding this method much better and the scope of it. So I would like to have some more details and to know if these clusters represent measurements of different patients in a single time of their evolution, or if they are samples, serial number samples. Let's say I have my sample today, and in 4 to 6 months, I will give another sample. So, are you considering this fact, this analysis, the evolution of a single patient, and at the same time how other patients behave? What is that What does that cluster mean? Because I know that it means different behaviors to predict what's going to happen with the patient that I see during the consultation. If this reflects the behavior of a patient or a group of patients, what is this method like? Yes, thank you. Sorry. A number of time or a series of time means that I saw my patient in 2018 two times and in 2019 two times, and then I have a record of the counting of these CD4 lymphocytes in time in these years. Two in 2018, two in 2019, two in 2020, two in 2020, two in 2021. And based on that, I put it in the statistic package, and I will see the fluctuation of this TCD4 and make a projection or a forecast for the upcoming years in order to understand or predict the conditions of the patient. We know that these are things that the things might happen. Probably this patient, for a very different reason, might see a change in its in the revolution, but we can make decisions in the health decision sector with some certainty. In the public health Ministry of Mexico, we have a mathematical memory based on records, and I think that mathematics and statistics are simply a support for medicine. That doesn't mean that we should go find support in here or a backup in everything. We should always inspect the patient, and if we need to find something more, we should do it. But for decision making with respect to the public sector, we can use this method. Hi, thank you so much for your work. Just as Mr. Eric, I'm trying to identify and understand the methodology of this study. I understand that there are three clusters, and the third one is the one showing this evolution that might not be so favorable. So I understand that there might be a number of lymphocytes, TCD4, run a statistic analysis, and to see if they could be part of one of these three clusters. So far, so good. If it falls in the group number 3, that is a patient that might need a better follow-up or some adjustment in the treatment and so on. The question now is, this, for example, could trigger the identification of the three clusters and probably, I don't know, to run some kind of profile, common profile, in order to identify from the very moment that we see the patient in the consultation. He might have some characteristics, and these characteristics might be a guide that could put them in a very specific cluster. That's my question. Thank you. Thank you. Yeah, this is something initial. This is an initial part of the project. What doctor said is applicable. It could be like installing a risk calculator customized and putting the records of the patient and get a forecast for the patient. The CAM media algorithm is used in many places of the world for against organized crime, for example, in the United States, and they know that by neighborhoods, or houses which houses are more prone to be broken into, since there will be an event or there will be a concert, and that's the way the policy system works based on a calculator. That's what we want to do, but in the consultation, this should be applicable both in public health sector and in the personal decision that we make over the patient. Thank you so much to the authors of these works. We want to say thank you for for your work. You are making a big effort to be part of this second International Congress on HIV. The authors are participating from Rio Grande do Sul in Brazil and Acapulco, Guerrero in Mexico. Thank you so much. This was the first part of the presentation, of the oral presentations. Now we will welcome you to be here with us. There will be some other presentations from 1:40 to 2:50, up to 2:30, sorry. We will be showing three works. Two of them participate for the political and social areas, and one for the clinical and epidemiological areas. Thanks to those evaluators, and that would be the first part of the oral researches.
Bueno, y para dar continuidad a las actividades del
And in order to continue with the activities of this Congress, it is important to mention that our next topic is this. Since 2016, the World Health Organization acknowledged the infection occasioned by hepatitis C as a public concern. Since that moment, the goals, very specific goals were established to set a group of strategy to eliminate the infection by 2030. In Mexico, and since 2017, specifically in the IMSS, we displayed a model for wholesome attention for those patients with these kind of infections. And during 2020, and despite the challenges caused by the pandemic, the COVID pandemic, we published a plan to eliminate the hepatitis C. Thanks to this plan, in the institute, we have set strategies and work lines that are very specific to work along with groups and risk population finding, or trying to find in some of them co-infection and association of hepatitis C along with the HIV virus. For me, it's a total pleasure to introduce Mr. Mark Sukolski. He is a professor associated to the medicine faculty in the Johns Hopkins in Baltimore, United States, where he is also a medical director of the hepatitis clinic in the division of infectious diseases, as well as hepatology and gastroenterology. He is an internist, a doctor in Duke in Carolina of North Carolina, and also infectious diseases by Johns Hopkins investigator. He's a researcher in more than 120 articles related to the treatment of hepatitis C and hepatitis B in people with and without HIV. And he is the ex-president of the group of Transforming Sciences from the hepatitis group in clinical essays about AIDS in adults, and he has been invited to multiple international and national congresses to talk about the topic. He is going to talk about the novelties in the infections in hepatitis C and HIV. Welcome to Mexico City.
Well, thank you very much. It is a pleasure to be here in Mexico City with all of you. And it's a pleasure to travel again after several years of being stuck on Zoom. For those of you on Zoom, I am glad you're with us. Today I'm going to talk about hepatitis B and C. I started my career in 1995 at Johns Hopkins before we had highly effective antiretroviral therapy. And over the past 25 years, we've made tremendous progress, but are still challenged by these viral pathogens. I want to highlight that when we look at the global impact of hepatitis B and C, what you can see on this slide, the global morbidity and mortality from hepatitis B and C is expected to increase and exceeds that of HIV, TB, and malaria. That is because of tremendous investments in both public health and treatment of these other conditions with a relative lack of input into viral hepatitis. Many of you know that in 2016, the WHO announced the goal of eliminating viral hepatitis as a public health threat by 2030. I won't go through these in detail, but one of the key features of hepatitis B is that we have a vaccine. And many of the goals related to Hep B include vaccinating people to prevent mother-to-child transmission, as well as treatment. On the other hand, for hepatitis C, the focus is on treatment because we don't have a vaccine. In both cases, it's fair to say the vast majority of people have not been diagnosed. So finding people with chronic Hep B and C is the primary goal as we think about elimination. And I'm going to talk about the concept of microelimination, that is taking a group of people with HIV, and eliminating these pathogens as a threat to their health. So I'm going to start with hepatitis B. The global burden of hepatitis B is substantial in people with HIV. In multiple studies, it's around 5 to 10% of people with HIV are also chronically infected with hepatitis B. Now, I will say that number is dropping. What we're seeing among younger people, those in their 20s and 30s who may have been vaccinated at birth, is they're not getting hepatitis B. But yet there is still a very high burden of chronic hepatitis B, an estimated 2.7 million people with Hep B and HIV. It was initially not recognized that hepatitis B was aggressive as a cause of liver disease in people with HIV. This study is now 20 years old, but has tremendous impact. What you can see to the right of this slide is that men followed in this study, if they had both HIV and Hep B, the risk of liver death was nearly 19 times higher than if they just had one of these. So HIV alone or Hep B alone did not cause substantial liver death, having them both a 19-fold increase. So that has led to an aggressive approach to diagnosis, and I'll talk about treatment. The recommendation is that all people with HIV should have 3 tests done, blood tests, to confirm the status of their infection: a surface antigen and antibodies against surface antibody and core. And then we can identify where the person sits on this chart. People who need a vaccine will be negative for these. People who have been vaccinated will only have the anti-HBs. And chronic infection is defined as having surface antigen for more than 6 months. So surface antigen is the critical test, and following this with the DNA test is the next step. I do want to mention vaccine. All people with HIV who are at risk for Hep B should be vaccinated. I want to highlight a recent study done by the ACTG in which a relatively new vaccine that has a novel adjuvant, it stimulates toll-like receptor 9, and in people with HIV was highly effective. It's one shot, and then a second one 1 month later was very effective, and then if you add a third shot, nearly 100% of people developed anti-HBs at high levels. So this is something that we're starting to incorporate into our practice instead of using the standard vaccine, using this CpG adjuvanted vaccine that stimulates toll-like receptors. So I mentioned that everyone who's S antigen positive should be evaluated. I want to highlight that they should have a hepatitis B DNA, preferably before starting antiretroviral therapy. Now, I will say that in our practice, we're not very good at doing this. We focus on the HIV, and we tend to forget that hepatitis B is also there. But the assessment outlined here includes an assessment of liver disease. We do not recommend liver biopsy, but instead we use elastography or fibroscan, as well as blood test. We also do recommend routine liver ultrasound surveillance. The surveillance with ultrasound is to look for liver cancer, and I'll talk a little bit more about the risk of liver cancer in this population, but hepatitis B is an oncogenic virus. It's recognized as a virus that causes cancer. So one novel feature of people with HIV is that treatment is recommended for everybody who's S antigen positive. If I were giving a talk on people without HIV, it would be a very complicated decision based on the viral load and the liver enzyme ALT. But in people with HIV, everybody should receive tenofovir plus either lamivudine or emtricitabine. The recommendation is for dual therapy as part of a full antiretroviral regimen. I'll come back to talk about entecavir. Entecavir is approved for hepatitis B, but it's important to know that it also has activity against HIV. I'll talk about that a little bit later. Interferon is an option, but nobody likes interferon. Patients don't like to take it, and for the medical team caring for that patient, it causes tremendous side effects. We have rarely used interferon to treat people with HIV. We instead rely on tenofovir or either alafenamide, TAF, or TDF. And I'll talk about a recent study that was published that compares those two. But first I want to talk about why we need to use two drugs. In the study to the left, they looked at suppression of virus. And the first thing I want to highlight is it's harder to make the hep B viral load become not detected. In the figure to the right, only 60% of people suppress at 1 year, that is those who have high levels of virus. And in many cases, in this study, TAF and TDF were similar, but I'll point to another study done on people with HIV where that wasn't the case. To the left of this slide shows that if you add lamivudine or emtricitabine to tenofovir, you get better suppression. More people are not detected. So in general, we want to use two drugs. But when we look in a cohort highlighted in the lower right, we found that 7% of people had an HIV viral load suppressed, but a hep B viral load that was greater than 1,000. So telling you these two viruses suppress differently with the same medications. I mentioned this study. This was recently published in Lancet HIV. And it took people with HIV who had never been treated for HIV or hep B, and it randomized them to receive either TAF or tenofovir disoproxil fumarate or TDF. And what the study showed, somewhat unexpectedly, since these drugs were similar with monoinfection, is people on TAF had greater hepatitis B viral load suppression. More people got negative, and more people had seroconversion. Now, with longer follow-up, these tended to equal out, and I don't think this study in and of itself is sufficient to select one or another, but it was an interesting observation from a randomized controlled trial. I want to move to talk about the outcomes. the key goal is to suppress a virus. But it is important to note, and if you could suppress virus, you could prevent liver disease and reduce the risk of cancer. So measuring the viral load during treatment is important. But the other thing that can happen is people can immunologically control the virus. They can seroconvert. And that's the loss of surface antigen and gaining surface antibody. We call that a functional cure. We don't call it a cure because we know that in the liver there is active or potentially active hepatitis B DNA called cccDNA that could wake up with immunosuppression or in the case of medications that impact the immune system. So we don't use the word cure, we use the word functional cure. And what this figure shows is that tenofovir suppresses the virus quite well. That's in the figure to the right. This is an older ACTG study, but I want to point out this was the first study to show that tenofovir was better than an older drug called adefovir. And over to the left of this slide is the idea that HIV-infected patients can achieve functional cure. The seroconversion rate or loss of S antigen rate is somewhere between 5 to 15%. What we find in our clinical practice is this test has not been repeated. And I would emphasize that ordering a hepatitis B surface antigen at least once a year to see if the patient has lost the surface antigen would be beneficial. In fact, we're currently screening for a study for people with HIV and Hep B. And what we have found when we actually measure that some of these patients had achieved functional cure, but nobody in the clinic was aware of it because we hadn't ordered the surface antigen test. So I want to talk about patients that don't suppress on tenofovir. This is a patient I take care of who her HIV viral load becomes not detected relatively easily. You can see the hepatitis B viral load was quite high, 922 million. And after 5 years, it was still around 1,000 and never got undetectable. And it got as low as 400, and it had been as high as 1.2 million. So the question that we discussed, and we've discussed this patient many times at our weekly provider meeting, is what's going on here? Well, the first thing I want to highlight is that hepatitis B virus, it is very difficult for it to become resistant to tenofovir. It can happen. And this is a study from Korea where they identified a Hep B viral strain that had developed resistance to tenofovir, but it had 5 mutations that are listed on the slide, quite uncommon. So most people who don't respond will not fail because of resistance. Instead, it'll be what's depicted here. It's incomplete adherence. This looks at dried blood spots for tenofovir levels. And these are all people where HIV was fully suppressed and Hep B was not. And what the figure shows is that in the people that were not suppressed, the tenofovir dried blood spot levels were lower. So what's happening is they're missing doses, but they're taking enough antiretroviral therapy to suppress their HIV. Perhaps it's a integrase-based regimen where the tenofovir is not helping that much, but they're not taking enough to suppress their Hep B. So the very first thing is adherence, and missing doses has a greater impact on Hep B than it does on HIV. And what are the consequences of this? This is a fascinating study from Dr. Kim and colleagues from the NA Accord. They looked at more than 8,000 people with HIV and hepatitis B followed in a prospective cohort study. And what they showed was that if the hepatitis B viral load was not suppressed, the risk of liver cancer increased substantially with an adjusted hazard ratio of 2.7 if the viral load was above 200 for Hep B, and above 200,000, it was a 4.3-fold adjusted hazard ratio. So having detectable virus with hepatitis B is not great. I mentioned our clinical practice. We don't measure this enough. At least once a year, preferably every 6 months, hepatitis B DNA should be measured in people with chronic hep B. You can think about adding entecavir to these patients. Now, it does not make sense to add another drug to a person who's skipping doses. So for my patient who was missing doses, adding entecavir was not the right decision. But if they're taking their medication, adding entecavir on top of tenofovir may be more effective, and that's shown to the right of this slide in a study that they added entecavir to tenofovir and showed additional suppression. It's also important to note that entecavir does have anti-HIV activity. This was actually discovered because a patient in our clinic in Baltimore took entecavir. This was back when we didn't treat everybody for HIV. His hep B viral load was 9 billion. We gave him entecavir monotherapy for hep B. We did not treat his HIV. And what the figure shows is both his HIV viral load and his hep B viral load declined. One of our HIV providers brought this case to our conference and said, this is really unusual. Why does HIV viral load fall? Fortunately, Dr. Robert Silicano was at that conference and took this patient's blood into the lab and proved that entecavir had HIV activity. I love this example because it was a single clinician, one person in the clinic made an observation that didn't make sense. And those observations of things that don't make sense are incredibly valuable. So finally, I want to touch on the issue for hep B with injectables. We are beginning to roll out long-acting injectable antiretrovirals, which, as you know, cabotegravir rilpivirine does not include tenofovir or emtricitabine. It's a hep B sparing regimen. So this patient comes, and he's been doing great for more than 10 years. His liver is healthy, but he wants to switch to a long-acting injectable. Can he switch? Well, the recommendation is that we cannot stop the hep B therapy. So he can switch, but what I tell patients is, yes, you can take a long-acting injectable, but you will need to take tenofovir plus emtricitabine every day. So you're not going to get away from this single pill once a day. So if that's your goal, to stop taking oral medications, it's not worth it. You should continue on oral antiretroviral therapy. Most patients at that time say, okay, I will continue my oral regimen. So what happens if you stop tenofovir? It's been well reported that people can flare. One of three things happens. Sometimes it's a mild flare. Sometimes it's actually beneficial. They seroconvert, but about 1 out of 3 has a flare that can lead to fulminant or liver failure. And people have died because tenofovir was discontinued. So what about the regimen of dolutegravir lamivudine? Is it appropriate to switch somebody with chronic hepatitis B to a tenofovir sparing regimen? Can he take essentially lamivudine monotherapy? Well, we have to go back to some of the older literature. And these studies were done years ago, back before tenofovir was available. What the two figures show is that lamivudine by itself will fail. Just like for HIV, it has a low barrier to resistance, and the hepatitis B virus will escape. And the figure that shows the Kaplan-Meier curve shows that lamivudine monotherapy, they escape more readily. So we don't want to use 3TC alone in this patient population. There's also the potential for inducing vaccine escape. Hepatitis B has an overlapping DNA genome, and when the mutations you get for lamivudine resistance also change the surface antigen, and can produce what are known as vaccine escape variants. And these are some samples of a study that was done in Africa where many countries had used lamivudine monotherapy in people with Hep B, and they demonstrated that vaccine escape had occurred. And obviously that is a public health threat to have a vaccine escape variant spreading. So the DHHS panel recently met and updated a guideline highlighted in yellow that people with chronic hepatitis B should not take 3-TC monotherapy. So I would tell my patient, you are not a candidate to switch. We don't want you to take lamivudine monotherapy. So in that case, we'd go back to this individual and tell them, stay on your current regimen. So I'm going to summarize what I've talked about with chronic hepatitis B. The most important element is to define the hepatitis B status before starting antiretroviral therapy. That's the surface antigen, antibodies against hepatitis B surface antibody, and core antibody. These three tests will allow you to go back to that chart and determine how to approach the patient. Do they need a vaccine? Do they need treatment? And in HIV, or treating people with HIV, the algorithm is very simple. If they're S antigen positive, check a DNA, but you're going to treat them. And the current and continuing recommendations are for tenofovir without a preference for disoproxil fumarate or alafenamide, plus lamivudine or M-tricytidine, with the caveat that once you start therapy, you can't stop the therapy because they might flare. Now, I will say we have had patients where tenofovir became an issue, mostly because of kidney disease, where we switched their HIV regimen and we gave them entecavir. And I'll highlight that entecavir can be used, but it must be used with a fully suppressive antiretroviral regimen. So it is an option, but one that has to be used in combination therapy. Avoiding lamivudine monotherapy, that's a recommendation that's been recently re-emphasized as the advent of these tenofovir-sparing regimens have increased. I also want to highlight that the routine standard of care for people with chronic Hep B is for every 6 months to check a DNA level and a liver ultrasound. There are many studies published that I didn't highlight, including those from our own clinic at Johns Hopkins, that indicate we do not do a very good job of monitoring hepatitis B. So that's not just in any part of the world, it's all over the world where people are treating HIV. The focus tends not to be on liver disease and Hep B because it tends to be very clinically silent. So screening for liver cancer and measuring viral loads. So I'm going to switch now to talk about hepatitis C and review some of the topics there. In 2016, there were about 2.27 million people in the world with both hepatitis C and HIV. I'll talk a little bit more about this, but one of the unique features about hepatitis C in people with HIV is it can spread both by blood and by sex, as well as mother-to-child transmission. Sexual transmission of Hep C in people without HIV is quite rare, but when you add HIV, sexual transmission increases, and I'll talk more about that. This slide also highlights where patients with co-infection live and where the problem is. In the United States, where I practice, we continue to have a substantial problem with people who inject drugs. And this slide is taken from West Virginia, which is right next to where I live, about a 3-hour drive away. And what it demonstrates is among a very small rural community, through injection drug use, Hep C in the light blue entered the community first. So Hep C was spreading, in the community quite rapidly. And then later in the dark color, HIV entered the community. So what we know in people, in populations of people who inject drugs, is hepatitis C is a canary in the coal mine. If you see hepatitis C spreading, you know HIV could follow because of unsafe injection practices. So there's a big emphasis among this group of people, people who inject drugs, to think about PrEP for HIV as well as other strategies. I mentioned the unique feature is sexual transmission, and this has been studied multiple areas of the world, and the results are very consistent. HIV infection plus traumatic sexual practices, some of which are listed in the table, that induce trauma or mucosal damage or bleeding can facilitate infection. So there is no question that among people with HIV, particularly men who have sex with men, Hep C is a sexually transmitted pathogen. The guidelines recommend that everyone with HIV should be tested for antibody, and everybody who's antibody positive should have an RNA test performed. Some people will be antibody positive, RNA negative. That can occur from spontaneous clearance, or it could occur from treatment. Increasingly, in our clinic that I'll talk about, many people have been treated, and they are now antibody positive, RNA negative. They're not infected, but their antibody will stay positive for life. People at high risk should be screened once a year, even after a cure with treatment, keeping in mind that people who are cured will be antibody positive. So if you're going to screen someone who's been cured, you have to screen with RNA testing. And many people recommend that once a year. Every person with HIV and Hep C, an active infection, should be treated. The only difference that I won't belabor today is the need to look for drug interactions depending on the Hep C regimen that you select. Drug interactions are entirely manageable. At times, they require us to switch HIV medications, which is generally not problematic. But it is important that HIV medication switches are done in collaboration with HIV specialists. So, for example, if hepatitis C is being treated by a liver specialist, they need to be sure they're working with the HIV specialist. Although I will comment and say that in the United States, the vast majority of people with HIV are treated by infectious disease or HIV clinicians. I'm not going to get into a lot of studies, although I spent more than a decade of my life doing clinical trials on novel therapies. They can all be condensed to a single slide. And this single slide shows in excess of 95% hepatitis C cure rates, or SVR, sustained virologic response, in people with HIV and people without HIV. The medications are highly effective. When taken every day, they will cure hepatitis C in most people. And virologic failure is uncommon. I'll talk a bit more about that. So this is a snapshot from our clinic at Johns Hopkins in Baltimore. So we asked the question, okay, the drugs worked well in clinical trials. It's well known that medications can look great in a clinical trial, but perform less well in clinical practice. And what this figure highlights is that in our clinical practice, with people who used alcohol, who injected drugs, people who had a lot of comorbid medical conditions, we delivered a 95% cure rate in the clinic, in the real world practice. This has now been observed around the world that in real world studies, 95% of people or more are cured. Now, that isn't because our clinic is so great. It is great, but it's because these drugs are highly concentrated in the liver and there is a forgiveness to them. We treat people for 8 or 12 weeks because we want the cure rate to be 100%. But if you treat people for a month, there are several studies that show you'll cure 50% of people in 1 month. And that means for that person, all the additional therapy wasn't necessary. Now, I'm not suggesting that patients shouldn't take their medications daily or finish their entire course. What I'm suggesting is these medications work extraordinarily well, in part because of their pharmacologic properties, and in part because we're curing, not suppressing the virus. So then we ask the question, well, if the cure rates are so high, can we simplify things? And we conducted a study published last year called the MIN-MON study. MIN-MON stands for minimal monitoring. And what we did is we took people in 5 different countries, Brazil, Thailand, Uganda, South Africa, and the US, and we did just basic laboratory tests at the start of the study. We did a CBC, a chemistry profile, a hep C RNA. We did not do genotype testing. We did not do FibroScan. We used a FIB4 to calculate liver disease, AST, ALT, platelet, and age. We then gave people 84 tablets of sofosbuvir, the entire treatment course up front. We asked them, how should we contact you? Many people selected WhatsApp, and that turned out to be highly effective because it doesn't change with the mobile device. We called them at week 4 and week 22. No visits, no laboratory test, nothing. And the overall cure rate was 95%. In some countries, like Brazil, it was 100%. Patients can do very well, and they really don't need the laboratory testing. So that led both the
Eso determinó las pautas en Estados Unidos para adoptar unas pautas, unas líneas, unos lineamientos más sintetizados. De 40,000 personas que tenían VIH. Entonces, las pautas ahora indican que podemos utilizar un régimen simplificado. No voy a ir a los puntos más finos aquí, pero se trata de un uso de genotipos. No se necesita ordenar una prueba de genotipos, solamente una vez tendría que utilizarse una tableta por varios días o utilizar GP para efectos preventivos durante 8 semanas. Sin pruebas de laboratorio, sin monitoreo y regresar para hacer revisiones constantes. Ahora, se quiere subrayar que esto no significa que no se desatienden las necesidades de los pacientes. Si tienen otros desórdenes, pero se pasa tiempo tratando otras cosas. Pero no es necesariamente enfocarse en la hepatitis C y no es necesario tener profesionales altamente calificados o que sean expertos en hepatitis. Lo que estoy diciendo es que ahora me siento más vacío porque ya no soy más necesario para curar la hepatitis. Cualquiera lo puede hacer. Entonces, un comentario adicional que quiero hacer es que los lineamientos también recomiendan el tratamiento de infecciones de hepatitis C agudas. Aquí esto parece espontáneamente claro. Entonces, algunos de ellos se infectan. Digamos, por ejemplo, que es una persona que tiene exposición sexual alta y su carga viral es alta. Los lineamientos utilizados indican que están bien. Sin embargo, hay un problema. Cuando estamos observando a esa persona con el QFC, pueden difundir esa enfermedad o pasar esa enfermedad a 20 personas adicionales durante ese tiempo. Entonces, la recomendación es tratar cualquier infección activa y los lineamientos indican eso. Entonces, voy a volver al punto de la microeliminación. En 2018 hubo una publicación por parte de Suiza que demuestra, y lo que hicieron fue hacer una prueba de varios pacientes con VIH. Los trataron a todos con una prueba positiva y les hicieron la pregunta, pueden eliminar o prevenir la transmisión, y lo que mostraron es que una prueba que se hizo un año después habían reducido la incidencia, que había nuevos casos de hepatitis C y se había reducido drásticamente. Entonces, esto bajó en un 50% y esto también indica que con el FC y las infecciones crónicas cayeron en 92%. Es decir, se eliminó de forma efectiva la hepatitis C en la micropoblación de hombres con VIH que tenían sexo con otros hombres y fue muy exitoso. Recientemente hicimos esta pregunta en nuestra clínica en Johns Hopkins. Entonces, esta es la clínica Johns Hopkins, y la línea más importante es que aquí todos los pacientes que era positivo, 75% en 2010 tenían virus activo en la sangre. Entre la tasa de positiva que revisamos el año pasado, lo que hicimos fue tomar una muestra de sangre junto con especímenes clínicos, y solo 5% de estas personas estaban en esta condición. El mismo número había caído a 5% con el virus. Vimos la clínica entera y un tercio de nuestra clínica había tenido arritmia en 2010. Hace un año era solamente un 2%. Entonces, esencialmente reducimos el impacto de la hepatitis crónica en pacientes con el VIH hasta 2% de la población. Ahora, vemos a quiénes son las personas que siguen estando infectadas al día de hoy. Y eran personas que tenían usos de ciertas sustancias, que no iban a la clínica, que no iban a sus citas. El VIH no se suprimió. Eran personas que necesitaban esfuerzos extras para poderlos llevar otra vez a cuidados. Gente que fallaba a sus citas o que no fallaba, tenían mejores resultados. Ahora quiero mencionar dos amenazas después de la cura. No hay vacuna para la hepatitis C, entonces si alguien ha quedado curado es susceptible a una reinfección. Este es el cohorte de la Colombia Británica. Aquí mostramos que el nivel de reinfección era alto entre personas jóvenes. Entonces veíamos personas que habían usado drogas, y todas las personas en Reino Unido tenían un mayor nivel de peligrosidad. Y estos incidentes de nuevas reinfecciones eran mucho más alto que lo que era entre las personas que tenían una infección. Y lo que vimos en este estudio fue que ahora teníamos o habíamos visto 7 reinfecciones que ocurrían en algún momento después de que habían terminado el tratamiento. La reinfección es algo que sucede en este tipo de poblaciones. Entonces, ¿por qué es más alto en personas con VIH? Por dos razones. Una es porque es menos efectivo en ellos, se vuelve crónico, y la segunda es que la transmisión es por sangre y por sexo, y para muchas personas con VIH solamente es por sangre. Entonces, la terapia es muy altamente protectiva. El otro punto que comenzamos a enfocarnos un poco, con el que empezamos a enfocarnos aún más, es la idea de activación, de inmunoactivación. Esto es con un grupo de personas que dentro de un lapso de 7 días, lo que podemos ver en la derecha es una respuesta, muestra lo que la gente con VIH tenía. Sin embargo, el número muestra un marcador de activación inmune en el hígado, y las personas con VIH en la zona azul tenían más activación inmune del hígado en el día número 7 que las personas con VIH. Confirmamos esto, que persistía en la sangre al menos 3 meses después. La activación inmune es una cuestión importante con VIH, y podría pasar que haya una persistencia en activación inmune que todavía necesite clasificarse. Entonces, hay dos cosas en las que debemos preocuparnos después de la curación. la reinfección. Y para personas con cirrosis, antes de que se curen, hay una revisión constante para revisar si hay cáncer en personas con riesgo de reinfección y en personas con cirrosis al final de la curación. Otros pacientes no necesitaban otro tipo de seguimiento. Entonces voy a resumir los pensamientos. Las reflexiones son VIH y hepatitis B y C. Entonces, los dos virus se pueden transmitir a través de la madre al hijo, por sangre o por sexo. Son diferentes. La hepatitis B es muy común en la infección por sangre, por sexo o de madre a hijo. Es lo más común. La hepatitis C es un poco más difícil de transmitir de madre a hijo, que tiene un porcentaje mucho más bajo y es básicamente por sangre, salvo en aquellas personas con VIH. Hay una vacuna efectiva. Queremos que nos vacunen al momento de nacer. Todos los niños recién nacidos, todas las personas que tienen VIH no serán inmunes. El control inmune es posible a través de la hepatitis C y con ciertas eliminaciones. Y lo importante que es una de las relaciones, porque la hepatitis C se comporta de manera distinta que el VIH. Y las recomendaciones que doy a todo el mundo tienen que ver con el cáncer de hígado. Es un algoritmo simple, hay que ver la infección si se encuentra tratada y hay que monitorarla para revisar si hay complicaciones por cáncer. Me voy a detener ahí. Gracias por su atención. We're very thankful to the doctor. Is there any question to the doctor?
Sulkowski. I found very interesting the Minmon approach. So the question is, it was taken in some different countries with different economic backgrounds. So my question is, did you see any difference in the outcome for country? And the reason of my question is because we physicians think that approach is quite okay, but some administrative issues may think I don't give you the whole supply because you might not take it or you might steal it or something.
Well, thank you for the question about the Midmont study. So I'll mention a few things. Of 400 people, only 3 people lost their bottle of medication, and we replaced it. That is a concern. But a bigger threat is what happens when you give only 1 month at a time. We know from claims data that 10% of people never fill the second month of therapy. So whether it's 8 weeks or 12 weeks, 10% don't start the second month. So the loss wasn't great. There were some differences that need to be looked at. In countries where Hep C therapy was hard to get, Thailand and Brazil were examples of that, where the medications weren't readily available. Patients really presented and took their medications. They had a 100% cure rate. In the United States, where we'd been using these regimens for about 5 years before the medicines got there, those highly motivated patients have been treated, and we treated a population that was a bit less motivated. We still had a 93% cure rate. The alternative would have been a 0% cure rate. So I do think that treatment, and then the other thing, the last thing I'll say is I think it's a misunderstanding to say that if we're treating someone with active opiate use disorder, we'll spend all our time and effort on the opiate use disorder and give them treatment, but we won't spend time and money on monitoring hepatitis. So it's not to say you just give them the bottle and off they go. We do want to monitor them.
Thank you very much. I'm Luis Soto from one of the National Institute of Health here in Mexico. Two questions. For HBV, do you consider that before starting double therapy for HIV-infected patients, should we perform viral loads, RNA for, no RNA, DNA for HBV in order to discard occult HBV infection?
Yeah, the question of occult hepatitis B, I actually intentionally did not discuss occult hepatitis B because it is it's confusing, both from a biologically, it's hard to know what to do. So occult hepatitis B refers to people with past infection. They may be surface antigen negative, but they are still have detectable DNA in the blood. And what's happening is they have covalently closed circular DNA in their liver, and some of that DNA is being transcribed and translated and made into new virions. But not enough. It's a pretty low level. So typically occult hep B has low levels. And when we've looked for it in our clinic population, it's not that common. And even when it is found commonly, it tends not to cause liver disease. And it's something where 2 drugs probably wouldn't be necessary. So I don't recommend looking for occult hepatitis B, which essentially would mean ordering a DNA test on everyone who's core antibody positive. But I don't recommend that in my practice, although I do have colleagues that do recommend that.
My second question is related to the liver immune activation. Is that related to the general immune activation that the HIV patient has?
Yes, that's a great question. The question is about the persistent immune activation of the liver, and it's something that we're trying to sort out. We don't have the answer to that yet. We do know that people with HIV, that one of the things that happens early in the infection is the integrity of their gut mucosa changes, and there are differences in the translocation of bacteria from the gut. And when you translocate, it goes to the liver. And we think some of that may be from persistent microbial translocation, and we have a few studies that suggested that, but we don't know yet the implications of it. So 2 very difficult questions, so thank you.
Bueno, agradecemos su participación y le hacemos entrega de su
We are thankful for your participation, and this is your acknowledgement.
Bien, continuando con nuestras actividades.
We're going to continue with our activities now. The next conversation is virtual. This will be held by Claudia Montes Cortez Moncara. She is from Chile. The doctor is in charge of the attention of patients with HIV since 2005 in the University of Chile, where she studied in the Faculty of Medicine. She has worked for more than 15 years in the Ariaran Foundation, the first and greatest center of attention to HIV in Chile, and she has been part of member of the consulting in Chile, and she was the vice president from 2018 to 2020. She will talk about what's coming for the anti-ARV conversations. We have already discussed that in the conversations, considering especially the injectable medication. So we're welcoming the doctor, and at the end we'll have a Q&A session. Thank you so much, and go on. Hi, can you hear me? Go ahead, please. We can hear you perfectly well. Hi, good afternoon. Thank you so much for your invitation. For me, it's always a pleasure to participate in the activities of the infectological society in Mexico. You don't know how much I would like to be there eating some cochinita pibil tacos. In the future, I might be there with you. I've been asked to talk about the future of what's coming in the ARV therapies. And this is true for some countries in the world, and a reality for some others in this present day. These are the potential conflicts of interest. And now we are going to share a timeline that describes the different ARV therapies that we have had in history. And we can see that in the history there have been 34 medications, and some of them are already consolidated. Some of them are very toxic, and some things are much better. But at some point, this treatment saved the lives of many patients. But the development of new medication is something that happens slowly and in a complex fashion, and it's also costly. There are compounds to discover molecules, and that takes around 6 years, including the preclinical phase, and then clinical trials with 1 to 3 phases that can take 8 years. And we start with 5,000 to 10,000 molecules and one drug approved by the FDA. So this is a long and complex way, and the medication that we have nowadays are pretty good. Our patients have an undetectable viral load, but we are trying to find an ideal one with the suppression of the virus and can be highly effective for most of our patients, and with the minimum of toxicity, with little interaction, and the detectable viral load should be detectable in time, and with few pills, and with little medication, because we know that these are treatments that will last for a long time. So the less medication you use, the better, or the lower toxicity. And we have this timeline as well. This is what has happened with HIV in the history. Then we are moving to the bitherapy, which was not very effective, as we all know, or dual therapy. And in 1995, when we actually achieved something effective for our patients, and we were able to give the patients with an undetectable viral load for a long time. The problem was that there was high toxicity and a lot of interaction of medication, and many pills in a day. And then they developed STDRs from 2006, and this is the first step to the simplification of the life of our users. One single pill per day in 2019. In 2017, we started with the Integrasa treatment. These are very low with drugs with very low toxicity, and they allow to save patients who were in a fail, that were not happy. Now the goal is that sometimes we can rescue the patient. And 2 years ago, in 2019, we started with these new medications, and these medications we started being used to the dual therapy with different medication. However, there has been an paramount progress. Now the expectation of life of person with HIV in the 90s, in 1995 to 20 years, could live 8 years because basically there was no treatment. Then we raised the expectation of life to 56 years, but nowadays we are basically in the same lifespan or life expectation to someone who without HIV. There are even places where there is a very accessible control. Some patients with HIV have a lifespan over those people without HIV because they have a regular control with the doctors and they have general checkups. That's the quality of the treatment. So why do we need more? If with the medications that we have now, we keep the patients stable and their life expectancy is like the ones who don't have HIV, because we are in a world that, well, we have biological reasons. The people want to enjoy life. There are secondary effects, or there are drug interactions, and there are other problems in group of patients or patients, especially very young kids or the elderly or people with some kind of damage or with cognitive issues of memory to take this medication. On the other side, we have psychological factors which are very relevant. I am tired or bored to have the pills every day. I have problems of anxiety, depression, or I need to take this medication every day, and that interferes with my stability, or simply I want to have other options. And there's also a social component. I want to have more convenient medication. I want to avoid the stigma of a person being taking medication. So these therapies are highly effective with little adverse effects, and we are still making research in other kinds of medication. And how do we want these medications to be? They should be negotiable, and most of the patients should have access for those with low and medium level income. That should be convenient for them, with formulations that are easy to take. Hopefully they will last long time, and then we won't need to take these pills every day, only once a month, for example. We're trying to reach a cure, and the medication that are easy to take for the children. So what are we going to ask for? What's the challenge to the new compounds? Not only new medication, but new mechanisms to get a better distribution, probably with a medication of deposit, or in a way that I can deliver for a long way. I don't know. Not only are we talking about new medications, but new models on how to administer this medication, and they should last longer time. Besides that, we need to include patients and people who are normally excluded from the clinical trials. We always try to find adults, men who are adherent, who are responsible, who don't have other pathologies. And the medications need to be tested in complex populations, people with cardiovascular diseases, with obesity, men, women, sorry. That's something that we need to consider. We need to have a great variety of options for our patients, not only because are we trying to find something, we are trying to have, not only because we have pills, but other options. We have a new step in this timeline. We have long-lasting medication, and if you want to find a totally, I have a very nice source where you can find. This is a website where you can find all the drugs that are the upcoming ones for TB and hepatitis. I follow a very important piece of the information. So, what is long-lasting in the medication? Should terms, it should last 1 week, so that means that the patient should take one pill once a week, that are injectables, and they should be taken once a month, and in implants at least one every 6 months. That's long lasting, and this was defined since 2016 for HIV. Now, when it comes to long lasting medication, that is not something new. It's not only or exclusive for HIV. We all know the benzoyl penicillin that we use in people with syphilis, that is being used for many years, and we also have other long-lasting medications such as contraceptives or different kinds of hormones, and we also have, in a very important number, there are medications for psychiatric purposes used in people with schizophrenia that can last 4 to 8 weeks, and we also have 12-week long-lasting medication. So this kind of medication is not something new in the world of pharmacology. They are only new, only for the people who work with HIV. Also, new kinds of molecules, and this is this is newer. We are talking about nanoparticles. There are also some other kinds of models and antibodies that, along with the drugs, can work well. Probably the particles is the new technology that has allowed us to have these new long-lasting drugs that can require very low volumes, intranucleus or intracell. It depends on where you want to have this action in a very specific tissue. There's a therapy against the infection. This has been great progress that has allowed us to get this long-lasting medication. And what is nanomedication? The production of materials and drugs and devices that are very small, from 1 to 100 nanometers. That is, 1 nanometer is 0.00001 centimeters. So that is, and we're talking about very small sizes, and this gives us a chance to suppress, and we will prevent toxicity. These are theoretical ranges, and thanks to the size, it's possible to get to other places and to keep there in the right concentrations. And we can also prevent therapeutical failures, basically because we have this duration and this administration simplified in gaps of time, which are very much gap. And this is the administration of the drugs. These are the ones in the red circle. I should show you some examples, some patches, some injectables, which are the nice scale of these times, the nanoparticles, and implants. Now, what are the technologies, not the drugs, but how is it possible to administer this medication to the patient with these new molecules? It could be
They are being used a long, long time ago as contraceptives and as a prevention of HIV. And this is another for gastrointestinal problems. This is like a star, and you intake it, and this will take for 1 week, and some other devices, microneedles and pens, and some others that is developing are diffusion pumps as we know it. As for insulin that might be administered with some other drugs in a more regular way. And this is not just imagination. You see the prototypes, the vaginal ring, you see the implant similar to contraceptives, patches with microneedles. You can see the size. They are not hurtful, they don't feel, and this is the one that you intake it, and it's open in your stomach, and it will be releasing medication. When we have a long-term this antiviral medication, we can avoid this lower dose that is more frequent, and we also have the opportunity and some challenges. We avoid this fatigue that we call for pills and less interaction, protection of privacy and the stigma to improve adherence. That's exactly what we are expecting, but there are some challenges. What about these big volumes of injections? If I have to inject my patient a lot, well, we need to do an IV, and this is very complicated. Need to start with oral LI. To start with OLI or go directly from the injection. Should I go first with oral treatment? What about if the patient skips one of these treatments? What about this coverage that we have? And if he develops resistance, we cannot just take out this because it's already there. Management of interactions and also adverse effects that are serious. We don't know what about children and pregnant because we have no studies about it. 2 words on the methods of administration still on development, still or not commercially. The strengths and weakness of implants are removable some of them don't, but most of them, they have a release, which is a constant release of drugs, independent from the place that I place it, might last longer, and some of them are refilled. And the weakness, I need an HCP to insert it. It's a surgical minor procedure. If they are not degradable, they should be released. It lasts like 4 or 5 years. Some of them are refilled, but they have a double regulation as medication and as a device. So these are two different regulating agencies, regulations, and this makes it more expensive. It's going to be very hard for generic companies to invest on that. Patches, which are the ones I'm showing, are small and non-hurtful microneedles, very small, removable, easy to place by anyone. You don't need an HCP, and it's independent from the site. It might last 1 week. But with technology, there's some of this medication, just a few people might be candidates, and they have a double regulation. Let's now talk about the new long-lasting medication, and there are some of them. You see the Partlax, and this is the one that I recommend you this review from Rafa Lagrovitz. These are Binash. We will be talking about this because it's a very broad topic. There are new families. We see DBD-TRA, we see some integrasa, you see them, and this is in the future, and CAPSI, inhibitor, and also the other inhibitors, which are inhibiting all these viruses. And we see also the different combinations. Some of them are well known as these names that you see here. They have a commercial name, and you see them in different stages of development, phase 1, 2, or 3. And you see one that is already being approved in some countries. And I think that in Mexico still you don't try it. We at Chile, it's available already. This is Cabeniva. This is an integras with an analog. And there's a switch of patients with indetectable viral load and might be changed to injectable, could be every 4 or 5 weeks, and might be with or without the OLI, going from oral to injectables, going directly to this. So these are 2 injections, one on a muscular, and there will be a switch, and in some cases it's indetectable. And we have the lenacapavir. This is a new medication, inhibitor of capside, and this is a subcutaneous injection. This is only for multi-experienced patients with multiple failure and should be together with 2 ARB, and so we are talking about just an injectable as such, 1 every 6 months, plus the oral medication, daily use. And what about, this is islatravir. This is another drug that everyone is so thrilled about it because it's very powerful. MOA is new, a new generation. Hype is very powerful, and medium life 120, which was considered to be administered every 2 to 4 months. But now they have to stop development because we see on the trials, phase 2, a drop on C4. So it was stopped for 2 years, and then it was possible to find that it depends upon dose. And this is a drug that is a low dose, and it could not be treated or tried in higher dose. And so it was 0.25 mgs or 2 mgs. And well, we have seen that there were 2 studies reporting all these, and there is an implant from titanium that is being used and is biodegradable, subcutaneous. And also the dose might depend upon the patient. There are some trials, and it has already been approved. And there is another one, which is a controlled study, phase 2, for randomized and open for population is PBBHI, and it's comparing TAF with FTC and BIC, and this is for at least 24 weeks. And we have a low dose every week. This result still is not known. We will have it very shortly at the end of this year, and maybe there will be an analysis. That will be the oral week therapy, ISL plus LEN. And this sounds very interesting. Now let's go to another a new one. Antibodies, which are now being used for prevention, primary vaccine, for treatment, and even for many other things. This is the only antibody that is being used by BNABS, as it is known, which are neutralizers, and it has a 121. More than 100 BNABs are being under study. There are many studies that are being made. They have lower toxicity and long-lasting for 6 months, and immune response very fast, depending upon the virus that might be there. So it's required a test to know which BNABs might be used. Antibodies used to prevent these type of infectious diseases are not new. They are used for measles if we have, for example, a pregnant woman, and it's been used also for polio, and also had been for CMA and for hepatitis A and B, and for children, and also prematures with BZB for pregnant women. This is not new, but the problem is that HIV is changing a lot. Not all the monoclonal antibodies are used for this part. The studies are showing safety, efficacy, but it's hard to predict the baseline sensitivity. And also, we have all these systems that are big volumes that should be IV, that might last for 6 months, but they are being used directly subcutaneous, might be even in 6 months. They're as long-lasting. And they have a vaccinal effect. They boost the immunity of the body, so the immune system should be outweighed to increase amplitude. It's not being neutralized, and it has a plasmatic life that is longer. The antibodies, which are very strong, are wider, multi-specific, and it lasts like 2 to 6 months, subcutaneous administration. There are some studies that are on phase 1 and 2 with retrovirals as well. And here you see which are the most interesting, the ones that have more information. TAB, that I talked about this before, but PABIMAP and Silibimab, ZAB, every 6 months. This is a small trial for one patient, phase 1, so small. We see safety first, and this is a blind study, and we have to see how is it working. It's been randomized, and after 26 weeks, we see how many patients have undetectable viral load, if they have plasmatic concentration, safety, and tolerability. And what we have seen on the first report, every 6 months, CD4 was stable, concentration, seric concentration was the right one, and also there was a susceptibility, which was good. It depends upon the virus, as I was saying. And there was some recovery of the TAR initial, no adverse event, and mild events that we can see, especially when they are being injected, and also one edema that happened for one patient. And if there's fever that is related to it, well, might be something mild. It sounds it's doing well, but still 2 years more to see the result. If we see the virological efficacy, there was a suppression of 90%. Remember, these were 20 patients. Yes? So this is good. You cannot read this, I'm sure, but I'm showing that they are so much BNAbs in different stages. On the stage 1, 2, and 3, and they are coming into the future, many things. These are studies done on animals, and they are preliminary, also on monkeys and also rats, and you see nano formulations that had 1 year they last, and that can improve their efficacy, as I was mentioning you before, ultra long-acting medication. But which are the barriers? What's the problem with this medication? Knowledge first, because the HCP, they do not know about them. Patients should be willing to use it. Implementation, what is available now, and requires a cold chain and to be affordable. What about these health systems? Who's going to pay? Because it's very high cost, and insurance of public health services, they want to save, private companies want to save. So it's hard to know. And there are individual habits of the user. But I will say that the main barrier is cost. We have to try to see and to get generic drugs, or that the pharmaceutical companies should make these prices come down. I know that it takes a lot of money to do so, but we have now these injectables and should be affordable for many people. What's the support that we can provide with a TAR long-lasting treatment? Well, primary population. If I am seeing I'm doing well with one pill, undetectable, I follow treatment, I have no problem, I'm happy. Well, I'm not a good candidate for injectable, but if I hate to intake pills every single day and I want to take it away, I have problems to swallow, and well, I don't feel good, and I follow treatment, but I have to, maybe I can offer this patient an injectable therapy, considering that our patient, which are under good control and they go every 6 months to the doctor, in this case should be every 2 months because it's an injectable. Injectable should be done by an HCP. These patients, they have a viral suppression, that's a change, and so in some countries that has been approved has been shown that, or had shown that we have a small buffer in time that the patient might delay 1 week or more, so in taking the pill, and to bring injections, or in this case to have more places where patients might go and have the injection, not to make him come to the clinic. Sometimes I don't have the right place or the right staff to provide the injection, maybe at a drugstore or in another place, a clinic, and well, additional population, they need injectable therapy because they cannot intake the oral one, or they have a problem. So those are the ones that might be candidates. What can we expect? New medication in the future, in the near future, but to extend the offering, and ultra IV, subcutaneous, muscular, and also injectable new MOA, and to get out of these 5 families. We have been there, long-lasting injectables and monoclonal that still are on development, but they sound like a big promise. And of course, all these with more availability for people who might need it. And I want to take an opportunity to thank all people who had been made this possible. So thank you very much. Thank you very much, Dr. Cortez. We know that you have a very tight agenda and you have room to participate here. We open the floor for people who would like to pose a question, taking this opportunity. Doctora, from the multiple barriers that you mentioned before, just implementing it in Latin America, which do you consider or believe it's higher? We know that affordability is important, of course, but the lack of knowledge too? There's a lot of new hires that are treating people with HIV, difficulty of health services to have all the right assets that we have as injectables coming to treat HIV. In Latin America, which is the main barrier that you feel is there to be able to, that might keep injectables to be there? Well, money, as you said, that's the most important, affordability, because it has a very high cost compared to the oral treatment of good quality, generic or originals, TDB. This is a good tool, but we need to switch to injectables with the support of industry. They have to understand the need there is to reduce the cost and the support of the organization of patients and other organizations to create pressure to the system to make all these injectables available. At PrEPs, we know that injectables are much more efficient than oral treatment because of adherence, and it's been short, but with injectable therapy, I guess that it will have a very good effect in terms of adherence. And this will help us to cut the transmission chain. Once prices are down, I think that implementation logistics of injection would be a step that is much more simpler. Pharmaceutical firms are developing all these subcutaneous, long-lasting drugs, and this will make logistics easier. But the main barrier is cost, price. Is there any other question from the audience? Yes. Microphone, please. Oh, you can come to the front and use the one we have here. Okay, maybe you might use this one. Yes? Can you listen to me? Doctor, well, thank you. Thank you. It has been a very interesting lecture. And by mentioning this part. Hi. Oh, yes, now I can listen, doctor says. Thank you very much for your presentation. Wonderful. And by mentioning this part, that adherence, I think that this is a main problem or helps for the development of new technologies. Now, thinking very optimistically, by developing these new technologies and reaching a point where all the HIV patients to have this treatment available, in 100 times, if there are no patients with HIV, the development of these technologies might not, since this is very pricey, to reach a point that if there are no patients, there is no one to apply it. Well, she answers, I wish we can end this pandemic or epidemic. There are just a few epidemics that had been eradicated and suppressed. But actually, the others are being there. But I think that as long as the patents expire, there are new generic medication, this will reduce cost. Now we have access to a new TDB, which is less than $10 a month, and this has allowed to improve things. So yes, it's true that when these conditions decrease, well, they are less appealing for the pharmaceutical industry, but we are far away from that. Thank you so much. Another question? Well, doctor, thank you so much for your presentation, for being part of this Congress. I hope that you can, in the future, come here, and we give you a round of applause. Thank you. Thank you. And as I was saying, I would like to be there, and I will eat my cochinita pibil tacos. Yes, of course. Thank you so much. We have 2 notifications. Well, in the program, we have a recess, a break. We have a small lunch, and we will be back at 3:30. And we want to remind you that tomorrow we will start at 9 a.m. We start with a big, very well-known speaker. So please be on time tomorrow. Thank you.
Cuando ya tienen 10 años ya no hay problema, pero los neonatos, pero bueno, te la pasas en el consultorio, pero por lo menos ves esa decisión, ¿no? Y esa es una cosa que les hace falta. Y peso, y ganancia de peso. Está perfecto. Es extraordinariamente interesante. Extraordinariamente interesante. La única cosa ahí que te sirva de comentario un poco. Única preocupación es la situación de los pacientes. Esa es la única. Vas a hacer un proyecto desde el punto de vista todo lo que quieras, pero eso depende de que selecciones bien a los pacientes.
Buenas tardes. Hola. Hola, hola. Hola. La presentación del doctor Soto. ¿La tenemos?
Jaime, do you feel okay? Jaime.
un gran apoyo.
So we receive our next speaker. Okay. Thank you so much. Thank you so much for this presentation, Ivan. Thank you very much. Dr. Treviño, Dr. Vega, many of my peers. We have been working together for a long time, and we are meeting very often on different events. I don't know why they have so many events at the end of the year, but we are very close to these big celebrations. Now, my task is a little bit hard because I have to talk about everything you wanted to know about sex, but you never dared to ask. But just take out sex and let's talk about resistance. So I'm going to talk a little bit possible the conflict of interest because I work with different pharmaceutical firms, molecular biology, antiretroviral treatment. Basically, this is what I'm going to talk about today. Some generalities about resistance and resistance, which is transmitted. I'm not going to focus more on that, but I will talk about the relevance it has in regards to this resistance and some problems that we have had with the interpretation of genotypes of resistance. And an important point, which is what we are seeing now of INSTI in first failure resistance. And then we will go to the last part that is multi-treated patient, multi-resistant patient. This is an outlook we don't want to reach, basically, because we don't have so many choices yet as the ones that the previous speaker was talking. And many of them still are not available. Some of them, we are not going to have them. And some of them are going to have the barrier of the cost, the price. And I'm going to show that. As you know, worldwide, we have around 300 million people that are under retroviral treatment. And undoubtedly, the advent of very powerful medication, very robust medications, and I will talk about that part in detail, what I mean by soundness. It will take us that resistance has been reduced very importantly in countries, developing countries. But that is not the story for all the rest of the world. That is not the story, unfortunately, for Latin America, where we have been exceeding resistance rates to Africa with this policy that African people have of generalized treatment with dolutegravir. So the disappearance, scheduled disappearance of experts on resistance, still is not happening. Fortunately, that's why I'm here yet. Let's keep on seeing that. Now, this is a work from a team, a group that at the Nutrition Institute, where clinics, and I want to say very specialized clinics on different countries of the world, I mean, different countries of Latin America, they claim about the failure rate in the first scheme. Let's see how these failure rates that are so high. And of course, not all of them are because of resistance, but a very good part of them they are. This takes us to this, let's say, the scheme that I have seen for a long time. Medication who have not have full power, because still we use medications that are very old, obsolete. We were talking before with Luis Adrian about sakinavir, some patients that are using sakinavir. These medications who have not enough power, and some of them that develop resistance, that is the transmitted resistance, or that a patient is not taking them well. Remember, in adherence, it's better not to have a pill instead of having it one every other day. And the weekend I won't, because that's where we generate resistance. Everything that has to do with a poor power will take us to a viral replication to the development of resistance, and so we will see this in our viral load as virological failure. And this is a term that is being used that way. Why this resistance is generated? As I always mention, there is the egg and the chicken, and you have to see the hen. You have to have a selection of the medication together with mutation, because it's a very high rate of mutations going on of the virus. Every time that the virus is replicated, there is one mutation, not necessarily resistance, but one mutation, so that there is a big amount of viral variants that we call quasi-species. Nobody almost speak about quasi-species, but this generates resistance. A problem that that we do have with resistance is that so far, this is a consequence that is irreversible of treatment. Irreversible. A resistance that you generate, it's going to be there on a patient for life, even though there are 20 years of indetectability, still is there store, is kept there, as Dr. Sulkowski was saying, talking about antibodies against hepatitis. Even though it's been cured with the treatment, antibodies will remain so. This is a memory. Well, it is exactly the same thing. One of the big issues of resistance is that still is being there stored and will be accrued and building up. The other big issue is that it develops cross resistance. And well, this is not totally absolute, that resistance in general are crossed with members of the same group of action of medication. There is a cross resistance in non-nucleotides and the protease inhibitors. And even though we have some phenomena of resistance in one region, as might be transcriptase reverse, might affect proteasa. But every single day we are learning more and more, because if human beings, especially Mexican people, we can make up everything that you can imagine, well, the virus will do the same thing. Not necessarily in a perfectly ordered way. Now, the genetic barrier, and I'm sure that many of you will agree, this barrier was set with lopinavir. One of the researchers of lopinavir claimed these patients are failing lecanemab, how many mutations we need to add lopinavir. And so I'm referring to the number, even though the number will be important and the type of mutation. But if they only have from 0 to 5 mutations, still lopinavir was working well, but more than 8 mutations, it did not work so well. And we call it genetic barrier. If you see this drawing made by Buck Schaefer, the author of the database of resistance of the University of Stanford, what you will see is that we see on yellow the integrase second generation inhibitors, which actually they don't have so much genetic barrier, because with 2 or 3 mutations of previous use of other integrase inhibitors might not function. So, well, but from the labs or pharmaceutical firms claim that they have a very high barrier to resistance. Yes, but the way we have been working about is we need to talk about soundness. Soundness means when you use, which is a concept of resistance as well. Soundness is when you use this medication for the first time. I'm using bictegravir, dolutegravir for the first time. It shouldn't be any mutation unless there is some transmitted resistance. But how long does it take? High soundness medication, it takes as much as I want, years to develop resistance. So, well, it's true These are medications that protect a lot against resistance. Well, if you want to add the name of soundness, it's okay, but genetic barrier is okay. What I care for is that sequentiation of these integrase inhibitors had a lot to say. You will be listening. Now, another concept I'm interested in to be able to talk about transmitted resistance is primary, secondary resistance. Secondary is very easy. Secondary resistance, I use medication and I will generate resistance. But primary resistance is a resistance that is being generated spontaneously by the change of virus because of mutations, or that it was acquired somebody at the time of event of transmission, whatever, transfusion, a contaminated needle, a sexual relation that has not been protected, any of that might be acquired, the virus might be acquired. And that's what I call the transmitted resistance, which is within the concept of primary resistance. As a good, far-sighted person, a person who had the advantage of being able to retire with good money, Dr. Harrigan from British Columbia, and he was claiming since a long time ago, because this is 2014, that there was going to be a switching between resistance 1996, which was secondary, after the use of the medication, to resistance, which is more primary, 2014. And this is clear in countries with high purchasing power. Maybe not as much as we have here. So there's this concept of transmitted resistance, and I want to add here the work made by Santiago Avila from INER of transmitted resistance 2015, and this is a work that is being submitted in several countries of Africa from WHO. This is a high rate of transmitted resistance to efavir, to non-nucleotides, and that may change this treatment at every level, because Africa has it, the rest of the world, we do have it, and we do have it here with the availability that we have for a combination of betigrabir. So it may change history. But if you realize here,
in these boxes that you can see in the bottom, you will find the resistance of America and Africa. But Africa, as I was saying, is decreasing. It's over 10%. But if you dissect it and analyze it with the integrase inhibitors and specifically about lutegravir, it's 0.2%. That means that there's little resistance transmitted. Probably with the non-nucleosides, we can reach up to 15%, which is far lower to the integrase inhibitors. Unfortunately, there's information and there's data in places where this has been used massively. For example, in Brazil. Brazil, in just 4 months, increased 100,000 patients. And what you can see in a report from my friend, Mr. Diaz from Brazil, what you can see here is how they, with disseminated use of something mentioned by Claudia, the TLD, which tenofovir lutegravir, see how they can reach. This is very little, but it's not that 0.2 that we had been told. They can reach up to 1.6% of resistance transmitted to the inhibitors of integrase. This is something that we need to pay attention to, and we need to follow it as well. It won't be a phenomenon such as the non-nucleosides, or it will increase dramatically because this medication is more powerful, and especially because in general, when they fail, they have viral loads that are not that high. They control replication or viral replication, and the secondary resistance. Well, I just show this example just for your information. This is the number of patients that show resistance to 4 different types of medication. We have more than 4, but they have a resistance. This has decreased dramatically in places with high level of resources. Remember, I'm not going to take longer in here, but remember that the resistant trials are not perfect. They don't detect population under 20%. And for that reason, if I see or I find resistance, it's very possible that the scheme might not work. But if I find susceptibility, I'm not sure that there will be strains as resistant as it can be found in some minorities. And a phenotype that has failed 3 times won't tell you the whole truth about the people in the back, because this was kept since there was not selective selection. The genotypes won't solve the whole problem. The problem is solved by you as the experts and thanks to the patient's file in order to find out what happened before. Finally, I want to be clear on this. This has changed. Unfortunately, we are not using it that well. Genotypes, sorry, are perfectly documented. They can go over 500 copies and between 200 and 500 based on the new guidelines of the EA, and that's very possible. We have a rate of amplification of a genotype over 73% when sometimes they are under 200 copies. I mean, it is possible. It's under 500. You are not going to be like under 500 or 1,000. I won't be able to amplify it. Now, what's the other problem? Who is going to make the interpretation of it? Okay, send it to Mr. Soto, but Mr. Soto cannot interpret everything, or Mr. Avila either. So who's going to interpret that? The problem is that the algorithms for interpretation are very are very different, and there are not many, and they are very different. If you use the Stanford base, and instead of using the first side where you can select, you can go to this AAL program, and what you can get here is a comparison of 3 different algorithms. Unfortunately, the one to your right, which is from Belgium, hasn't been updated. But they have at least the Stanford logarithm and the ANRS, which is a French agency for research. And what I want you to see here is how, for example, a single mutation can, in an algorithm, be intermediate and in other one be resistant. I'm talking about a very complicated mutation, which is 263K, and you will know why I call it complicated. Fortunately, in the clinical trials, once you start using in the first line integrase inhibitor, the failures are very few and show no resistance in most of the studies that you can read. And this is something that provides this robustness to this kind of medication. However, nothing is subject to be totally successful. And see the report of the ample use of lutegravir in different parts of Africa, and how the mere viral control can be only seen in between 74 and 78% in patients using dolutegravir. 74 is the lowest limit. So there are patients that somehow are not responding, and there are some other patients that do this with bictegravir, and after using it, they have a bounce of a viral load, and they have 2 kinds of mutations, which is 263K and 184V, which is for ricetabine. This has been reported extraordinarily. Fede Garcia from Spain, for example, has done this first report in 2020 in a patient who had other antiviral schemes and changed it to bictegravir, something that doesn't sound so weird in many of the scenarios in our country, and check how they developed this 263K and reviews other 3 cases besides this one where this mutation is found. There are very few cases. Yes, but they do exist. I cannot say too much more about it, but I can tell you that the evidence that this is actually happening in our country will be shown in an oral poster presentation, in this kind of presentation in Kroll I was accepted to this kind of work, with this work, so for you to understand what's going on. These are very low numbers, but it does exist, as I said before. So we need to be careful, even though these medication and combinations are extraordinarily robust, we need to be careful with them too. A little bit about what you can see here in Brazil. Check Ricardo Diaz with the combination of TLD. You can see these failures and see how interesting is this. One of the mutations with the most frequent mutations, there are very few. Imagine all those patients with TLD in Brazil. It's nothing. It's very little, but it's for 113 patients, and 4 of them had 273K. The interesting here for Ricardo Diaz is that they found a lot of this combination of mutations that produce, and according to in vitro studies, show discrete resistance to the integrase inhibitors of second generation. That means that resistant bias could be different. One thing that is interesting here is that it seems that we don't know everything about the resistance to inhibitors of integrase. Why? Because we follow this mental train of thought that resistance should be mutations in integrase. However, for a long while, it's been discussed, other mutations have been discussed that can be associated to resistance to the integrase inhibitors, such as the mutations in a region of polypurines that can be found in the extreme of the virus. And that, Ricardo Diaz in Brazil has been able to detect, after the use of dolutegravir, 6 out of 51 patients with these mutations in this region of polypurines. More recently, in CROI, this year in 2023, in 30 CROI, the report for in vitro studies has to do with patients that accumulated mutations. Check. This is 263K. Sorry, it's not patients. Sequential steps in vitro. Sorry, this is not in vivo, this is in vitro. Sequential steps in vitro. And what you can see is mutations in the integrase, yes, of course, mutations in the nucleocapsid. Of course, there's a second side, but the third one that is actually surprising, mutations in the cover. And this is something that is actually surprising, and this group of Japanese researchers could actually provide documentation on these mutations on the cover, or the code, which are very difficult to amplify because the cover is very variable. They could increase the change of dolutegravir up to 2,000 times. So that would be 2,000 times the normal concentration. So there are things that we don't actually know. I'm going to skip these conclusions because this is something that we have reviewed. Now, we are going to be talking about the multi-resistant patient. First thing, we need to try to define this kind of patient. The problem is that there are definitions of 2 different kinds, which are very interesting. This one that is from Eurocida, and other one from the Court Opera. And the problem is that the definitions might not be very clear. There might be a failure and resistance over 3 classes, the use of dolutegravir in a double doses, or uses of dolutegravir twice a day, to call a patient multi-experienced. There is no clear definition about this. And why do we have these kind of patients? Because some of them have gone over all the history of HIV, and we know that they started without treatment with monotherapy, then we used DDC and DDI, DDC and 33C. I know that more than one of you will say, what is that? That existed, and it was extremely toxic. And then we started with therapies, and then we had a new one, and then we added it. And instead of changing the whole scheme, we added it. So, of course, we have created patients with multi-resistance. See, for example, this in another prestigious group of study, there are patients that they have in the rescue schemes have up to 4 kinds of medications because there are no other kind of medications, even though what Americans report and what Europeans say is that the number of patients in multiple resistance, highly experimented, is lowering, as you can see in this curve. And the other thing is that these multi-experienced patients can be taken to undetectability. That doesn't mean that someone with multi-experience can go home and say, well, you're going to die. But instead, this means the use of new medication, and I'm going to talk about that in just 1 second. Anyway, someone who is showing resistance to the 4 kinds of medication has more chances of dying and morbidity. Let's not forget that. We can create some kind of monsters, little monsters. But in this other one, for example, in this database, ARCA, which is also Italian, we can see that the ones that show resistance have kept in the 3 last determinations. And in that cohort, what is that associated to? Well, to men, to viral loads, basal to the beginning of the infection that are very high, or other that are very low. Some we are still receiving, and the diagnosis of AIDS. If it was a diagnosis of AIDS, that means that the L4s lowered. Number of medication and the history of exposition to integrase inhibitors and other entry inhibitors such as Maravil. So, this is the history of patients that show multi-resistance. And this chart that you will see in your reference that is actually old, from 2019, from the DHHS. For us who don't have so many other medications to use in patients with multi-resistance, it's still a basic. Why? Because we are told, okay, what's going on with the resistance to the IPs, the resistance to the integrase inhibitors, and according to that, we will try to build with the greatest number of active medications. So what does HH say? We should try at least with 2 or 3 active medications. So you can be totally sure, about a totally active medication? For example, I have a patient with 3 protease inhibitors, and now he was using one without a protease and no mutation. Are you sure that this person or that the vulnerability is totally active, even twice a day? So we need to run some genotypes. This is not applicable to you, but just think of the way basic answer. We were given the chance as a lab to have 70 genotypes every month to different states in the country. You know how many we get? 13. And when we say, okay, that's because they are not failing, and we are told that they were failing, but they didn't send it to genotype, or we have a blocking agent in CIDA that won't allow the genotypes to be done. So, of course, how can we find if it is active? Well, we don't know. The other thing we are told is that you should use the new medication, so the sofranavir, lenacapavir, ivalixumab. Oh, yeah, that's great. We will try to use them. But what is clear, and this we were told a study as the benchmark and some others, not only the benchmark, is that the more medication, the more active medication, and the better the treatment works. My recommendation for you to do, and it's not something that I do, is to find out if there's any kind of active nucleoside or mononucleoside that is also active. If we only have Budenavir and needs to be used twice a day or once a day, if there's activity in the integrase inhibitors and other medications such as Malaviroc and Infuvertida. So we need to use nucleolysis in the advanced rescues in multiplex rescues. Option says no. However, Nadia, which is a study of not multiple rescue but first failure rescue, we were told by it that it was it didn't matter if they were rescued with Dorum or Narinarito. And we were told that even though there was resistance to tenofovir as with case 65R, it worked the same way. So sorry, but I still think that the case 65R is it worth less than the value we had considered for it previously. But I won't talk about this. However, I think that if there's activity and you need some kind of extra activity, a great researcher, which is statistics, has proved that the medication with residual activity are the nucleosides. And for me, and I tell you this honestly, as I have said before, tenofovir, for example, from the tenofovir family are the only real medications that can be recycled. But we can use a nucleoside. It all depends. They say that resistance to this non-nucleoside is quite low. However, in a study that we showed in AIDS in 2020, we saw that the resistance was pretty similar in its numbers between doravirina and etravirina. However, in some patients, it was doravirina was better, and in some other patients, etravirina was better. This study, actually, we were checking the last pieces of information. We increased it to over 20,000 to 2,000 patients, and the results are pretty similar to it. And what can we use? Once a day with ivermectin, darunarito twice a day for those. That's the purpose of this algorithm. If you find more than 2 mutations, then you should not use it once a day. And if there are more than 4, not even twice a day. Now, what were we told back in 3? And he showed us how when integrase inhibitors failed, a number of mutations generated with a complex of the position 148 that decreased significantly the activity of dolutegravir, even though it was used twice a day. Pay attention to this. So, this doesn't mean that we can use it twice a day. Sorry, it doesn't actually mean that we need to use it twice a day and it solves the problem. And this is my next question. So how can I use Big T twice a day? Because it comes in a pill and I don't want to use tenofovir and dexacitabine. Dr. Jose Luis Blanco from the Clinic of Barcelona showed us information that supports clearly that for bictegravir, it's not necessary to use it twice a day. The activity, the affinity against the white is that big that it's not necessary to use it twice a day. But the main question is, and what about the ones that we saw with 263K? There are few. They are very few. However, the ones that we are accumulating, how can I sequence them if ARN says that they shouldn't be sequenced? And actually, most of the people who know about it say that if you have a 263K, you better not use other kind of integrase inhibitor. This is just a chart that I want to show you. There are many committees, resistance committee using the combination of darunavir reinforced with dolutegravir in order to rescue patients in any moment. And it's been quite used. Actually, we have little experience with the dual studies. They seem very good, but we should see the criteria. And what are the new molecules we have? I'm going to show you this very quickly. We have entry inhibitors for such as fostemsavir, and this is a study of ivalizumab that gives us 96% per week of efficiency. That's pretty good. However, you need to do it injection in the veins, and you need to bring in the patient every 2 weeks. Then we have fostemsavir, which is work even when there are very few active medications. The ones that work best are the ones with other active possibilities. And for those who are old enough, this is the same the one that Fubertina had in their first trials. And of course, lenacapavir. The truth is that we are all waiting for lenacapavir anxiously. Why? Because lenacapavir, and I won't delve into many details, not only does it act as one of the part of the viral cycle, but also we have seen that it actually acts in three different parts of it. And the responses in patients with multi-treated up to 82%. Sorry, 78% with less than 50, which is marvelous. All this is pretty nice. Islatravir, as the Dr. Claudia said, we don't know yet what's going to happen with the toxicity of CD4s. And now these are the costs that I have found. I don't know. I don't work in the United States. These are the costs that I found. Ivalizumab, $118,000 per year. Fostemsavir, $4,700 per month. Lenacapavir, $40,000 per year. Hopefully, some of you will be Secretary of Health for the next term, and you will be able to pay this treatment. And, well, just to finish, the incidence of multi-drug resistance or multi-experimentation has decreased very significantly around the world. However, if any site has more problems, is Latin America. Every case will need a customized perspective, try to use the higher number of active medication. Be careful, I insist. The active is not the one that is in green in the genotype, is not the one that is in green. There are new options. Well, of course, we want them, even for the compassionate use. Unfortunately, they are not here yet in our country. And even though I'm not seeing, I don't see too much because of the lights. I don't see Dr. Trevino. I can tell you that one day she introduced to me, just as he did. It was a pleasure to be introduced. And she said he is the only doctor that sleeps with the virus. I still sleep with the virus, but now I'm worried for other kinds of resistance. And I'm very thankful for your attention. I think that the presentation was quite clear. And now we are going to open the floor for questions and answers. For Mr. Soto, go ahead. They are testing microphones. As usual, Mr. Soto, it's a total pleasure to listen to you, and especially with this topic on resistance. Oftentimes, it's very hard for people living with HIV when we are facing adverse effects. And nowadays, the comorbidities that we are facing will kill us. It's not the HIV, but comorbidities. And in this sense, I have two questions. Is there actually a cross-resistance? Because oftentimes, it seems like we think that there is a policy of detectable or not transmittable or not communicable, and something that we are oftentimes told is that there is a transmitted resistance. And the second one is, what should we do when one person is still failing and the treating doctor says, okay, and with this absurd comment, I'm not going to switch it because we are going to remove bullets. And if I do the switching, then you won't have anything. And what you said with the example of sakinavir, it's pretty tough or pretty rough that there are still patients with sakinavir because the treating doctor said at some point switching should not be done because it was like burning bullets. Or the other one, people who decide to have a lot of medication at store to fight the replenishment, and they are changed to Integravit, but they still use Trada plus Cefarivent, and they have great issues because there is no interaction to improve the relation doctor and patient, and we assume that the patients take this because, well, they actually take other therapeutical options because they have a great number of medicine that they have stored during the years, and first they want to run this over because the doctor says that first they should finish their first option and then second options before switching. Thank you, Luis Adrian. It's always a pleasure to share information with you. Now, for your two questions, I will start with the second question. I will come back to you. If you have the chance to buy, even if you sacrifice the car that you want, the consulting office, you do it. You don't know if you will be here tomorrow. That seems to me the greatest absurd using this kind of argument. You are going to save bullets. Let's remember that the resistance does exist, the cross resistance does exist, and then if I still using sakinavir, I will waste a more powerful bullet. I'm just talking about the group of proteases. I will not take advantage of a more powerful bullet such as darunavir that has more genetic barrier and a stronger robustness. So I think that this is a pretty lame argument. Now, the other thing that you are saying is yes, and we see this more frequently than you think, that people still take what they have stored. Otherwise, if they don't do that, the medication will expire. The communication between the patient and the doctor is very important. If I am changing the medication, is because that other group causes toxicity or comorbidity or other issues, or it is failing and you need to use another kind of medication. In this sense, there's no more to say. What we need to do here is to actually insist that someone who's having failures needs a switch. And this happens everywhere. We can see in a resistant committee, we can see that there's this patient with 5 years that has failed for 5 years, and we're wondering why? Why will you allow this person to fail for that time? This happens everywhere. Now, with respect to your first question, okay, I think that the data is terribly solid for uncommunicable, not detectable, with undetectable as such, under 50 copies. For me, it's not still clear the argument of the WHO in the last meeting that less than 1,000 copies is totally uncommunicable. This is based on data that is very suggestive, but they are not completely clear. However, this we know that under 1,000, the mother won't pass it to the child. I think that we need to be very careful with this. Now, pay attention. Something that we studied a long time ago with Mr. Del Rio was that the compartments of the body are very different. The viral load that you might have here is different to that one that you have in your genitalia. And what you expose in the section relationship, which is the most common thing for the transmission, is the genitalia secretions, both semen and vagina secretions. First, I would like to say that the patient should be under 50 copies, 40, 20, in order to achieve the goal that we want, which is to increase the quality of life, to increase the lifespan. First, that's the goal. And the secondly, not transmitting the virus to anybody. But let's not discard, or let's not forget that HIV is not transmitted, but the syphilis or other or gonorrhea are also transmitted. We need to comment this with our patients as well.
I would like to give you this document and acknowledgement. Thank you for being here with us today, and a round of applause for the doctor. Good afternoon. We will continue with this agenda. I am very pleased to introduce next speaker. As a preamble, I remember many years ago when we started dealing patients with HIV, we used a book which was coming from Johns Hopkins medical management of the HIV patient. And the main author was Dr. Joel Gallant. Fortunately, he's today with us today. Dr. Gallant is one of the main experts on HIV in the USA. And as I said before, he has been working for a long, long time at the Johns Hopkins in charge of this clinic for HIV. And currently, he's the global manager on behalf of a pharmaceutical firm, Gilead, and he will be talking about a topic as interesting as the one that we just heard before, which is the experience of 3 decades in antiretroviral therapy and the view towards the future, towards 2030. Thank you very much, Doctor, for accepting this invitation.
Buenas tardes, and thank you very much for that introduction. It's really a pleasure to be here and talk to you about history. And what I find is that I get older and closer to retirement, I get asked to talk about history more and more. And I guess that's one of the maybe advantages of getting older. I'm going to be talking about the history specifically of antiretroviral therapy. And before I do, I just want to point out my disclosures, which have already been mentioned. So the history of the AIDS epidemic officially began in the summer of 1981, when there were cases reported of both pneumocystis pneumonia and in another report, Kaposi sarcoma in gay men in large urban centers in the United States. Now, of course, we later learned, when we learned about the HIV as the cause of AIDS, we learned that it had been in the human population much longer than that. So, for example, there was somebody who died in what was then called Zaire of an unclear illness. Blood was saved and was found to have been positive for HIV. And we subsequently learned that, in fact, it had probably entered the human population in the early part of the 20th century. But from an epidemic standpoint, 1981 was really the beginning. I was a medical student then at UC San Francisco. I also began my studies in 1981, so it was really just the very beginning of the epidemic. And by the time I reached my clinical years, 1983, the world's first AIDS ward had opened at San Francisco General, and that was where I was admitting some of my very first patients as a student. It was a terrifying time to be practicing medicine, especially in San Francisco, because, of course, those patients had a very poor prognosis. The discovery of HIV as the cause of AIDS occurred in 83 and 84. There are 3 people who are credited with this discovery. On the far left is Françoise Barré-Sinoussi, who worked in Luc Montagnier's lab in Paris, and they both shared the Nobel Prize for this discovery, though there is some claim from Robert Gallo in the United States as well. Now, of course, this led to the ability to do HIV testing. That first happened in 1985. And of course, it was critically important, especially because it allowed us to screen blood products. That didn't happen immediately, but it did happen and made the blood transfusions much safer. From the standpoint of people who were at risk for HIV, many of them did not rush out to get this test. There was nothing medical that you could do with the information. There was no treatment other than treatment for opportunistic infections. There was nothing available to slow the progress of disease. And in fact, in those days, we didn't even know what the natural history of HIV was. We didn't know if some people would progress and die, and others would just be chronic carriers. The downsides of getting testing were stigma, discrimination, people lost their jobs, people lost their homes, and so it didn't seem like there was much reason to get tested for a long time. So these were dark days. We, as I said, we had nothing to offer people other than opportunistic infection treatment. People jumped at
alternative therapies, proposed touted cures, some of them, most of them useless, some of them dangerous, like the so-called blood boiling that I show there on the left, but it's really all there was back then. That changed, though, in the mid-90s when the first nucleoside analog and the first antiretroviral agent, AZT, or zidovudine, became available. And although we typically think today of AZT as being a weak drug without much benefit, the original clinical trial that led to the approval of AZT did have dramatic results. And you can see that, I don't know if that works. Anyway, in the dark line, you see that all those arrows are deaths. So there were 16 deaths in the AZT arm and only one, in the placebo arm, and only one death in the AZT arm. So the results were very dramatic, and this led to a great hope that AZT was going to be an answer, and then it would be followed by other drugs, and we were out of the woods. Of course, we soon learned that you can develop resistance to AZT, and you can develop it very quickly. Now, this was not something we could test in the clinic. This was only a research tool that was done in laboratories, but it was clear that you could develop resistance to AZT within a matter of months. And at the most, people on AZT monotherapy maybe got a year to a year and a half worth of clinical benefit before the drug stopped working. We did have development of additional drugs in the early 90s, and although you can see that the number of drugs is increasing, these were very dark times because DDI, DDC, and D4T were not terribly effective and were very, very toxic, in part because of their effect on mitochondrial DNA. And in addition, they had overlapping resistance patterns with AZT. So although there were some differences, for the most part, extensive resistance to any one of those drugs led to extensive resistance to the others. 3TC came out in 1995, and of course that is an important drug that we still use today, but we don't use any of those other drugs. And those years were continued to be very hard years during the history of this epidemic. So people, of course, out of desperation, started combining nucleosides, and we learned that two drugs, at least with AZT and 3TC, was a little bit better than one drug. So this trial by Joe Aron compared AZT monotherapy, 3TC monotherapy, and the combination of the two. And you can see that viral suppression was best with the combination, though you get this rapid decline and then it already starts to come back up again because resistance was already forming. You weren't ever completely suppressing viral replication. But this offered, again, a little bit of hope. And of course, we also knew that 3TC had some unique properties with respect to resistance in that it could help to either prevent the accumulation of thymidine analog mutations, or it could help to at least partially reverse the effect of those mutations on the virus. And that's one of the reasons we still use 3TC today. That, and of course, the fact that it is probably, along with M-tricetabine, one of the safest drugs that we have. All right, so things began to change in the mid-1990s. Protease inhibitors and NNRTIs were being developed. And here's a study from Trip Gulick, who you heard from today, landmark study of the combination for the first time of a triple drug regimen with indinavir, the first, well, not the first, but one of the first protease inhibitors with AZT and 3TC. And here they were comparing it against indinavir monotherapy and AZT 3TC. And for the first time, and this was novel too because they're using virologic endpoints as opposed to waiting for death or opportunistic conditions to occur, and they showed that with the combination of the three drugs, you got complete suppression that persisted through the course of this trial. Now, we heard about these results in conferences in the fall of 1995, but they didn't really become widely known in the community until this conference in 1996, the International AIDS Conference in Vancouver, which was truly one of the historic landmarks in this history that I'm telling. It was, without a doubt, the most optimistic, positive news we'd heard after many, many years of depressing, negative results. What did we hear? We heard about protease inhibitors. We heard about NNRTIs. We heard about the ability to measure viral loads. But most importantly, we heard about the effect of triple combination therapy that not only suppressed viral load, but suppressed it so low that you no longer had replication. So it was a durable effect. And David Ho at that conference proposed his hypothesis that if you suppress viral load long enough, that you stop replication in resting CD4 cells and reservoir cells, they die a natural death, they get replaced by uninfected cells, and you cure HIV. So the motto, what people talked about at this conference was hit early, hit hard, treat quickly, treat with maximal therapy, and we all came home from Vancouver and put that into practice with our patients. There was what I call the post-Vancouver thrill. So the news media got all over this. Newsweek even said the end of AIDS. There was a question mark there, but many people ignored the question mark. They said, we've got this problem solved. David Ho was Time Magazine Man of the Year. And we saw amazing results. So this is just kind of the evolution of treatment. On the left, monotherapy, you get a modest reduction in viral load that's temporary, a modest increase in CD4 count that's temporary. Dual combination therapy was a little bit better, but still temporary because you're never fully suppressing viremia. But triple drug therapy was not just quantitatively different, but qualitatively different. We were totally suppressing viral replication, and therefore the effects were durable because without replication you could not get resistance. And this is what happened at Hopkins, where I was working at the time. We saw between, say, 95 and 97, dramatic reduction in mortality. And what you see in the colored areas is on the left, monotherapy, in the middle, dual nucleoside therapy, and then triple therapy in the dark color. And as practice moved toward triple therapy, the results were remarkable. This wasn't just at Hopkins, it was throughout the world where we were then using therapy. And we'll come back to that, but that was, of course, resource-rich countries only. And you heard amazing stories, entire AIDS wards closing down, people leaving hospices to go back to work. It was truly a remarkable time. But it wasn't all good news. First of all, the David Ho hypothesis was basically put to rest. These are data from Mario Stevenson, who showed that the long-lived reservoir cells where HIV hid out, their half-life was 44 months. And so Bob Silicano at Hopkins took some of our patients in the clinic, the ones who always took their medication, never had viremia, always suppressed, and he quantified their latently infected CD4 cells over time, the amount of time they'd been on treatment, and he did show there was a decline. You can see there's a slight slope there, but it's a very gradual slope. And he estimated that it would take 73 years for all those infected cells to die out and be replaced by uninfected cells, and that just is not a feasible way to cure HIV. The other, before I go on, whoops, I should go backwards here. The other point I wanted to make about that this was not all good news is that we had, and you heard this from the last lecture, that there were many people who could not benefit from these combinations. They had been treated in the 80s with AZT, in the 90s with other nucleoside analogs. They had extensive nucleoside resistance, and by the time the integrase inhibitors or the NNRTIs came out, they no longer had an effective combination they could use. In addition, the drugs were incredibly difficult. So indinavir, one of the major integrase inhibitor at the time, you had to take it on an empty stomach at least a half an hour before meals and 2 hours after, every 8 hours. Plus, you had to take the AZT and 3-TC, which generally were taken with food because of gastrointestinal issues. So people were on these enormously complicated regimens that were also very, very toxic. So even those who did have the susceptibility to the drugs had often a very difficult time achieving good adherence. So efavirenz came along and challenged protease inhibitors, and this was a study looking at efavirenz plus 2 nucleosides versus indinavir plus 2 nucleosides, showing statistically better results with efavirenz. Now this is not necessarily intuitive. Efavirenz had a very low barrier to resistance. A single mutation could cause high-level resistance. Indinavir, on the other hand, had a pretty high barrier to resistance. It took multiple mutations. But efavirenz had a few characteristics that indinavir did not. First of all, it was much better tolerated. Second, it was much easier, once a day as opposed to every 8 hours. And it had a much better pharmacologic barrier, a longer half-life. It achieved drug levels that were well above what you needed to suppress the virus. And those things all combined together to become more important than the genetic barrier in this case, and efavirenz quickly became a standard of care agent. Now let me shift gears here and talk about what happened globally, because I would say this is the next super important conference that we had. And a lot of the history of the epidemic, we kind of think in our minds of, we date the changes based on conferences. In this case, I think it's fair to do that. This was the first conference that was held in a resource-limited setting, Durban, South Africa. And up until this time, many people said the therapy is too complex and too expensive. It can't be taken by people in resources-poor parts of the world. That all changed overnight with the Durban conference. And Nelson Mandela gave a keynote address and said a tragedy of unprecedented proportions in Africa is unfolding. AIDS today in Africa is claiming more lives than the sum total of all wars, famines, and floods. It was shortly after this conference that the Global Fund and PEPFAR were formed to help achieve the goal of delivering HIV care in many parts of the world that had not previously had it. And if there were still any skeptics who didn't think that we could achieve this, here's a dramatic example from Africa. This young man came in with, of course, advanced AIDS, and it was kind of hard to be skeptical after you see things like this. Now, we're still, even though we're making progress with protease inhibitors, now with NNRTIs, we were still using these old nucleosides. Of course, they were much more effective now that they were combined with better drugs, but they were still quite toxic. And the toxicities could vary from cosmetic toxicities like lipoatrophy to disabling toxicities like peripheral neuropathy and fatigue, to life-threatening toxicities like lactic acidosis, pancreatitis, and non-cirrhotic portal hypertension. On the right, you see a picture of lipoatrophy. In those days, we often blamed fat changes on the protease inhibitors because we started noticing this as the protease inhibitors came out. But in fact, a lot of that was probably due to the nucleoside analogs and their mitochondrial toxicity. So a big important development was the approval of a safer nucleoside, tenofovir DF, or Viriad, approved in the US in 2001, and it was compared against stavudine on the left and against AZT on the right. In both cases, it was better tolerated and better and less toxic. And in the case of AZT, it was actually superior from an efficacy standpoint as well. So very quickly, TDF and later also abacavir began to replace the older nucleosides that had caused us so many problems. In the middle part of the 2000s, we saw the development of a fusion inhibitor. I won't say much about it, T20 and fuvertide. It wasn't widely used, but it was used for people with extensive resistance. But then we had the first single tablet regimen. So a triplet was approved in 2006. Now, this on 1995 shows a not unrealistic pill burden for a patient back then. By 2005, a lot of people were taking 2 pills a day, usually a combination of Truvada and Sestiva. And many people said, well, we don't need a single tablet regimen. 2 pills a day is good enough. Nobody's going to care about 1 pill. But in fact, a single tablet regimen became incredibly important to people living with HIV. Imagine if you have a chronic, serious, often fatal illness that you can control by taking 1 pill a day. You're better off than most people with many other chronic conditions. And so it was very destigmatizing. It was very hopeful to be able to treat this disease with a single pill. And this, of course, became really the gold standard for many, many years. The other a year that I think of as being very, very important in this history is 2007. Because I've been talking about all these great advancements, but once again, many people couldn't benefit from them. They had too much resistance. They had what we would call untreatable HIV, and we used to spend a lot of time at conferences just like this talking about what do you do for the person you can't suppress? Do you still treat them? If so, with what drugs? Doesn't that increase the risk of future resistance? Doesn't that burn your options? It was an area of controversy because there were so many people like that. And again, as you heard in the last lecture, this wasn't necessarily because they weren't taking their medications. Some of the ones with the worst resistance are the ones who did exactly what we told them to do in the 80s and 90s. That is, take nucleosides, add a new nucleoside, then add a protease inhibitor, and of course they developed multi-drug resistance. So in around 2007, we saw development of a second generation protease inhibitor, darunavir, which worked in people who had resistance already. We saw raltegravir, the first integrase inhibitor, very well tolerated and in an entirely new class, so it worked no matter how much resistance you had. We saw Maraviroc, not widely used, but effective for some people with CCR5 tropic virus. And then later we saw dolutegravir, the first second-generation integrase inhibitor that worked in some people who had resistance to first-generation integrase inhibitors. And I've left out an important drug, etravirine, which was a second-generation NNRTI that often worked in people with NNRTI resistance. So if the number of people with untreatable virus was like this, in 2007 it was like this. Doesn't mean the problem went away, but lots of people who couldn't have been treated in 2006 could now be treated effectively. Now, these regimens were often very complex. We used to use the term salvage therapy, megaheart. They were often on multiple pills, complicated drug interactions. An HIV provider during this time had to have a lot of expertise in interpreting resistance tests, in knowing about drug interactions, and knowing how to deal with toxicity. But it was still an enormously important step forward. Shifting gears to prevention a little bit, because I'm trying to go chronologically. 2011 was when the results of the HPTN 052 study were reported. We already knew that HIV therapy prevented perinatal transmission, but we didn't have great data about sexual transmission. And in this study, they randomized discordant couples where one was positive and one was negative to either have the positive partner take therapy right away, even though they didn't need it based on guidelines, or to wait until they did need it according to guidelines, and they showed that being on treatment resulted in a 96% reduction in transmission. Now, of course, as they reanalyzed the data and other studies came out, looking not at whether you were on treatment, but whether your viral load was suppressed. If your viral load was suppressed, it was 100% reduction in transmission. And this, of course, led to what we now call U equals U, undetectable equals untransmittable, meaning, if, at least in terms of sexual transmission, you do not transmit HIV if your viral load is undetectable. Even the CDC in the United States, which is a very conservative body, comes out and says the risk is 0. So we're not supposed to tell patients, well, your risk is negligible, your risk is very low. No, we're supposed to say the risk is 0. Why is that important? It's enormously destigmatizing. It's enormously hopeful for patients. It's also true. And it allows them not to think of themselves as carriers of a contagious disease, but as people who can have normal relationships without having to worry. It also encourages them to be adherent, because now they're no longer just worried about themselves, they're also worried about partners. PrEP came out the next year, 2012. For the first time, notice that we're moving away from so-called behavioral modes of prevention, which was at the time ABC, abstinence, be faithful, use condoms. Those had not been very effective techniques. Now we're moving to biochemical, biomedical forms of prevention, treatment for those who are positive, and now, so for the first time, something we can offer to people who are negative to take the situation into their own hands. And this, you know, we certainly all knew that these things would have individual benefits, but the public health benefit became very clear. And these are results from San Francisco, where I had first trained and where it just felt like you were on a battlefield on the losing side of the battle every day. But when PrEP was approved in 2012 and when San Francisco initiated a rapid start program the following year, you began to see a dramatic decline in new cases of HIV. By 2017, it was close to 200. It's now well below 200. And many other cities have had similar results. Amsterdam is now close to eliminating new cases. Even the country of Australia is doing extremely well this way. So who knows? Was it PrEP that did it? Was it Rapid Start? It's probably a combination of both, because they both happened at about the same time. But the importance there of treating the positives and giving PrEP to the negatives is really the cornerstone of our new for people who are starting quickly, because and it's a smaller list, because it has to include regimens where baseline laboratory results aren't necessary. You still order them, but you don't need to know the results to start the therapy. So you don't need to know their hepatitis B status, viral load CD4, HLA-B5701, or kidney function. And, you know, we never could have done this with older regimens. Not only did we need to know those results, but we also had to make sure the patient was going to be adherent, because if they weren't, they could develop resistance within months of initial diagnosis. That's no longer a concern with these regimens. Even if they don't take them properly, they're not going to develop resistance. So this is why we can now do Rapid Start. And I hear people say, well, we should have done that years ago. No, not necessarily. There were a lot of reasons we couldn't have done it years ago, and we can now. So what happened in recent years? Well, we continue to see a pipeline. The number of untreatable patients is small, but it's still there, and that's why some of the drugs you just heard about, post-attachment inhibitors, attachment inhibitors, and most recently the capsid inhibitor are approved. These currently are used in a small subset of people with multi-drug resistance who are highly treatment experienced, and that even further reduces the number of people who can't be treated. So you all know about the UN AIDS goal. In 2013, they announced that 90% of people with HIV should be diagnosed, 90% of those should be on treatment, and 90% of those should be durably suppressed. Then they made those even more challenging, but some cities and countries have achieved them. They switched it up to 95, 95, 95, and then they added a fourth category that applies to all people with HIV, that 90% should have a good quality of life. The Lancet editors said it is not enough that people living with HIV are alive, they should also be living well, which means we can't just think about their viral load and send them on their way if it's undetectable. We have to be talking about aging, about comorbidities, about both treating them and preventing them, about knowing the long-term complications of antiretroviral therapy, making appropriate changes if necessary, and something that's harder for us to deal with is stigma. And that's a huge reason for poor quality of life among many people with HIV. It's not something we can always fix other than in our own practices and exam rooms, but we have to be aware of how important that is. So the guidelines say that ART should provide rapid, durable suppression of viremia. Rapid is easy. We know now that integrase inhibitors suppress viral load much faster than PIs or NRTIs. So I won't even show you the data there because everybody accepts it. Durable, of course, it takes time to show durability. And now I'm going to put my Gilead hat on for a few minutes and just point out that with BF-TAF or Biktarvy, we now have 5-year data, which is longer than any of the other recommended regimens on the guidelines, and the results are excellent. So if you look at the line that's going down, missing equals failure, that means anybody who drops out of the study for any reason is counted as a failure. And of course, in a 5-year study, it can be hard to keep people engaged in the study. But if you look at missing equals excluded, where you exclude those sorts of discontinuations, then the results are 98% and above for viral suppression over 5 years with, again, no resistance. We also have data in switch patients, people who were suppressed either on a dolutegravir, abacavir 3-TC regimen or a protease inhibitor-based regimen with long-term follow-up there. And again, using a missing equals excluded analysis, you see essentially 100% of people maintain suppression. So these are the kind of long-term data that are important. This is how we establish resistance barriers. You can't do that in the lab. The only way you can know what a resistance barrier is to see that no resistance occurs in clinical trials or in real-world studies. And so these trials clearly help to sort of quantify the resistance barrier. We also have real-world studies. This is an interesting one from France, where they like to use reduced doses of everything. And in BF-TAF, they looked at people who were taking it either 4 or 5 days a week. Not something we would recommend, but certainly some of our patients are probably doing that either accidentally or on purpose. And what they showed was it did very well. There were 2 virologic failures, both of whom resuppressed on the same regimen without any resistance. Again, in France, they probably do this on purpose. We would just say that this provides some reassurance about the forgiveness of the regimen in people who aren't perfectly adherent. So let's talk about the future, because it was part of my title was to talk about the future. And first of all, we have long-acting therapy, and we already have that now with cabrolpivirine, and more regimens are coming. Cabrolpivirine has now been studied in several clinical trials. It always shows good efficacy. It generally shows non-inferiority to whatever it's being compared to. But there is a difference, and I think cabotegravir in this regimen behaves a little more like a first-generation integrase inhibitor than a second, in the sense that you can develop resistance. So in these studies, on average, about 1% of people developed resistance, either to the NNRTI component, the integrase inhibitor component, or in many cases both. So 1% doesn't sound like a lot, but that's compared to 0% in most modern oral regimens. So I think it certainly has the advantage of being able to be given by an intramuscular injection, but the disadvantage that you're taking a slight loss in resistance barrier. Lenacapavir, you've heard about today probably from several speakers, is the capsid inhibitor currently approved for people with multi-drug resistance, but of course that will change over time, we believe. On the left, you see various options for oral lenacapavir. At the top is daily oral len plus bictegravir. Now this would be a regimen for people who have resistance to anything other than integrase inhibitors. Even people with multi-drug resistance to nucleosides, non-nucleosides, PIs, as long as they didn't have integrase resistance, could take this regimen. So that means a lot of people who are on multi-tablet regimens could potentially go on to a single tablet regimen if it works out. And then we have a variety of weekly oral drugs that could be combined with weekly lenacapavir. The one that's furthest along in development is Merck's islatravir, the translocation inhibitor, but we also have some internal candidates. And then in the middle, you see long-acting injectable. The only 6-month regimen we have that we're looking at now is lenacapavir plus 2 broadly neutralizing antibodies given every 6 months. It's in phase 2 studies. And then there are some other candidates for every 3-month injections as well. And then on the right, lenacapavir for PrEP. Currently in actually 5 different clinical trials, but 2 of them are large registrational trials, one of which is fully enrolled, the other of which is doing well, and this is to look at every 6-month injections of lenacapavir for PrEP. What else can we talk about in the future? I'm skipping over preventive vaccines because, frankly, the data hasn't been very good in the last 40 years on them. I'm going to skip ahead to cure. And cure is an amazing goal, very aspirational, but it's realistic enough that the NIH and other research bodies and drug companies are spending a lot of money studying this, and some of the best minds in our field are working on the idea of an HIV cure. Gilead has its own approach. It's not the only approach, but the one we've taken is to look at some combination of latency reversal agents, immune modulators, and therapeutic vaccination. We've had good results in monkeys, and we're studying this approach in people. Initially, the idea would maybe be to achieve a functional cure where people didn't need therapy but were still infected, but ultimately, of course, the goal is eradication. Now, I've heard people say, why do we need a cure when we could eliminate the epidemic next year? And we could. I mean, if we really put our money and resources and political will into diagnosing everybody, putting them immediately on treatment, and giving PrEP to people who need it, the epidemic would go away. And we are seeing that now in select parts of the world. So why do we need a cure? Well, maybe you could argue we don't need a cure, but wouldn't it be great if we had one? And I think, you know, if you think about the challenge of a cure for HIV, right now there's one viral disease that we can cure, hepatitis C, no others. HIV is much more complicated because of latency. So if we could develop a cure that could cure a disease where a viral DNA gets integrated into human DNA in these long-lived resting cells, that would be a scientific breakthrough. It would have ramifications for virology and immunology way beyond just HIV. So even though I think ending the epidemic is probably more important, I think it's great that we're working so hard on cure. So let me just close with some predictions for the future. And I'm going to kind of focus here on resistance because it's what I always love the most. First of all, I think the accumulation of multiple mutations resulting in extensive drug resistance, that's over. We're not going to see that happening anymore. Why? Because it was mostly due to our use of thymidine analogs like AZT and D4T, where you'd accumulate these multiple mutations until you got up to 6. And it was also used due to, oh, does that mean I'm done? It's also due to use of unboosted protease inhibitors, where you had accumulation of resistance mutations. So we're not doing that anymore. Whoops. But we will still need to know about 184V. That's still going to happen. To mutations to second-generation NNRTIs, that will still happen. And in terms of integrase mutations, they'll probably remain uncommon, but we're going to still see them, and especially as we start using new integrase-based options. So I've mentioned cabotegravir. The guidelines in the US now have come out and said that if you fail treatment with cabrilpivirine, or if you fail prevention with cabotegravir, unless you can prove that somebody does not have integrase mutations, you need to put them on a boosted protease inhibitor. This was not part of the guidelines until these regimens came out. So we will have to think about integrase resistance in the future, but hopefully it will not be common. And then the final point I want to make is there's this still kind of somewhat theoretical risk of resistance after discontinuation of long-acting agents, either for treatment or PrEP, and it's due to what we call the tail. That after somebody stops these long-acting therapies, they still have drug levels for months, even beyond a year, that are subtherapeutic and could give them a risk of resistance. So far, we haven't seen this much, but the drugs are fairly new. Most of the resistance we've seen has been in people actually taking the drugs, but it's a potential risk both for cabotegravir and also for lenacapavir. So I'll stop there. It says 3 decades of experience in ART, but of course it's now over 4 decades of the HIV epidemic. And I feel privileged to have been a part of it since my student days. I'm hoping that when a cure is finally announced and it hits the front pages, I will be alive and cognitively intact enough to realize what's happened and to kind of see this to its final conclusion. Thank you very much for your attention.
Thank you, Dr. Galat. ¿Tienen alguna pregunta para el?
Do you have any question for Mr. Galat in this extraordinary review of what has happened in 40 years in 50 minutes? Nope.
presentación? Sí, súper, perfecto. Ya en 2 minutos vamos a dar inicio. Una disculpa por...
We will resume our presentations in a couple minutes. The next lecture will be given by Mr. Javier Arellano from United Nations AIDS. He's in Panama, and just as you know, we are celebrating activities related to the HIV Day, but he's about to join us.
Recording in progress.
Muy buenas tardes, nuevamente.
Good afternoon and welcome to this is to the Inter-American Conference of the Inter-American Conference. We are going to continue with our activities for this day. And in order to conclude the activities of the program, we are going to have a plenary session by Javier Arellano, who is the youth officer and social organization in the regional office of United Nations AIDS for Latin America and the Caribbean. He's also been a consultant for United Nations in Mexico. He also was a regional consultant, officer of a BIH, and the High Commissioner for the Refugees. In the governmental world, he was director of prevention of HIV in Mexico City and coordinator of TELCIDA, the information line for against HIV in the national program of Mexico. His initial formation starts in the civil society. He was a volunteer in the social organizations in Mexico. He has stories of in health and reproductive health. And he's been working in Walmart 20 years in the response against HIV and a lecturer in different schools, in different social congresses. He wrote 3 chapters in books about the topic, and he's interested in HIV, health, sexual rights, masculinity, sexuality, work with key population and LGBTQ and plus population global health and international cooperation. I want to welcome our dear Javier Arellano, who will talk about global strategies against AIDS and the three crises in Latin America. Thank you so much, Javier. We already see you there. Welcome, and I pass you the floor now. Good afternoon. Good evening to everybody. My name is Javier Arellano. Thank you so much to the International Conference, Inter-American Conference, to it and other organizations, because for your invitation to this event. I send you my greetings from the regional office in Panama. I am here sharing this afternoon with you. As you know, this is always a pleasure to be in these kind of spaces, especially in this conference of the Inter-American Conference to discuss about the novelties with respect to the response against to the HIV and the AIDS pandemic. This afternoon, first of all, I would like to send you the greetings from Elsa Cavala, General Director of United Nations AIDS. The idea is to discuss three different topics, three additional topics. First one is one that I added very recently, the new report over the World Day of AIDS 2023. It's a very recent topic that was just published yesterday. So many of the images and part of the information that I have wrote to you is pretty new. Later on, I will ask you to visit this report on the World Day to commemorate AIDS and the main goal of it. Later on, in the second part of the presentation, I will talk to you about the global strategies against AIDS and finally, by the end of my presentation, I will talk about the three crises, what we have considered for like that for 2 years, the crisis in the region of Latin America and the way they affect us regionally with respect to the answer to the HIV. So this way, I'm asking you to talk about these three topics. And we are going to start talking about the first point, which is the global report over AIDS to commemorate the World Day Against HIV, celebrated on December 1st. This time, the global report is called Free Communities. This is a reference to the response of communities of the social society, civil society in the whole world. As you know, and as I always said, to think of a response against the AIDS without thinking of the response from the civil society organizations wouldn't be possible. It wouldn't be possible to do it as the way it is considered today. The response from the community are nowadays little recognized, little acknowledged, and in many countries they don't have the right resources. In the world 10 years ago, 11 years ago, by 2012, they financed 20% of the response. Nowadays, a couple of years ago, in 2021, this response was just 20%. So there was a decrease of 12 points in these 10 years. The idea is not like this. The financing to the communities should not decrease but increase. And in United Nations AIDS, we are clear on how to do it, and I will talk to you about that. As I said before, the communities are very important. They have the unique capacity to reach populations where the governments, the cooperation agencies and other entities cannot get. It is possible that they might guarantee that the health services that live with HIV reach them, that is, the people living with HIV, but they also reach other populations. It's easier that one person from a key group. My field identified with a person from his own community or their community than identifying with a person that is not part of the community. We have seen that the community responses aimed to people doing sexual works when they are led by sexual workers are more successful to get to them, where other organizations of the government would not reach. That's what we are trying to commemorate United Nations AIDS with this motto. The communities have created an inspiring movement for a change. I've seen this in many different times, and of course the response to the HIV is also against other pandemics, specifically COVID-19, where communities and organizations from civil society did additional efforts, for example, to give ARV treatments to those people who couldn't abandon their communities. Other inspiring actions in communities facing other phenomena like pox and the community responses that have given to these phenomena. In the streets and in the parliaments and in the courts, we are establishing key policies. I remember that many years ago in my country, in Mexico, the civil organizations closed the streets and the main avenues to demand resources for their policies. That's basically the universal access to ARV treatment for everybody. We have seen that in many other places, such as in Brazil, the policies were changed thanks to the leadership of the members of the community. And for example, today in Panama, we have seen how the community leadership has changed in key decisions. For example, for the society in Panama, there was a change a couple days ago, happened thanks to the pressure of the communities. So that's why we think that we should acknowledge the communities as a great asset that is not only active, but also oftentimes lacks resources or doesn't have all the resources they would need. Not always you see it well paid, and well, I remember that some years ago when I used to work in an organization from the civil society, they asked us to give everything we had, no matter other resources. There was little backup, and our effort was very poorly acknowledged. In Mexico, with some social programs that were conducted some years ago, communities and organizations from civil society flourished, and they had many important initiatives aimed to the prevention and the treatment of HIV. That's why this year the leadership of community two or three slides away, we had this suggestion. First, we need to acknowledge that the organizations from civil society and communities play a very important role that not all of the organizations can comply with. For this reason, we think and we trust that the organizations from civil societies will continue playing this autonomous role of a fast reaction compared to the ones done by the government or bilateral organizations, and their permanence is necessary not only in the community responses but also particularly in the response against HIV, and as I mentioned before, they are vital in the response to other pandemics such as the one from COVID-19 that we underwent a little time ago. What we are suggesting, and this is a topic that I will discuss, is to consider the goals of 30, 80, 70. That means that for 2025, that is in a couple years from this moment, The 30% of the trials and services are provided by organizations from civil society. That's it. 3 out of 10 services for quick detention or other services can be provided directly in the headquarters of the organizations and by members of the community and organizations. We also suggest that 80% of the supply for preventing and for key population, including women and children, are led by organizations led by communities and key populations. That is, the organizations themselves should be the ones, especially those that take part of the key populations who lead the supply of these resources. And finally, 60% of the programs of HIV support the use of social workers given also provided by the organizations. That is, the programs against HIV support programs and that civil organizations can reach different sites or provide or get access to PrEP, or that the organizations have enough habilitators, enhancers to comply with the work that they need to comply with in a very honorable way. These are the goals for the 30, 80, 60 that were considered for the global plan against AIDS. And in this moment, to commemorate this day, has been very important, and it's very important, more than ever. I think that we are going to close the first part of my conversation, and as I said before, this is totally aimed, or the goal of it is that this year and forever, the civil society and the community organizations, based organizations, organizations-based another based organization lead their own people. And in the second part of my presentation, we are going to talk about the global strategy of AIDS, and that's a topic that I was invited to discuss. In the past, we used to have a global strategy of AIDS that ended, or that was renewed in 2021. The previous strategy of the AIDS was different to the one we know right now, and it was totally focused, as you might remember, in the ODM, if I'm not wrong. It was basically where everything was placed. Now, thanks to this new global strategy of international cooperation, actually have been able to organize differently, and we have noticed many different things. Most importantly is to apply the understanding of the inequity in the different strategies. What does this mean? This means that we should acknowledge that, yes, we have around 17 ODS, especially ODS 3, that is related to, of course, the HIV pandemic, but also that the new global strategy against AIDS needs to spot the fact that people have different kind of inequity because of different reasons. For example, one person might live with HIV, but at the same time might belong to an indigenous community, and at the same time with a disability, might live with disability. This is an example, a real example, and that explains to us how we need to use magnifying glasses the different inequities people undergo. That's why this strategy, we are grouping these strategies that I will share with you in this slide that I love. Probably it might seem too small, but anyway, I will share it with you that you can review it and read it more carefully. I just need to mention some other things. The first thing is that it has 3 strategic priorities. One is still maximize the equalitarian access to solutions or services against the HIV virus. Secondly is to destroy the obstacles that prevent us from accessing to the obstacles, especially by 2030. And we are still thinking that this is possible, because we think that we might have a generation free of AIDS by 2030. And the third one tries to get financing to fight against the HIV, because yes, of course, someone needs to finance the response against AIDS. In most part of the region, the response to the HIV epidemic has been absorbed by the governments. However, there are many countries, especially from Central America, where the pandemic of HIV is still in the need of the international cooperation. And this is in our region, the World Fund against the AIDS and malaria is conditioning its participation in this region. Many countries, such as Mexico, are not to be chosen by the World Fund. So we need to think of this new international cooperation scenario. Before concluding with this slide, I would like to highlight three different things. There are different results that want to provide more results in specific areas, and I want to point out in this moment that, for example, of the results 7 is the area of results devoted to teenagers and young people that had never been considered in the global strategy against AIDS. We had discussed youth and young people and teenagers, but we had never had a result area. This is one of the changes in the global strategy against AIDS in 2021 to 2026. But now we can also see what was kept and what changed very quickly. Through 5 different examples, we will see what is maintained with the vision of 3 zeros to stop AIDS as a threat to the public health in 2030. Oftentimes we have been asked, what does it mean to end with AIDS as a health threat by 2030? Well, this doesn't mean that new infections will happen by HIV. The infections provoked by HIV will still happen because basically 90% of the cases in Latin America and in the Caribbean happen because of sexual transmission. However, it is hard to change this. However, something that we can actually change by 2030 is to prevent people dying from causes related to AIDS by 2030. We have all the technology, all the resources available, technological resources, all the advanced medication to prevent people dying from causes related to AIDS by 2030. Some countries have even posed the attention for the people with AIDS because there are no cases of AIDS in some countries. So this is, let's say, the line that we want to see, the horizon we want to go to, and fight the inequities, something that I mentioned, combined against HIV. The PrEP, the self-testing, and all the prevention resources are resources that in the last 10 years have been combined and been introduced in Latin America and in the Caribbean. Some countries have led the response of PrEP in the region, and some others are intensifying the response, such as in the case of Mexico. And IMSS, along with the AIDS, has a PrEP strategy that is about to start or has already started. And we congratulate you for that. Mexico is one of those countries that is betting and in the use of PrEP as a central strategy to prevent AIDS. However, it doesn't happen like this in all the regions of the continent. There are many places that are left behind, not only in the policies, but also in the sense that there is some time, the need of time for them to access to it. As I said before, we're still keeping some priorities to treat stigmatization as well, but there are new goals and commitments. I have already talked about the goals of the civil society, but in the next slide I will talk about new indicators of the 10-10-10 that measure stigma and discrimination. We're still keeping in number 4 the alignment with the priorities of national resources, the participation of the civil society, which is the main topic of the year, the key populations, based on the human rights, and of course the equity and gender equity. The area of responses, which are new, have been prioritized, for example, on communities of like human rights, one devoted to the youth and the pandemic. This new area is definitely new area, which is a heritage from the pandemic of COVID-19, and it basically has to do with our own preparation to face new pandemics that we might face in the future. Hopefully not a very close or nearby future, but we actually need to be ready to face them. Finally, we're still keeping the glossary for preventing the infections in key populations. This is a word that has been mentioned very little. These three words are not so mentioned, but are still so important as the time when they were first said. The wholesome sexual education through different ministers of education in the region. The sexual education is still in the center of the global strategy, and it's a topic that we need to keep on talking. Finally, I'm going to conclude this slide that say that this global strategy should be applied in every community and country. This is a global strategy against the AIDS, not United Nations AIDS, signed up by all the member countries, and actually this is a strategy of everybody.
Something I like very much from this new strategy is that we have two areas, and before they were not here, and one has to do with 95, 95, 95, and the other one with 10, 10, 10. Basically, it has to do with it, because putting people with HIV, but communities at risk, in the center of this new strategy. That's why these indicators of 95, 95, 95 seek that 95% of people at risk or the key populations to have access to these treatment, PrEP, and self-aid as PrEP. And 95, 95, 95 of HIV test should be this type of test, and the treatment for suppressing viral load in children and teenagers. 95% of women should have access to, when it's required, when it's necessary, to reproductive health and sex with an approach of gender, and to have all these studies without people pointing fingers at them, and considering the needs of some populations, especially as women that live with HIV. And I want to tell you that, of course, as any other woman might have children and free of infection, but 95% of services or coverage of services might increase to get rid of this transmission. As we know, the transmission, vertical transmission from mother to child, still remains as a constant issue and embarrassing in our population. We need to have been able to recover, but unfortunately it's still present there. And it's looking for 95% of people with the HIV to receive preventive treatment for tuberculosis, because we know that the relationship between the two is very evident linkage. People with HIV might suffer from the tuberculosis at a given time. That's why they require preventive treatment. And we have been able to see, happily, in some centers that they are providing this preventive treatment for people that suffer HIV to prevent tuberculosis. 95% of people who suffer from HIV and are at risk, they should receive an integrated treatment. But 95% of these people with HIV should have other health services, and specific for them and specialized as required. In Mexico, there are many cases in that sense. Of course, the model of the specialized clinic, this is a clinic where I have the honor of being part of when I was working in Mexico, and it has a specialized service for this type of population. On the other hand, I would like to talk about this new indicator that I like very much that has to do with this transmission. For many years, we have been talking about stigma and discrimination, that these key populations are suffering stigma and discrimination. People who suffered HIV and from LGBTQ+, and many people who suffer from that. So for the first time, this strategy has some very clear indicators about where we want to work on and decrease the stigma and discrimination against this group. That's why the new strategy is telling that less than 10% of people who live with HIV and key population not to suffer from this stigma and discrimination, and not even the family. Less than 10% of people who live with HIV, women, children, and key population to experience inequality-based, gender-based, and violence, gender violence. As we know, the gender violence still remains a big issue in all Latin America and the Caribbean. And there are many times that many lives are related to gender violence that are lost. We see that in many cases, in many countries, every single day we heard some murder and disappearance of women or transgender, and many times we do not know what to do about it, but still this is a very important curse in our society. And finally, this new indicator is seeking that less than 10% of countries to have laws that might penalize this type of discrimination and stigma. Unfortunately, worldwide, in some countries of the region as well, still there are some laws, national, subnational laws, that are penalizing the transmission of HIV, something that we cannot stand. This is something that actually shouldn't be there. And we have been trying to do something about it, but still we are trying to promote that this might disappear. As countries impose some penalties and sanctions for people who live with HIV, well, unfortunately, still we see all these practices, maybe less and less, but still remain the same. Well, this is so far what I've been talking about, the global HIV strategy. In the first part, the new commemoration of AIDS Day and communities to celebrate. And I was talking then about the innovation of the global strategy of AIDS. And then there was, I show you 3-4 slides that is a kind of a summary to put the person on the center and acknowledge the type of stigma and discrimination these people are going through on the different, let's say, groups, because they belong to one or different groups or collectives. And finally, I would like to talk about what we have called the 3 crises in regards to the answer to HIV in Latin America. I would like to talk about the prevention crisis, access to treatment crisis, and exclusion and discrimination crisis, or stigma and discrimination, within the framework of the AIDS global strategy, but related to some of the social phenomena and that we have heard about. So please, I want to show you with the prevention crisis. That's the first one. What do we mean by prevention crisis? Well, good news region-wise, and that shows us reports on AIDS UN, the one published yesterday or 6 months ago, that is called En Peligro, in danger, is that the good news is that mortality related to AIDS in the region has decreased in 32%. Undoubtedly, this is a good region. Latin America and the Caribbean, as of some years ago, were leaders in the access of treatment retroviral. Now it's not the case, but undoubtedly, this had some impact because mortality rate related to AIDS had been reduced in the last 10 years. Bad news is that based on this report, is that Latin America and the Caribbean, there's been an increase in the last 10 years of 8% in the new HIV-related infections, and 8% of these infections had been focused on this very feeble population and male population, those who have sex with male and transgender women. On a third stage, they are impacting people who are doing this type of sexual activities and key populations that are affecting directly Latin American region and as the migrant population. Migration currently in Latin America and the Caribbean, it has a very big trend, and we know that it's increasing day in, day out, and it comes from the south borderline going to Tapachula, Tijuana, in the southeast part of Mexico, with a series of people, thousands and thousands of people. We believe that in the south borderline, Panama, Colombia, and Costa Rica, we have around 2,000, 3,000 people a day seeking to reach the USA. Now, from the 8% of these new infections, 90, how is it doing in our region? 85% of people living with HIV, they know their diagnosis in Latin America and the Caribbean. This is good news. Most of them, they know this diagnosis. But 7 out of 10, they are under treatment, retroviral treatment, and 8 out of 10, they have the suppressed viral load. And finally, this is what we want to reach, because people should have a long and healthy life and a good level of life. And people should have a suppressed viral load because it's very important for their health. But we know that a person that has an undetectable viral load, is possible he might communicate this disease, the virus in this case, and in some systems of the UN, as AIDS UN, we have undetectable is on non-communicable. A person who is on viral suppression, it's very hard to, because it has a very low load of virus, to be able to transmit it to other people. That's what we have. So if they follow treatment, retroviral treatment, and if they receive this treatment directly from the doctor, they will be safe. We know that this person that lives with HIV might have a long, healthy life, might have children free of virus, and also when it's undetectable, it might inhibit or transmit the virus sexually through the partner or two other partners. We know that some people do not have one partner, but more than one sexual partner with, or many. And so as the more fortunate, as Woody Allen might claim. But a person who is undetectable does not have a possibility to be able to transmit this virus of the HIV virus. Now, which are the relations of prevention, the challenges in Latin America and the Caribbean? Well, I would like to give you some information as a conclusion, and to move on the prevention of HIV, especially among the core population, most vulnerable population. We have seen how recently some countries are launching campaigns among population to prevent HIV, and that's good. And this is good news. But the idea is that we have to create focalized campaigns to target populations in our region, and that's why there is we can do it. We know that our males that have sex with male and transgender people, transgender women, and so these two populations, they show a prevalence, very high prevalence of HIV compared to other population. And we know that, and I will show you the right information, and we know that still they are under the most vulnerable population. So this is not a magic. It's not magic. So we need to do these prevention campaigns. We need to channel all these resources for them. And I am reminding Jonathan Mann, one of the pioneers in public health, and he claimed that we have a prehistoric because of these gay women and transgender, because we have not been able to answer on the right way to vulnerability that these populations have in regards to HIV. And this vulnerability that was increased within other pandemics, especially COVID-19, where we have seen many people, friends, close friends that live with the HIV were more vulnerable, and they passed during the COVID pandemic. Now, the second is to enlarge this access to this population, and then to impel PrEP and other preventive measures other than PrEP that, as you heard before, we know that is being encouraged in the region. There are some other tools that might be successful, that might be used for our region. One of them is self-PrEP test for HIV. We have seen in some countries, as Brazil, where at Weitiba they have an interesting experience with Gora Gora campaign, which was a campaign to encourage the access of self-test for HIV, and it was successful, still has. And that means that these are not strategies that are on a pilot, but these strategies, we know that they work. But nonetheless, in some other countries, we have some legal frameworks that cannot allow the access of some tools as combined test or PrEP, because I don't know why, but well, I won't be delving into this, but we need to open this legal framework to accept all these preventive tests for HIV. Now, the second crisis is access to treatment. As I said before, 10 years ago, Latin America and the Caribbean was the champion region in regards to the use of ARV against HIV. And because of the pandemic, and there are some other factors as well with the environment and economic, global and regional environment, these are not the two regions that have more access to this type of treatment, but the one from the Pacific. But nonetheless, at present time, 1/3 of people who receive an HIV treatment, still 1/3 of them that need treatment for HIV still have no access to that treatment. That means that an important part of them still, they do not know they need the treatment because they haven't have through this detection test, they have not have access to it, have not been able to get the right diagnosis. So the first pillar of the cascade still remains core, more than ever, prevention. We know that in Latin America and the Caribbean, 44% of people reach these centers with a very late diagnosis, with advanced disease. And as I said some years ago, I had the honor to work with Health Services of Mexico City on the Condesa Clinic, and I was astonished to see how on a city with so many access of public services, Still, there were some people with a late diagnosis. It had nothing to do with the low access to health services. It had to do more with other factors. Environment, stigma, and discrimination that people might feel. Even though might claim that in a country as Mexico City is not the case, still they feel ashamed, and because they don't want people to know that they suffer from this, or their peers at work or workers. What will happen when I go to the health center or next to the church where they go? What do people might think about it? That stigma, that crisis of stigma and discrimination and exclusion has not changed in 40 years. In Latin America and the Caribbean, we've seen some access to new tools as PrEP, as self-test, and we have seen a wonderful enhancement in the access of retroviral treatment, but still discrimination and stigma remain the same curse that is now affecting and that might just make some people to pass. Even young people who might have access to these health services because they are afraid of what people might say, or that they live with HIV or belong to this key population or core population, or that belong to the LGBT community, or the three. That means that we still live this pandemic of stigma, discrimination, and that is making that is based on the social response and affecting people to go to the health services. That in many countries, as in Mexico, there are many centers where people can go, and they come from the federal government or the Ministry of Health on behalf of the IMSS and other services and health national services. But people don't go there because of this. They are afraid, the stigma and discrimination that still is being featuring our continent. And so also the transmission of HIV, we are considering it unjustifiable and in a very biased way. Still, we are sanctioned in many countries the sexual work, and there are some countries, and I've seen this myself, where people who are sexual workers had been sanctioned just because they have the condoms on their belongings, and because they claim that they are doing a sexual work. And I've seen how sometimes the police frightened and bully this person or harassing people, these people who are transgender women or men who are doing sexual work in the street. Still, they are being impacted, criminalized, stigmatized, and they are just left behind. And so we are stigmatizing these type of groups and marginalized, and still they are unprotected by law. Next one, please. And I think that with this, I am almost concluding to my presentation. And I wanted basically to talk about these three big topics I was asked to share with you. And this slide, the last one, which is no discrimination, it gives me an excellent justification to conclude, because this is an excellent message to conclude. As I said, discrimination still remains a structural barrier to endorse the rights of population, key population, male having sex with male, and transgender women, migrants, and people who use drugs, and people who are in jail. And there are some other populations who are being left behind. People, children and women in our region. Women are not part of this key population. we've seen that they are part of the more susceptible population. In Latin America and the Caribbean, women are the ones who slowly get all this treatment compared to some other people and male and young people, teenagers, still they have problems to have access to many services in many countries of the region. People had to be after over age or the right age to have be eligible for this type of pretest. If a young person under 18 years of age cannot just have a test, and in some countries cannot just go to a pharmacy to ask for condoms because it's a minor, it's not the right age. Indigenous population, Afro descendants, we know that they are showing new issues. And we know that there are because we have no enough research of these populations. We need to promote a serious research to point out what is happening in regards to this population. I know that now in December there are new encounters and meetings for the indigenous coalition at Santiago de Chile. And maybe we can promote these initiatives there. And as I said, to the migrant population, Mexico, and Panama, Costa Rica, the USA, we are going through a migration wave we hadn't seen before in history. And it points out that this migration wave, this phenomenon, is not going to stop. People, male, women, children, are migrating because of economic reasons, but also because of social reasons, and because of being prosecuted homophobic, and because some gangs are harassing them, or the organized crime are harassing them, and they are prosecuting them because of their gender. So the migrant population is one of these big populations that are vulnerable. The idea is to tear down all these structural unequal barriers to promote laws and policies that might promote or avoid this crisis of stigma and discrimination that still is there in the region. Next one, please. And with this, I will conclude my presentation. I would like to conclude by thanking this CISS, Inter-American Conference Social Security, and IMSS for considering me and as part of the UN AIDS as part of these activities. And every year that you invite us, of course, we will be able to participate. And my final message is that we need to bet on communities. Think about the response of the many phenomena that had happened, but without leadership, without positioning, without the courage of communities, of the civil society, will be unthinkable, because communities will need to be the leaders of the HIV response, together with the government, with the agencies, with the conferences and the autonomous agencies, and of course of the bilateral and multilateral cooperation agencies and cooperation agencies. You know that we are here as UNAIDS for you. We are doing our best to support your response, not just for the community, but for the HIV, to prevent it in Latin America and the Caribbean. The idea is that for the 2030, we might have a free AIDS population. Thank you. Okay, thank you very much. Thank you very much, Javier. You are our ally, our partner of big battles and struggles, as Dr. Isasola was leading, fighting HIV. And in our country, thank you very much for accepting this invitation. I know that the agenda is very tight for these days, but I thank you on my personal and on behalf of the Mexican Institute of Social Security and the CISS for your participation. I would like to mention that you will receive an acknowledgement for your participation. I will send it to you by e-means. Mr. Álvaro Velarca and Doctora Gabriela Borallo will be acknowledging your participation. And I would like to ask the audience, those who are here with us or streaming, if there is a question for the speaker, we have some minutes to be able to answer questions. Yes, please go ahead. Your name. Where do you come from? Hi, can you hear me? I am Georgina Gutierrez. I am the chair of the Mexican movement of positive citizenship and representative in Mexico of Latin American and Caribbean positive women movement. Never change, please. This is a local, let's say, joke. I'm going to make full use of your presentation. It was so to the point, going beyond the friendship that we have. You are a committed person with this work. First of all, I would like to thank the Mexican Institute of Social Security for this interest to update in the terms of HIV. And I'm telling you, from my particular viewpoint as civil society, there's been a lack of Congress, symposium, conferences in the topic of HIV, and to updating, much less than updating. As Javier said, that communities should be the leaders. This is a challenge in Mexico because the maximum leader of this country, and I agree in some things with him, but this part that civil society, we have been regarded by him as enemies. We have been tired of telling, these are our hands and our experience. Let's try to find out the response in terms of HIV in our country. We are not corrupted. We are working. We have social hiring. There are some studies by the public or the institute that we are doing things. We are not stealing money or budget. And we are there because that's the answer, leading of social communities. And I did that with people who were in jail since 1991, and I think that there is a lack of these strategies, especially for HIV. I want to make a to mention that there is a lack of, in terms of inequalities of women in the agenda of gender. There is not a single table that might work about gender. Maybe because of pregnancy, we were taken into account when we are pregnant, but not the rest of our rights. They had a table, working table, but not even now we have that. They mentioned that it's important to decrease the number of children born with HIV, but there is not a table talking about this topic. So still we have children with HIV, and I'm telling this in this country. So I believe that I don't want to be imposing, but I don't want to feel bad. That's why I'm telling you this. And I want to invite you to have the including language. It's not a fad. It's not talk about us. It's a matter of gender view. It's a political position of rights. And I haven't heard that on this Congress at any of the presentations. And I'm concerned about that because this is telling us what the government is doing, or from the institutions of Social Security, to do these inclusions and to have this gender view. And honestly, I acknowledge the big effort for this Congress, this event. I'm not here just with this criticism and trying to point fingers at, but I am inviting you who are part of to create these working tables and all the speakers to bear into account the participation and the presence of women and something else, and this is for you. Now, that part of women, CISS, where we were talking about inequality of women who live with HIV, is not a key population, but nonetheless it should be key population. We necessarily women, we are more than half of the world, and we are not key population. We are not taken into account at any strategy, none from UNAIDS, regional world in Mexico. I guess that they need to start by listening our voice, or we are going to make ourselves listen at any space where we have the opportunity to raise our voice. As we close the streets, I was a co-founder of people affected by AIDS and prepared to have this availability to treatment. If it's necessary to close streets and to throw ourselves on the streets, we'll do so. We will take the strategies necessary because there are some assassination of women because of gender-wise, women who disappear. And the figures, they say 16. Come on, this is, what about, this is a black hole or this is something like a big hole in the ground? What about these women who disappear? We are talking about gender violence. So I guess that, please, Luisa, I know that you're sensitive for this agenda. Let her know, because this, I'm trying to provoke, take into account cis women as part of key population in the world. That's it. Thank you so much.
Muchísimas gracias, Georgina.
Thank you very much, Georgina. I think that the main intent to generate these spaces is just to provide the voice to people who are in charge and who are facing directly this problem. Especially, I thank your comment and your intervention. Believe me that all the comments that you just did will be considered and taken into account. I'm sure that I hope that next year we generate the third Congress in collaboration with the IMSS. All what you mentioned will be taken into account. So thank you very much. Is there any other comment or question? None? Okay, well, thank you so much. The participation of our dear Javier Arellano, and a round of applause.
Te llevas muchas cosas de tarea para transmitir.
You will have many things to work, assignment to keep on working, and there are many areas of opportunity still. Civil society might have an impact, a good impact on. Thank you, Javier. To conclude, would you like to add something?
I know that we are just on the time, and I want to be very brief on this. First, we are making an effort with the civil society groups in Mexico. There was a hiring project to review a study of how important it is, the participation of communities, and the motto of these years in UNAIDS comes back to the same spot. We definitely need to, as the motto says, societies and institutions united to reach the goals, but we definitely need the civil organization groups. With respect to women, yes, it is true. Even though only 14% of the women represent new infections in the last decade, 11 countries in Latin America report that 25% of the effects are delayed in women, and they access more slowly to the treatment, to the ARV treatment, and besides that, they come to the health services later. That is, they are, it takes longer time for them to show a viral load that can be detectable. We have a project that is called Soy Clave, or I'm a Key, where it has this feminist regard, where there are a group of regional women contributing to the same goal. But I agree with you in this sense, in this effort. And finally, I want to acknowledge and thank the Inter-American Conference of Social Security and you, Álvaro Velarca, and other colleagues from IMSS for this invitation, and celebrate that this effort can be seen. I think that the most important thing here is to keep on talking. We are still way far from our achieving the goals. this is more visible in the world. The response to HIV is very important. The message in the region of Latin America and the Caribbean has not ended, as many people think. It's the opposite. We have many challenges before us, just as I said before, and I hope that this ends soon. Thank you so much, Javier. Among the participants in the forum, we have the Secretary General. He sends his greetings. I have his regards. I have a notice before we end. By tomorrow, the participation registration will happen at 8.